Good morning, everyone. Today I am continuing with the day 2 of lecture series. Our speaker of the day is Dr. Prachi Goyal. Dr. Prachi, you can start with the lecture. Thank you.
Thank you, Dr. Ashish. A very good morning to all. As per one of the theme of this conference today, I would like to discuss smile designing, and it really do wonders. What's an attractive smile? Why are some smiles better and younger looking than others? Why are some smiles radiantly beautiful while others are an average? While you may know a nice smile when you see it, and it's harder to explain exactly what makes a nice smile. Here comes the difference between a lay person and a dentist. जब एक lay person कहता है कि देखने में तो बहुत सुंदर चेहरा है, दांत भी सफ़ेद हैं, सीधे हैं, पर वो बात नहीं है. तो वो बात क्या missing है? It's our dentist, which we should know. Thank you very much. There is both science and art for creating and restoring attractive smiles. Whether it is whitening of teeth, fixing crooked teeth with instant orthodontics, replacing unattractive dark fillings, or restoring an aged worn-out smile, modern dentistry can quickly and easily give you the perfect smile that exudes confidence and will let your true personality shine. And when followed, you can enjoy a radiant smile with all the confidence, natural attraction, and peace of mind that goes with it. It is important to analyze the characteristics of the smile, to think about how the dentition relates to the facial tissue dynamically as well as statically. For the diagnosis of a smile, we can clinically evaluate in the OPD when the patient is just sitting right in front of us, or with the extraoral photographs in the time of treatment planning. There are different types of smiles that has been categorized. There are styles of smiles, like first a Mona Lisa smile. That's a simple smile which is characterized by the action of zygomaticus major muscle, drawing the outer commissures. It's not working. Drawing the outer commissures outwards and upwards, followed by a gradual elevation of the upper lip. Whereas the cuspid of commissure smile, नहीं on है, ऐसे काम कर रहा है, स्क्रीन पे नहीं कर रहा. अच्छा. Whereas in the commissure smile, it is characterized by the action of all the elevators of the upper lip, raising it like a window shade to expose the teeth and gingival scaffold just above the interdental gingiva. And it is a complex smile with full dental smile characterized by the action of the elevators of upper lip and depressors of lower lip, acting simultaneously, raising the upper lip like a window shade and lower lip like a window. We also characterized smile in two forms, that is posed smile and a spontaneous smile. Posed smile is a smile which you can reproduce very easily. Whenever someone asks you to smile, you give a posed smile. For instance, the smile when you are introduced to a new colleague is different from the smile when your team has just won a perfect game. That's an emotional smile that's drawn. That is called spontaneous smile, corner to corner, all 32 out. For the examination of this smile, the facial and dental appearance has to be examined in 3 categories: macro aesthetics, mini aesthetics, and micro aesthetics. I'm not going in detail with the macro aesthetics because we are concerned with the smile designing, but macro aesthetics involves the whole evaluation of the facial form, the proportion of the face, horizontally as well as vertically. For the horizontal evaluation, we draw vertical line, like 5 vertical lines, which has to be 1/5, every section should be 1/5. If it is there, then it is called horizontally proportioned. And if for the vertical proportion, we draw 3 horizontal lines from the forehead and the base of the nose and the chin. And if all the 3 segments are 1/3, then it is called vertically proportioned. And if we don't find any problem in the vertical and horizontal proportion of the face, then we go forward to examine the mini aesthetics, which concerns the smile analysis. For mini aesthetics, smile arc, lip line are evaluated, midline of the dentition, transverse cant, incisors, and gummy smile display. For smile arc, actually smile arc is a hypothetical curve that passes through the incisor margins of the maxillary incisors and canines, making an arch. This arch has to follow the upper border of the lower lip while smiling. And if it's not following, then it is called a non-consonant smile or a negative smile. Or if it followed, that is a positive smile and consonant smile. And a flattened smile arc is less attractive and it tends to make you look older. Data states that the most important factor in smile aesthetics, since the one by itself can change the rating of a smile from acceptable to unaesthetic. Here comes the lip line. The lip line defines the aesthetic zone and frame the smile when you smile. The amount of tooth exposure depends on the lip line. Like in this case, the upper lip curvature goes upwards while you smile. The corners of the mouth are going upwards. In this, the corner on the one plane, that is a straight smile. And here, while the smiling, the corner of the lips are going downwards. That's why it's called downward. To compare the lip length, if it is a normal or short, we draw a baseline, a horizontal line on the base of the nose and draw vertical perpendiculars to the commissures of the lips and the mid-philtrum. If all the 3 lines are equal, then it's a normal lip length. If the middle one is shorter, then the lip length is small. For the midline evaluation, first we evaluate the midline of the maxilla with the forehead or the facial form. Like from glabella, we draw a perpendicular towards the philtrum and the maxillary incisors. If it's coinciding, then we can evaluate the midline of the mandibular incisors with the maxilla. And if the maxillary midline was not coinciding, then we can evaluate the mandible with the forehead as well. Here comes the occlusal cant. When we can determine this occlusal plane in 3 directions, which have been explained as pitch, roll, and yaw. Here you can see a yaw, which has been disturbed. Like this horizontal line is there, the vertical deepening is there in the right side, whereas in the left side it's higher. Then it is called the roll, transverse roll of the dentition has been disturbed. And if there is a gummy smile, the maxillary anterior length is more, then it is called the pitch has been increased, like the deepening of the maxilla. And if the dentition of the occlusal plane is in the left or the right direction has been moved, the yaw has been disturbed. Dentists can detect this transverse roll at 1 mm from side to side, whereas a lay person are more forgiving and see it at 2 to 3 mm. But at that point, it has become a big problem. So when you see it, consider it in the treatment planning. Then we come to the microaesthetics. In microaesthetics, we closely look for the teeth proportions and the shade and color, which affect the smile. For the tooth proportion, then first we take the account of negative buccal space. It is this dark space that appears between the jaws when laughing and smiling. It promotes the dental composition by providing contrast. These lateral spaces are due to the difference in the width between the maxillary arch and the breadth of the smile. Like in this, it was the increased negative buccal space which affected the smile appearance. Later on, with the orthodontic treatment, the expansion of the maxillary arch has done and the normal or average value of the negative buccals have achieved and smile has increased its appearance. Whereas in this case, you can see there is no or zero negative buccal space, which gives it as a denture-like smile. If you want to calculate how much negative space should be there? Then it's a formula that percentage is equals to 100 minus arch width into 100 divided by intercommissure distance. Here comes the golden proportion. It's golden because it works magically. And every artist in the designing of a car, house, or and any person who is designing something which has to be appealing or to the eyes should consider into the golden proportion. Is a mathematically constant ratio between the larger and the smaller length, that is 1.618:1. For a smile to be perfect, the upper anterior 6 teeth should follow the golden rule. Because these are the most visible teeth, they should always follow the golden rule, and we can examine it if it is following or not, and consider it in the treatment planning to properly improve our treatment outcome. Like you can see in this diagram, the extraoral face should also be in the golden proportion if you need it to be considered as appealing or appraising profile. Now here you can see the two teeth are aligned in such a way that every tooth, the tooth in the center, if it's showing 1.618, then the adjacent tooth should only 1. And then the tooth next to it should be ratio, as in ratio of 1.618 is to 1. Then only the appealing smile will be there. And also the height and width ratio is there. Like if the height of a tooth is 1, then the width should be of its 80% only. Whenever the basic rule of the smile design and golden proportion are broken, either by nature or of yourself as a dentist, your smile and confidence can be seriously compromised. Now here comes the gummy smile. As I have discussed earlier, the pitch has been increased if the maxillary plane is downward anteriorly, then the gummy smile will be resulted. For this gummy smile, as you can see in this picture, the gummy smile was there, and the clinical crown length was very less. For the treatment of this particular case, we did the lengthening of the clinical crown length so that the lip will raise just up to the interdental gingiva, which is good for your looking smile. And in this case, where the clinical crown length was okay, and we can't change it. So we went because of the thin lips, we went for the Botox for the gummy smile. Now, after the Botox treatment, the lips were thicker and covered the anterior gingiva. In this case, the surgical orthodontics with fixed orthodontics took place because of the anterior lengthening of the maxilla. We did, along with the fixed orthodontics, the maxillary anterior impaction for reducing the gummy smile. Whereas in this case, the patient didn't want the Botox. So we went for, because of the good lip length and movable lip, we went for the incision in the mucogingival fold. And after the incision of the mucogingival fold, we replaced that suture with the help of suture more coronally, so that when the patient smile, from here to here, you can evaluate the difference. The gummy display has been drastically reduced. Now comes the gingival height, shape, and contour. In this, you can see the central incisor has the highest gingival level as a curvature, and the lateral incisor is 1.5 mm lower, whereas the canine gingival margin is at the level of the central incisor. And since in this picture it wasn't happening, so we did after the gingivectomy and marginal gingiva, then the normal cervico-incisor length has been achieved, and the smile has increased drastically appealing. Now in the shape, actually this slide considers the gingival जो हमने modulation कर सकते हैं for gaining a good smile. First we did the contouring. ठीक है कि आपका जो cervico incisor length है teeth का वो normal होना चाहिए. Then only it will be a good smile. The second what we did, because the shape of the contour was not good, so we have to get a good shape. And what are the ideal shape? For the maxillary incisors and canines, it should be elliptical, whereas for the lateral incisor, it should be symmetrical half circle. And what is the zenith? Zenith is the highest point on the gingival contour. And as you should know, in the central incisors as well as canine, the gennate should be distally to the long axis of the tooth. When we draw a long axis of the tooth in the clinical crown, the center, then the gennate is the highest point, should be a little bit distal to the long axis, whereas it is coinciding in the lateral incisor. Now comes to the connectors and embrasures. Connectors includes the contact point and the areas above and below that are so close together as if it's seen as touching. Height is greatest between the central incisors. If it is 50%, then it will reduce if you go posterior and also shifts apically. And embrasures and black triangles are the short interdental papilla leads to open gingival embrasures above the connector area, arises from loss of gingival tissue due to the age or periodontal problem and post-orthodontic treatment. Now here you should know that all the interdental recession areas are not due to the gingival problem or periodontal problem. We should always evaluate the adjacent papilla. If it at the same height, then we should consider taking an IOP and consider as a bone loss or some periodontal problem is there. But if it is in a particular area, there is gingival recession and showing the dark triangle, that it can be also due to the shifting or less connected area and inclination of the crown or tooth is wrong. That is after orthodontic treatment, if the inclination has not been corrected fully, then it is called, it will leave a black triangle as an embrasure. Tooth shade and color. The color and shade of the teeth with increasing age, and many patients perceive this as a problem. The teeth appear lighter and brighter at a younger age and darker and fuller as aging progresses. A normal progression of shade change from midline to posteriorly is an important contribution to an attractive and natural appearing smiles. Either with going with the composite restorations or aesthetic veneering, we should always consider this, ki the color or shade we choose should be lighter in the anteriors and darker towards the posterior. It is important to recognize any restorations which need to be corrected or changed because of the age. If the tooth composite restoration has changed its color with the time, and you should change it. And due to the formation of secondary dentinous pulp chamber, this decrease in size, the pulp chamber, because of the thinning of the facial enamel, it results in translucency and darker underlying dentine show, which should always be considered while treating a patient and according to his age. Now, if we conclude this, in the 8 major components which should always be considered during smile evaluation are the lip line, smile arc, which has to be always in line with the upper border of the lower lip during smiling, upper lip curvature, lateral negative space should be average, not more, not less, smile symmetry should be there, occlusal frontal plane, dental components like inclination and size of the teeth, gingival components with their contour, their placement, and their position of the gennate. Now, as the recent advances, the smile densizing softwares are there. And you, as a new dentist, should always know what are the different softwares where you can easily, if you put your photographs, the patient's photographs, and can evaluate what are the changes need to be done to get a perfect and better smile. Starting with the use of photographs and more recently with the use of straightforward and accessible software photographs, virtual or digital smile design has been used to analyze patient's smile and design 2D or 3D images to provide a guide for planning and communication. Since every patient in your OPD would like to visualize different treatment outcomes which you are suggesting on their smile and their appearance before committing to any procedure, these smile design softwares are quick and easy to use simulation softwares. They generate a natural smile simulations right in the first consult or even over virtual consultation with the platforms. Using simple photos, they can give you a better outcome results. This goes a long way in patient motivation and decision-making time, eventually leading to a greater case acceptance. What are the features of these softwares? First, it is realistic nature simulations, facially driven planning using photos as well as scans, smart interface using artificial intelligence, instant smile simulations, lab communication module with CAD/CAM overlay, 3D designs for mock-ups, temps, and injectable composite gang can also be taken. These are few best smile design softwares that every dental practitioner should know. And the top, the first number, the dental treatment simulation is very much used nowadays. The Planmaker Romex's Smile Designer Pro 3D Shape Smile Design ExoCAD Smile Creator. Here, as you put the external photographs and you can draw your virtual lines. Here, after drawing the smile arc, we come to know that lengthening of the crown has to be there, and their gingival contouring is needed to achieve a better smile. And tooth proportions can also be calculated. Just you have to draw the mesial and distal lines along the tooth, and they will calculate for you. Here, when we draw the curvature over the upper border of the lower lip for getting a positive smile is there or not, then we get to know that lengthening of the central incisor over less. So if we do the lengthening, we can achieve a better profile and better smile. Since dentistry has evolved from a curative to a creative science in a very short span of time, smile designing is a dental procedure in aesthetic dentistry which artistically creates straighter and beautiful natural-looking smile that is holistic and does not compromise with function. Many people assume that there is nothing that can be done to improve their smile. But on the contrary, working out on some key facial muscles and mini micro aesthetics of teeth can do wonders. Thank you. हाँ. That the contouring in the central incisor should be elliptical, whereas in the central it should be semicircular. तो हमें क्योंकि आइडल पता है तो हम उसको इवैल्यूएट कर सकते हैं कि हमें इसमें क्या करने की ज़रूरत है. और क्लिनिकल क्राउन लेंथ जो एवरेज में होना चाहिए, जब हम पूरे आज का क्लिनिकल क्राउन लेते हैं उसका जो एवरेज निकलता है, देन वी कम टू, बिकॉज एवरी पेशेंट इज नॉट स्माइल. You know SX appliance ना? अच्छा, SX appliance is a clear appliance, ठीक है. वो क्या करते हैं, मॉकअप सर्जरी करते हैं ऑन अ कास्ट, ठीक है. पर जब वो मॉकअप सर्जरी कर लेते हैं एंड वी अडैप्ट मेकिंग अ SX appliance, क्लियर प्लास्टिक जो प्लेट होती है. नहीं, that by us. Lab technicians doesn't know anything. What we ask them to do, they only do this. Okay, we should not rely on them. तो वी शुड नॉट रिलाई ऑन देम. तो हम जो करके देंगे, हम अगर उसको बता रहे हैं कि यहाँ पे हमें 0.5 mm रिडक्शन चाहिए, ही विल डू दैट. तो हम इसलिए एसएक्स अप्लायंस बना रहे हैं, या फिर हम उसको मॉकअप सर्जरी करके दे वहाँ पे मार्किंग, वो एसएक्स अप्लायंस बना दे, या हम अपनी क्लिनिक्स में भी बना सकते हैं स्मॉल. No, not so much. Even we can get it online and we can pay for like subscription करते हैं Netflix का, just like that. Yes, and it's very easy actually. We just have to draw a line कि हाँ ये है हमारे पास, and it will calculate everything for you. You have to do this much of reduction over there, you have to do this much of construction over there, and this much of planing, and the cant is there, how much cant deflection is there, you get to know right away. Thank you so much. Any other queries? Thank you.
Thank you, ma'am, for the informative lecture.
This laptop only will be used next, no? This is my, yes, okay, so I'll keep it here.
The next speaker of the day is Dr. Sudhanshu Agrawal, sir. He is professor in Perio Department, Chandra Dental College, and he is the member of ISP as well. He has published various articles on international and national level, and along with that various books in perio, and the topic that he is going to cover today is P4 and O4 Medicine Roadmap in Precision Periodontics. We welcome you, sir. Pointer is there, sir, but one second. It is.
Good morning to all. First of all, very warm regards from my CynoDent college. Thank you. मिल जाएगा क्या? दे दीजिए. Actually आगे से खड़े हो बोलना है. Hello. First of all, very warm regards from my CynoDent college, and on behalf of the city of Lucknow, I welcome you all who are basically from outside of Lucknow to the city of Nawabs. And myself, Dr. Sudhanshu Agrawal from CynoDent college. I am professor in Periodontology department. My topic of today's my presentation is P4 and O4 medicine, a roadmap towards precision periodontics. Ladies and gentlemen, please don't confuse with P4 and O4 with tetraphosphorus or tetraoxygen molecule. It's basically precision, P for precision and O for overt. Okay? We will discuss it later on. Thank you. Now, being a periodontist, first sign of inflammation in early diagnosis, or you can say early stage of gingivitis, it is pink in the sink. First sign of inflammation when you need a dentist or a periodontist. But gingivitis is a reversible condition, as you know. When it turns into the periodontitis, which is an irreversible condition, which is now, according to the global disease survey, it is the 11th most prevalent condition in this world, whole world. And rate is near about to 20 to 50%. And in India, not in India, which is developing country, if you see the US, it is more than 47%. The prevalence rate of periodontitis in USA, it's more than 47%. So it is a silent disease. Chronic periodontitis or gingivitis periodontitis, it is a silent disease, or you can say it's a silent killer. Affects everyone and is contagious. Why have used term contagious? If you see the World War II, anak, which is the most prevalent condition at that time, when the mass of the soldiers are kept in a cage, the anak used to transmit. It is a transmissible condition, okay? It is a multifactorial, multispectrum, affects various organs of the body, like we see in the chapter of periodontal medicine. It can be hereditary, like aggressive periodontitis. It can leads to the loosening of your teeth. And one basic etiologic factor, that is the plaque, which is a dysbiotic biofilm, 3 into 10 to power 11 bacteria, which is in your mouth. So it can compromise this with your mastication, your aesthetics, your self-confidence, your quality of life. And it is the major cause of the tooth loss. So finally, it shortens your life. A plaque to the life shortening. Now, as we see in the conventional diagnostic procedures, we have probing depth, clinical attachment loss, mobility, radiographic parameters. Now the thing has changed. We have come to the 5D or 7D imaging techniques now. Now, this is basically a classification system. You can say spectrum of condition or the trajectory of the disease, stage 1, stage 2, stage 3, stage 4. You can say gingivitis is turning into the periodontitis. Now, why I have put in this slide here, one size fits all, very important term. In the early stages, what we see, only used to the phase 1 periodontal therapy, we give the antibiotics, we put it on the oral hygiene measures or mouthwashes. So one size fits all. But now the things have changed. Now the things are come at the subclinical or biomarker level, which I will discuss later on. Now coming to the P4 medicine. P4 medicine is coined by Leroy Hood and is future of the medicine. The concept is basically now changing from reactive to proactive clinical approach. Now what is P4? 4 pillars of precision. One is the precise, more effective and efficient. Preventive, early intervention, ideally before the disease onset, personalized, targeted, and individualized. If you are doing a survey, if you are doing a procedure, it is limited to the 1% n is equal to 1 and towards all of the society, n is equal to infinite. Then participatory, like in the camps and other procedures also. So if we see the phases of this P4 level, all of the factors we consider, the intrinsic factors, extrinsic factors, lifestyle interventions, medical interventions, patient education, and then understanding the cause of the disease factor. Now coming to the O4 medicine. Now, if you are healthy, you have to prove yourself by the various blood markers. But sometimes in the school when we used to go, ma'am, aaj humne homework nahi kiya. So ma'am what say? Sir, okay, bring some medical certificate. Okay. So if you are not healthy, then also prove yourself. This is basically part of what we teach in the oral over medicine. That is over testing, over diagnosis, over treatment, and overcharging. Some doctors used to do for just sake of the minting money, over testing, over diagnosis, or confirmatory diagnosis in sabke naam pe, but these things are not good in the gesture. Okay, if sometime you have a problem, you can go for further testing also. Now coming to the precision periodontics. What is precision periodontics? It can be defined as the combination of clinical parameters and biological markers enabling highly reliable prediction of the periodontal disease, susceptibility, early diagnosis, prognosis, and planning for the safe and most effective or precise treatment. What is precision periodontics? Where are we? New technologies are coming up. Driving forces are biomarkers. Now advanced omics method like metabolics. This is basically an ecosystem. This is basically an ecosystem where we see all the things are related with each other. Some risk factors, some predictive factors, socioeconomic status, medical history, treatment, and all the things are related with health and the disease of the patient. How do we stage or monitor the prevalence of the disease? Sampling approach. For being a periodontist, we take the sample from the plaque, we take the sample from the saliva, from the blood. Then monitoring is metabolics, and then community metabolic function, metatranscriptomics, surrogate markers are core susceptibility. This is basically, you can see in the supragingival area, we have saliva, blood, we have plaque, and in the subgingival area, we can go for the area of metabolics, transcriptomics, epigenetics, extra, at the genetic level also. Now, what are the advances in diagnostics? Assessment of the gingival inflammation, assessment in the radiographic diagnosis, assessment in microbial analysis, in immunodiagnostic techniques, advances in the biomarkers. And we have also chairside diagnostic kits also. What are the limitations of the conventional diagnostic procedures? Clinical and radiographic measurements was not good totally. Full mouth recording being in the MDS was not done clearly. Individual susceptibility to periodontics varies both genetically and over the time was not calibrated. All clinical diagnostic techniques provided information, but past disease activity was unreliable. So, benefits of this precision medicines over conventional diagnostic techniques. That was our aim. Customized disease prevention strategies, prescribe more effective drugs, avoid prescribing drugs with predictable negative side effects, reduce the time, cost, and failure of clinical trials, eliminate the trial and effective insufficient or inept health care, shift the emphasis to medicine, predict susceptibility to disease, improve disease detection. Now, coming to the biomarkers. Biomarkers in periodontology. How many types of biomarkers are predictive, which calibrate the prevention of the disease, diagnostic markers, the disease onset, prognostic markers, which assessment of the disease progression, and diagnostic and surrogate endpoints that eliminate the patient compliance with the administrative treatment. Reason of the lack of the diagnostic biomarkers in the periodontics basically, high interstudy variability, small sample size, inappropriate study designs, need clinical strategy and data processing, variability in specimen collection, variability in analytical methods, interpretation and data processing. Now coming to the O4, the good, the bad, the ugly. As I have said early, this was done by some dentists or you can say some doctors for just sake of the minting money. So this may be not good procedure. See, all things I have done in one slide. This is the summary: overdiagnosis, over-detection, over-definition, over visualization, over treatment. These are various stages where sometimes a doctor used to prescribe the medicines, do the diagnostic procedures, do all things what he want, but sometimes it is not very good thing for the patient. And also see, all the things are interrelated. Patients are also not very feeling good. Technology is also improving day by day. Media persons are also calibrating silent killers like general trends, new is better than the old. This is the most common line which used to by the doctors, that this good one is better than the old one. Then industry is flourishing. Professionalism is lack of professionalism basically. So if we see the population is screening, if we have negative, then no action is taken. Like in this corona period, if we have got any positive result, then if we have getted the positive result, you can go for the benefit. If we do the overdiagnosis, overtreatment, only the patient will harm. So this is the good, the bad, and the ugly. Now, causes of overdiagnosis can be summarized as follows: screening and increasing sensitivity, incidental findings, widening of diagnostic criteria, confusion makes the risk of the disease, physicians' fear of missing the disease, and financial interceptives, insufficient knowledge of the disease. These are the basic reasons when we go for the overdiagnosis, but sometimes it cannot be good for the patient. So, what are the special qualities should be possessed by any physician? That excellent doctor-patient relationship. Patient should rely or should keep in touch always with the doctor and should have a faith in his doctor. A well-founded wait-and-see approach. Yes, we will give this medicine. If it फायदा होगा तो ठीक है, नहीं तो we will change it. Open communication between the patient and doctor, and understanding the importance of patient education, whether he can afford or not, whether ये आपको फायदा करेगी कि नहीं करेगी. Okay. Now we will see that its whole industry, medical or something else, is a broad spectrum or interrelated with all the things. So it's a multi-sector approach, engaging the clinician acumen, advances in integration of the system biology associated with the technological advances. Now, being a periodontist, what I rule used to follow is treat to target. Suppose you have a plaque, you have an oral hygiene problem, you have a gingivitis, then go for treatment. Do with the phase 1 therapy, prescribe some antibiotics, go for the oral hygiene procedure and all. But if the problems is not solving 3 to 4, like in the Medin's classification, what we will see, if the patient is not solving the problem, go for the further diagnostic procedures. Then what we see, if we have structural loss or functional impairment, loss of the bone patterns, loss of the gingiva or clinical attachment level, then we go for the advanced diagnostic procedures. If the inflammation or infection is not subsiding, go for the advanced drug system. Then a patient should be informed for the target and proper treatment should be given. Now, present, past and future of the medicine. In the early stages, we used to depend on the clinical trials. But in this future, we are following with the precision medicine. See, a chart is given, I have given here, like in the traditional approach, if we see the symptoms, like in the COVID period, we treat all of the persons with the same medicines. So some have got benefited, some have no effect, some have adverse effect. One size fits for all. But in now, these days, we classify the risk factors, then we do the surveillance or preclinical disease, then we treat with the different drugs. So we classify the patient according to their needs and their depending on the problems. So prospect of the precision medicine improved by large-scale biological database, patient characterization, health technology, computer tools, and large data sets. Now, creation of the, at last I conclude, creation of the medical treatment is unique for the particular patients. So a difference can make a difference. First, you have to be a good doctor, you have to be a good diagnostician to diagnose the disease, then you can further start with the treatment. Don't go for over treatment, over diagnosis, overcharging of the money, so that the patient will not turn up again or maybe not very faithful to you. Thank you.
Thank you, sir, for covering this important topic of dentistry.
Laptop. Oops.
So now I would like to invite the next speaker of the day, and she is Dr. Kriti Bua ma'am. Dr. Kirti is an assistant professor at Bharati Vidyapeeth Dental College and Hospital, Navi Mumbai. She has an overall experience of almost 7 years. She is PhD in the subject of oral pathology and microbiology. She is working effectively in research lab for almost 5 years and has received many grants, patents and copyrights regarding AI and healthcare. She has more than 12 publications to her credit and other as well. It's a pleasure to have you here with us, ma'am, and I would like to invite ma'am to come on stage and start with her lecture. Please give a round of applause for ma'am.
Okay, thank you so much, Dr. Anam. It was very helpful. Thank you so much for this. Okay, first of all, I'll start with my lecture, just congratulating ISRO scientists for Chandrayaan-2. It is a remarkable milestone for us. As a proud nation, we can say that we are leading ahead in technology. While speaking about technology, I feel very fascinating about whatever artificial intelligence is coming these days forward. So, these AI related technology, how it is integrating in the diagnostic procedure is very important to understand for the new millennials and Gen Zs, right? I am Dr. Kirti Bua and I am here to discuss human eye error and how do we overcome with this human eye error in diagnosis. So, first of all, this is my workplace. This is my beautiful colleagues and seniors, and these are my supporting system, my students. So, my key points will be introduction, histopathological diagnosis, different diagnostic aids, AI in oral cancer benefits, worries regarding AI, and a future sneak peek. Okay, there is a spoiler. I would like to tell you all. Within these 20 minutes, I am not going to ask you all to understand about oral squamous cell carcinoma. I won't ask you all to understand about epithelial dysplastic features or anything related to the patterns of AI. I do just want to germinate some thought with respect to the artificial intelligence and how we can use it in healthcare system, that too specifically in dentistry. So, what all are the challenges? Why even there is need to check about oral squamous cell carcinoma diagnosis? From many years we are doing diagnosis, it is not something very new which we are doing. So, what are the challenges? First of all, oral squamous cell carcinoma, we all agree that this is a dreadful disease, right? This is a malignancy which is most common in the all tumors. This is the 7th most common worldwide, and almost 4 out of 1 lakh are affected by oral squamous cell carcinoma. But what's most funny is, if we see one example of oral pre-malignant disorders, clinically it could be red, it could be white, it could be ulceroproliferative, it could be verrucous, it could be any these forms, right? But histopathologically, there are array of diagnoses. It could be hyperkeratosis, it could be just hyperplasia, it could be just mild, moderate, severe, or well, moderate and poorly differentiated oral squamous cell carcinoma. So, with example I would like to tell you all, these are dysplastic features, all of us all have learned this. These are the pictures of these dysplastic features. Can you just have a glance to these pictures? What can we see? I would say that, okay, fine, with this particular, okay. So, with this particular image, I can see that, okay, something over here, hyperpigmented cells, some mitotic figures, I can see something here. But I would say that as per WHO titer, I can say that I feel it is moderately differentiated, or I can say that I feel it is mild. If I go with the classification, mild dysplasia is something which is below 1/3 of the epithelium, moderate is above 1/3, and severe is above 2/3, right? But one of my students, she might say that it is severe dysplasia. Some of other oral pathologists may say it is just a mild dysplasia. So, here the question comes of subjectivity. So, most of the clinicians who all are my friends and do send me the tissue samples, they always say that if I am sending these tissues to institution, they are giving diagnosis of mild dysplasia, while you are giving me moderate dysplasia. If I go to somebody else, they are giving me severe dysplasia. So, what is the point? The point is there is a subjectivity, that is a human eye error, which requires excellent experience, and then only we can rely with that. Okay, can anyone tell me who is she? Who is this beautiful actress? Yes, she is Deepika Padukone. Deepika Padukone performing some romantic scene. She in action, she in very happy mood, she in sad mood, she in angry mood. But who she? She is Deepika. This example particularly I have put up because to make you understand, dysplasia will be the same category which can be seen in all clinically diagnosed oral malignant, pre-malignant disorders as well as oral squamous cell carcinoma, because of which the subjectivity enters in this particular field. Squamous cell carcinoma, as earlier I said, it could be mild, it could be well differentiated, it could be moderately differentiated, it could be poorly differentiated. Again, there could be one foci which can be missed, and it could be a basaloid variant. Sometimes it could be adenosquamous variant. Sometimes it could be a fatal variant, that could be a clear cell variant. So, imagine there are 1000 foci. As an oral pathologist, daily I do see not more than 10 cases, but I see 10 cases and 1000 foci. Imagine how much tiresome work it could be, observing 1000 foci. Is it easy? Observing 1000 of cells and telling, okay, these many cells could be malignant, and that is why I am giving the diagnosis of moderately. These many cells are, I feel these are dysplastic features are so many over here. So, that is why I am giving this diagnosis, right. So, this is quite, again, what all are the challenges because of this only, this not only subjectivity, but if you see misinterpretation, right. What happens because of this subjectivity, sometimes there is only an early invasive carcinoma, just few epithelial cells are travelling into the connective tissue, but due to human eye error, the person will neglect that particular thing and might give just carcinoma in situ or some sort of dysplasia. It could be mild, moderate or severe, right. That kind of misinterpretation can be given. Second could be misclassification. Again, I had given the example prior also that I feel it is a mild dysplastic features are seen and it is a mildly differentiated thing, and somebody else might feel it could be moderately, because there is a the WHO classification itself together, it has some limitations. Because of that, the diagnosis is very much challenging in such cases. So, failure to detect a rare variant, as I said, clear cell variant is a fatal variant, and some of the foci, in 1000 foci, there might be one foci which has this multiple bunch of clear cells, but this is fatal. Can I just only give, I can just give the diagnosis as moderately differentiated oral squamous cell carcinoma? I can't give that, because we as a pathologist have been taught that whatever is the fatal thing, you have to give diagnosis about that fatal thing. You just can't say that, okay, I can feel that this is oral squamous cell carcinoma, but which thing I don't know, because based on these diagnoses, surgeon has to excise the tissue and decide the treatment modality for further things for the patient. Now, sampling errors and communication errors, again from clinicians and pathologists, these things are happening. So, again there is a subjectivity in giving diagnosis, right. Then over diagnosis. So, as a human being, we do not want to hurt anyone. As a human being, we do have empathy, sympathy towards the patient. So, always while observing squamous cell carcinoma slide, we do feel that, okay, it could be a severe thing only, I do not want to give moderate because it is going to be a severe only, let the surgeon take the call and excise the tissue. It could happen sometimes if the pathologist who is less experienced is looking after. Because of that fear, because of that sympathy, empathy, the over diagnosis can happen over here. So, unnecessary and repeated biopsy are also taken because of these things. Lack of communication between the team of doctors. So, if you all have learned carcinoma, you have gone through all radical neck dissections and all, your people have learned that in your final year, third year, final years. I guess most of them are undergrad students and interns. So, third year final you have learned all of this. So, you know that there are multiple doctors involved, like many doctors are involved, there are pathologists, there are medicine people, there are multiple subject specialists are there. So, there should be a proper communication. Oral squamous cell carcinoma or any pathology is not related to only pathology and clinician. It is about radiologists, it is about medicine people. We are supposed to work multidisciplinary. We are not supposed to just restrict it to be like, okay fine, this is my subject, this is your subject, right. So, the communication is the key over here. So, that also leads to subjectivity sometimes, right. But what is the worst scenario? This is taken from one of the study. I do agree that patients do come in a very late scenario into the clinic, they delay while coming for follow-ups, they won't come back, and there are some challenges from patient side. But what is the most dangerous thing? Can we realize we have 34% of delay in giving diagnosis? Can we imagine our relatives, our siblings, our own relatives or family members going through such case, and there is delay, 20 days, 25 days for second opinion, third opinion, and the carcinoma is growing like anything. Can we imagine that with our relatives and our family members? No, we can't imagine. So, professional delay is also a big issue in today's era. So, yes, I would like to give few suggestions also here with this particular line, that if there are, we should understand first of all what are our strengths and what are our weaknesses. Clinicians, surgeons or any general dentist, we should understand what are our strengths and weaknesses, and then decide which case to be handled and which case to be referred. Delay in referring to the tertiary hospitals is also a big mistake, I would say. I would not say it is a challenge, I would say it is a mistake. If you understand that that is quite challenging, I can't treat that, send it to the tertiary hospitals. Now, this is just for fun. So, being a pathologist, I have seen many patients, and I feel I love you is not the best statement in English. It is the best statement is, it is benign. It is not malignant, it is benign. Okay. So, yes, with this image I do wanted to tell you, whenever the patient is suffering from oral squamous cell carcinoma or any cancer for that matter, head and neck cancer, not the patient, but the whole family is getting affected. The economical balance, equilibrium, the emotional balance, everything is lost. All family members are affected with this kind of cancer. So, now the hero of the topic is our artificial intelligence as a diagnostic tool in the oral carcinoma or oral squamous cell carcinoma. So, just giving the introduction of artificial intelligence, this is Mr. John McCarthy, who has coined this terminology artificial intelligence in 1956, and later on these legendary people who have worked in health sector and AI. So, what is exactly AI? Artificial intelligence is machine who is imitating human activities, human capacities. Who is this gentleman? Anybody? Can anybody tell me? Anyone from crowd? Yes? So, this guy is Mr. Sam Altman. He is Sam Altman. You people might be knowing about AI, OpenAI, ChatGPT, artificial intelligence, everything. This guy is CEO of OpenAI. So, ChatGPT and everything, I guess most of the people are using ChatGPT these days. He is the person behind that. Why am I telling this? This guy has invested in so many sectors, but 24 out of them are in health sectors. Okay, what it will change for us as a dentist? What is he himself? What he says, that India has a tremendous capacity to change the health sector, health scenario, and advanced technology. You won't believe $14 billion have been invested in specifically in India, and this number is going to be 102.6 by 2028 within 5 years. So, this artificial intelligence altogether, which they are telling from 2000, in 2028 it is going to be super artificial intelligence. Not only artificial intelligence, but super artificial intelligence. So, where all we can use this artificial intelligence regarding health sector and regarding cancers, radiology, artificial intelligence nowadays what they are doing, they are studying multiple scans, MRIs, all other radiographic diagnostic aids. They are going to take the pictures and they are going to use it with the softwares, and they are telling about the what type of cancer it is, how much the cancer size is, how much is the prognostic value of this particular case, everything they are talking only looking at X-rays. Okay. In pathology, same goes. When you take the picture of slide, that particular picture of the slide is getting segregated with the pixel segmentation and various molecular, cellular, textural, the features are getting scanned through the machines, and they are telling, okay fine, this is mild only, because in 100 I guess 60 are normal, 20 are mild, and somewhat 20 are connective tissue. So, they are giving a quantitative data where we were using our intuitions while giving diagnosis, but AI uses the actual number. Quantitative data is segregated in AI related apps. Third is so clinical decision and treatment plan. Whenever we want to treat a patient, again it is a very crucial thing. We want to go for a radial neck dissection, we want to remove all lymph nodes, we want to remove tongue, that all decisions are taken by the oncologist or surgeons, right. So, that time also if some machine or some person is telling, okay, these are the findings and you are supposed to go for this treatment, particular treatment, that will be an advice provided by artificial intelligence. Then prognostic markers and treatment modalities, here the detailed genomic data is studied, and the person, whoever is the patient, that patient's predictive value or prognostic value is also defined by this artificial intelligence. Then coming to the post-op on and future perspectives, drug discovery, this is very interesting topic nowadays, because huge data sets, thousands, lakhs of data sets are getting assessed within few minutes, and they are telling which patient is supposed to take what type of a drug, or what type of a drug can be prescribed to this particular person using this artificial intelligence. So, I will not go in depth because of time constraint, I can't tell everything about artificial intelligence, but I just want to tell you all, nowadays we are using, since 2010 we are using deep machine learning. What do we understand by deep machine learning? First they used to use traditional machine learning, where there was a data which is put up in the machine that used to get segregated, and the machine used to give the output. Now, imagine that was a child, 4-year-old child, and that brain we used to train, like how to work, taking some images, segregating them and giving the output or the result. Now, deep machine learning mimics the adult human brain, and there are neural networks. These neural networks are used as an adult brain. It is giving you the same 86 to 96% of accuracy. So, adult brain is there with you, working anywhere, working in your specialty. So, these are the berries. Why am I putting these berries and all? So, what do you feel if I give you basket of berries and I asked you all to put certain berries in certain compartments? So, in strawberry compartment put strawberry, in blueberry put blueberries. So, I asked you all to segregate. So, your brain watches that, identifies the particular features, the architecture, the color, the texture, everything that will identify, and put that particular berry in some particular segment or particular compartment, right. Why am I giving this? Now, another example I am just going to tell you all, then I will come to the deep machine learning. So, here what do we see? There is a road, left side pictures is actual pictures. These pictures are seen by artificial intelligence. So, there are roads, right. Road is colored purple in this particular right side image, the marks on the road are fluorescent orange here, whereas trees are green and other things are blue. So, if you notice, all vehicles are blue, all pictures, roads are purple, the lines on it are orange. So, this is how machine is going to segregate the things. Pixel segregating is very important. Why we are supposed to understand this? We can use artificial intelligence in many sectors. That is why only using these two pictures, just understand in where all, in dentistry particularly, where all we can use this. So, this is about my subject, the pathology. What AI is doing? It is first going to see what foci is the interest of the person, like which is the most important foci, and then there will be the selection of that, and again there will be count of the cells. Now, coming pictures you might understand this, see this one. Now, blue color cells are malignant, the pink color ones are benign, and certain color pictures are like cells with connective tissue. This kind of counts or quantitative data is given by AI, and it will give you the histogram. So, it is not based on intuitions, it is not just based on human proficiency. So, here is the basic, ruling out part of human eye error is going to happen, right. It is going to give you quantitative data, right. So, these are just applications where all we can use. We are using it in oral pathology, we are using in radio, in fluid biopsy. If we see clinical pictures, if you see this picture, the left down picture, here it is a clinical picture, clinical patient's picture. There also if you see the light is on the clinical side and the AI is just giving this multiple, it is segregating that clinical foci in multiple sectors, like it could be red, it could be white, it could be normal. So, the AI is going to segregate these three compartments, and it will give you the diagnosis whether the soft tissue lesion is leukoplakic, whether it is a erythroplakic, or it is a mixed one, or it is a verrucous, or it is a ulceroproliferative. It is going to help accordingly. Right. In pathology, same, the count of cells, segregation, and telling what is malignant, what is connective tissue, what is benign, and what is something like just a fat cell, a neural cell, or a salivary gland, that is it, right. And this one technology, the fluid biopsy, nowadays they are just taking the blood and finding out the DNA and genomics from that blood. That is again AI based technology. If you could read about it, you will understand it is a very interesting thing these days. So, yes, okay, fine. This hero is always hero. No, it is not. No, the AI is not hero all the time. Artificial intelligence has some limitation like privacy and confidentiality, right. Who will protect the data? Nowadays you have seen there are many hackers with some sort of softwares, other softwares, they are hackers. So, who will take care of data, who will take care of privacy and confidentiality? With this regard, we at Bharati Vidyapeeth are trying to do something, and we have published one paper and we have taken patent for this particular AI and health sector related software which we have developed. And in coming years also at Bharati Vidyapeeth we are working on an app where we can give the better understanding of this oral squamous cell carcinoma. The second drawback is who will take the responsibility, whether it is pathologist, whether it is clinician, whether it is patient himself or herself, who will take the responsibility? When the machine is saying, who will take the responsibility? That is again a big question. So, again I will by just saying this, I would like to tell one thing. In the whole lecture, I do not want to ridicule oral pathologists, or I do not want to ridicule any medical healthcare sectors, because human experience can't be replaced by machines. That is for sure, but what the machine will do, it will be an adjuvant help for the medical professionals for diagnosing the things. Who all can use? Again, researchers who all are working with cancer, they also can use. For second opinions, clinicians can use AI. So, yes, this is useful, but as an adjuvant right now. So, if you ask me who all are working in today's scenario, people do ask me, ma'am, you speak about artificial intelligence a lot, where all they are working actually, who all are they working? So there are almost 10 to 12 companies in AI specifically working in healthcare. You just need to approach them, you just need to go and tell them what is your thought process, you just need to germinate something here that the world is going to change, we are not going to stick to the old things, we have to change, we have to move further, not going only with this 3-tier classification which is coming from generations and generation, we need to move ahead, we have to give something core to the patient as well as the clinicians. So these are few examples. The last one is this company is very near and dear to Bharati Vidyapit because the person radiologist has opened it and he is working over here, and this is a nice onco radio artificial intelligence company. So this is just a sneak peek. Imagine this is working right now, robotic surgeries. So it just makes me feel enthusiastic about this artificial intelligence and these technologies. So yes, as my objective was just to germinate the thought of technology in all of your minds. I don't wanted to tell about the cancer and artificial intelligence in depth, but just to germinate the thought that how many research you can do, how many scoping questions are there, and you have to find out the solutions for them, right? And yes, acknowledgements, first of all, Almighty, BVDU, DCH, NM, and organizing team, of course, my alumni student, Dr. Anmol, who has been very nice to us, then Dr. V. Srinivasan sir, who's principal, my teachers who always guided me, I was not a good student, but they guided me a lot, and my department at BVDU, DCH, NM, and my family, my mother, my brother, and my most supportive hand, my husband, who's sitting over here. So all of them, and these are just references. Thank you so much for the patient learning.
Thank you, ma'am, for the informative lecture. Before moving on to the next speaker, it's time to felicitate the speakers that have already given the lecture. So I would request Dr. Ashish Chandra sir and Dr. Shalu Rai ma'am to please come on stage and felicitate the speakers. We would like to felicitate the first speaker of the day, Dr. Prachi Goyal ma'am. I would request ma'am to please come on stage. Next, I would like to call upon Dr. Sudhanshu Agarwal sir. Thank you, sir and ma'am. Thank you. Our next speaker of the day is Dr. Alok Singh, sir. A brief introduction about sir. He has completed his undergraduation from Yogita Dental College, Ratnagiri. He has completed his post-graduation from Vasant Dada Patil Dental College, Sangli. He is a distinction holder in post-graduation of the esteemed MUHS University examination in the year 2019. He has been awarded as the best case finisher in the International Damon Symposium held in the year 2019. He is a member of World Federation of Orthodontics, and in addition to all this, he has a fellowship in the field of aligners, surgical and lingual orthodontics. Dr. Alok is currently working as an assistant professor in Bharatiya Vidyapeeth Dental College and Hospital, Navi Mumbai. And he has many research publications in various national and international journals as well as patents in the field of orthodontics. I would like to request sir to please come on stage and start with his lecture.
Hello everyone. Hope you are doing good. Good morning everybody. So myself Dr. Alok Singh, and currently I am working as assistant professor in Department of Orthodontics and Dentofacial Orthopedics in the Navi Mumbai campus of Bharatiya Vidyapeeth. This is my department along with the post graduation. It is a PG department of 5 units where we are mentoring and guiding the postgraduate students as well. This is my brief CV. And this is my small clinic in the heart of the Navi Mumbai. Which is specialized only for the aligner and surgical kind of patients. Let us now talk about the recent technology which is booming day by day, coming in everyone's mind. What is artificial intelligence and how it is working and how it is converting our generation to generation and how it is implied in the orthodontia. Everyone nowadays telling that aligner is blooming nowadays and it is replacing the orthodontia by using the artificial intelligence. I am totally disagreeing this fact because artificial intelligence can be an important aid or a diagnostic tool in diagnosis and treatment planning, but it cannot replace the orthodontia. Why and how I can tell you. Let us take an example of a patient came to your clinic at the age of 25 years and he was a class 3 tendency of patient. He get concerned from a single orthodontist and he told that this case is a severe case and we have to do the surgical treatment planning. Okay, fine, fair enough. After listening this surgical treatment planning, patients wants to take the another opinion for the another orthodontist. So he went to the other orthodontist. The other orthodontist told, I can do this case with the clear aligner. Okay. Now the patient is getting confused. After listening this, the patient is more worried and went to the third orthodontist. The third orthodontist said, I can do this treatment with the braces, but I will opt for extraction of premolars. Now the patient is confused between three orthodontists. Okay. The person like me would go for more orthodontists, and he was also like me, he went to the fourth orthodontist. The fourth orthodontist said, although your case is critical, but it can be treated, and I am going with the third orthodontist opinion, which can do your treatment by extraction of the premolar, but the only thing is that I am going to extract your 8, the wisdom tooth. Now the patient is more confused. Now what to do? Whether I should take the treatment or whether should I go with which path? So now here, by seeing the facial form, head form, facial features, the rest of the diagnostic tool, he can take the use of artificial intelligence and can reach to the diagnosis, or any orthodontist can reach to the diagnosis which is better and fair plan. But the treatment protocol is maintained and managed by the orthodontist only. So you can see here how the diagnosis is taken care by the artificial intelligence. But the treatment planning and the way of doing the treatment, the protocol of the treatment is not managed by the AI. It is just managed by your skilled orthodontist, right? So it is a non-human identity. First we have to understand that, and as we all know that AI is classified into two things, machine learning and systematic AI. So in machine learning AI, we have two kinds of AI, supervised and unsupervised. In supervised AI, you are going to tell what are the things and what are the things that should be incorporated in that. The data, the treatment planning, like for let us take an example of diagnosis, class 1, class 2, mild crowding, spacing, severe case of class 3, and all the features that is going to do by your human brain, which is incorporated in the AI, and then AI is going to give you the results. This is how the AI works. This is how the machine learning works. Okay. So basically it is a data feed by the human brains only. I am going to show you many cases, not many cases I can say because of the constraint of the time. I will show you very few good cases in which you can see how the AI plays a role. So as you can see, it is non-biological entity as I told you. Okay. So AI is just a tool for assistant to the orthodontist to arrive or to reach to the diagnosis and treatment plan. As I told you, as I have given you an example, like if that patient was having a crowding, then you can take whether it is mild crowding, moderate crowding or severe crowding. Now these all things you have fed into your AI system, and now the AI is going to tell you which treatment plan you can opt. If it is severe, you can go for the proclination, IPR, you can do the extraction, you can do the distalization, and you can do the premolar extraction as well. So the orthodontia, this is a basic history of orthodontias from where we have started and now where we have reached. HD Kessling was started in 1945, then Nahom, Ponce, McNamara and Sheridan. This is as you all aware about the Invisalign system. This is a office of Invisalign system. Now they have treated the billion of cases with the aligners. Now they are using the generation 8 aligners, which is the currently trend and currently used thermoplastic material by them. A smart track material, what they are using is generation 8 kind of aligner. This is how the Invisalign technology has evolved from a smart track to the smart force, and now they are delivering it to the smart stage technology, what we are using. So whenever a patient came to you, to your clinic, first of all, you have to, either you can take the impression or you can do the scanning of the patient. Then you have to prepare the plaster model, or you can send that impression to the lab company. Now the in-house aligner trends are going on. You can do the printing at your own office, okay. Then you can form, with the help of 3D printer, you can form the stereolithographic models on which you can fabricate the aligners. This is how it works, okay. You can see we have done the intraoral scanning, then we can proceed ahead with the 3D manufacturing, and now after that you can get the stereolithographic models. These are the stereolithographic models which are used for the record purpose as well as in the diagnosis and treatment planning in orthodontia. So if there is any new patient consultation, first take the records and for the diagnosis and treatment planning. Then we have to do the clean check for the patient. That is a software. I am going to explain you how it works. Then you have to do the clean aligner adjustment appointments, then additional aligner records, insertion of the additional aligners, adjustment appointments, post-treatment records and retention. So definitive diagnosis and treatment plan are made, and what are your treatment objective based on your scanning, okay. So this is how we used to do the scanning with the iTero or the 3-shape. First we have to 3D imagination, it gives from all the views, okay. Then you have to replicate the stereolithographic models on this. Now depending on this scenario, the scanning, you can decide whether the case is of crowding, whether the case is of expansion, whether the case is of some other kind of malocclusion, and based on that you can plan your treatment plan, whether it is mild type of crowding, moderate kind of crowding or severe kind of crowding. After that you can decide the treatment plan, or you can explain to your patient. Similarly, if the problem is in vertical relationship, whether it is deep bite or open bite kind of problem, you can go ahead, whether it is open bite, whether we need to extrude the tooth, which kind of extrusion, anterior extrusion or posterior extrusion, okay, with the help of TADs, without the help of TADs, that everything you have to plan. And in this doing all this formulation of your treatment plan, AI can help you, but it is not going to tell you where to place the implant so that you can achieve the maximum intrusion, because there is a limit of palate, there is extension of palate, then and certain amount is there, only you can do the intrusion. It is not like you can intrude the whole palate or whole maxillary segment. Similarly, if the problem is in transverse direction, you have to first diagnose whether it is a skeletal problem or it is a dental problem. So these are the different kinds of problem that you have to tackle after taking the digital scanning. After doing the digital scanning, you have to do the treatment planning, or you have to categorize which kind of case is this. After that, you have done all your diagnosis. Now how to proceed with the aligners? So first you have to fill the prescription form, which is available on the Invisalign site. Okay. After that, aligner company generate a software plan. A virtual setup plan is going to provided by the Invisalign. Okay. Nowadays they have created an app. In that you can show then and there only the patient that this is how your face is and this is how after the treatment. This is currently for the motivation of the patient. Like if the facial form is like this, so after doing the scanning, a few seconds later you can see your face is like this. Okay, this is how the AI helps. in motivation of the patient, in generating the approximation of the facial structure. Okay. Now, orthodontist review the plan. Once you are going to, they are going to generate the software plan, the orthodontist review the plan. This is an important step. This is not done by the AI. You have to assess what is the root angulation, what is the facial form, okay, what is the tip, what is the torque, everything, what is the teeth position, whether they are maintaining the molar relationship or not, whether the canine relationship or not, okay, whether the incisal relationship, whether after doing the treatment this retention protocol is going to be followed by or not. So, all these things are you have to evaluate, the orthodontist should evaluate, and then they are going to change the plan according to them, and if it is fine they can proceed ahead. Okay. So, orthodontist approve the corrected treatment plan, and after that they are going to manufacture the aligners on the 3D printing. So, this is a software which is used by the Invisalign or the Align technology. So, in which they are going to decide the sequence of the tooth movement, the final tooth position and the final occlusion. Yeah. Just I will show the cases and wind up. So, this is how we have to do the treatment planning. In aligner we have to do the staging. So, there are different kind of staging like VA staging, A staging, M staging. Okay, according to that you have to decide the tooth movement and how many aligners are desired in this patient. Okay. So, by staging protocol you are going to see it. So, this is how the staging is done, and Invisalign will tell you whether it is mild case, moderate case or severe case. So, whether you are going to require 14 aligners or more than that. So, these are some features of the smart Invisalign they are going to give you. So, review the initial occlusion first, then review the comment on the tab, then review the number of stats, then review the final occlusion, review the superimposition before and after. Okay. This is not working. So, this is the superimposition. Now, we have to finally place the attachments on the aligners. Okay. And this is how you give the precision cut. After doing all these things, your aligner is going to deliver at your office. So, I am going directly to the case report, whether I will show you some interesting cases. Okay. So, first before showing the cases, I will tell you, whenever you are going to get a case, first look at the case from the external features, the facial form, the head form, because all these things are going to affect. Okay. So, this is a one case. This patient seems to be very pleasant profile, but when the patient was smiling, her upper incisors were not displayed. Okay. She seems to be old when she was smiling, and she cannot visit properly to my clinic because she based in Dubai. She only visit 3 months, 4 months time, and she wants to get treatment only with the aligners. Okay. So, whenever you are going to, I see the case, I diagnose the case, it was a skeletal open bite kind of case. I can see here the spacing in the lower arch, okay, and it was totally, you can see a surgical kind of case it was, but the patient was not agree for the case, agree for the surgical treatment. So, I opt for the aligner, she was ready for the aligner. So, I started, I have done the scanning of this patient, and later on I have delivered the aligner, I place the attachments to this patient and do the tray delivery for the duration 2 years, and as we all know that we have to change this aligner tray on 14 days. Nowadays Invisalign is suggesting with the G8 and the smart materials you can change it by 7 or 8 days, and the current studies are also going on that. So, these are the mid treatment photographs. So at the mid-treatment photograph, you have seen that I have till now I have not used any kind of adjunct like mini implant or anything to correct the open bite. This seems to be little bit closer, but it is not still corrected. Okay. So I use the posterior mini implants for the intrusion. I place the buccal implant and I place the palatal implant on both sides, and I use the elastics, and I advise the patient to change the elastics at every day. Okay. After changing this elastic, I see the drastic change. I have intruded the posterior segment. After intrusion of the posterior segment, I see that there is a closure of the open bite. I have taken the anteriors back as well, okay, lower anteriors, so that I can create the jet in that kind of patient. Still the case is ongoing, but now you can appreciate the comparison. I have reached from here to here. You can see the overjet. I have now it is in finishing stage. Remaining 4 or 5 trays are there. You can see the IZC I have placed, okay, and lower spacing also I have closed. I am near about to finish this case. You can appreciate the comparison. Okay. This is another case report which came to me from the Kerala, and this guy wants only aligner. Okay. Although this is a difficult case because it is having a class 3 tendency. If I would like to prefer, I would definitely go for the extraction case, but the patient was not agree or not willing for the extraction too. So I go for the distalization of the lower arch, which is a very rare and done under supervised person. If you are very well versed with the aligner, you can do this case. So I have done the distalization of the whole lower arch. You can see the, so I have, you can see here the crowding, the laterals were inside in the cross bite, okay. You can see the lower arch, it is well toward the class 3 tendency, okay. So I have done the attachments, I have placed the attachments, and I use the retromolar mini implants. I have used the retromolar mini implants and tried to distalize the whole mandible, okay. And I have tried to distalize the whole mandible with the use of the power cuts, okay. Now I have got the ample amount of space in the anteriors, okay. The only motto was that I have to retract the anteriors. Once I am going to retract the anteriors, I can create the overjet, and my class 3 tendency problem is going to resolve, okay. So after that, you can see here I get ample amount of space here because I have done the distalization of the arch. This is known as the sequential distalization of the arch, okay. I cannot put the IZC and distalize the whole arch. It is the aligner is going to distort, okay. There is some mechanism, there is some staging pattern in that, okay. This is known as frog distalization mechanism, okay. So by that frog distalization mechanism, I have taken the 2233 tooth in a sequence and creating the space so that I can get the overjet over here, and you can appreciate here the laterals are getting out, okay. The laterals are aligned clearly at that stage, and you can see the upper arch is get aligned totally, okay. But in the lower arch, I have gained the ample amount of space in the canine region, distal to the canine region, so that I can retract the canine as well, and I can finish the case in the proper ideal overjet and overbite. You can appreciate here the amount of space that I can get for the overjet. Yeah, work nahi kar raha hai. The last case, just 2 minutes. This is the case of extraction. This is a case of supernumerary tooth. You can see there distal to the lateral, there is a tooth due to which the central incisor is get proclined, okay. The proclination is there, the midline shift is there, okay. The midline shift is also there, and in this case I have done nothing. I have just extracted the pec lateral, or you can say the supernumerary teeth, and I have done given the Pontics because he was an MBBS guy, so he wants to maintain his aesthetics, okay. So I have place the attachments, deliver the tray. For picture, I have taken how this was the space, okay. This is the progress of the post extraction. You can see we are nearly about to achieve the midline, okay, and we are near about to closure of the space, and in the post treatment you can see I have clearly achieved the closure of the space. The proclination is got corrected. Okay, proclination is got corrected. I have given the lingual retainer in both the arches, and we have successfully achieved the midline as well. Okay, the patient was happy, and you can see the comparison. This was the pre-treatment. In the mid-treatment, as the extraction space was clearly visible, and in the post-treatment, you can see the smile aesthetic. I have get the smile aesthetic very pleasant. So from here to here, we have achieved just by delivering with the aligner. In this case, I have not used any kind of adjuncts. Okay, only by just following the aligner protocol. But yeah, I have tell the aligner company that how much is the tip, how much is the torque, okay, and how much is the root angulation and everything should be there in my patient, so that I can achieve the better stability after the treatment. So this was the profile after the post treatment of the patient. So do we understand AI better now? So AI is progressively ingrained in orthodontic workflow and driving equations. And as we navigate this transformative era, AI role in orthodontics hold limitless potential. Okay, thank you for listening. I hope you have enjoyed the cases and a better theoretical knowledge about the orthodontia as well. Thank you very much.
So this was Dr. Alok Singh sir, who gave an understanding of artificial intelligence tool for an orthodontist. Thank you once again, sir. Without further ado, I would like to introduce the next speaker of the day, that is Dr. Sanjeev Kumar Salaria sir, Principal, Professor and Head, Department of Periodontology, Kalka Dental College, Meerut, Uttar Pradesh. He is currently in MM University. He has graduated from Government Dental College, Patiala, 1996. He has done his post-graduation from GDC Amritsar in the year 2000. Sir has more than 22 years of clinical experience as academician, both as undergraduate and postgraduate teacher. He has more than 60 publications, both in national and international journals, and many more things to his credit. Along with all this, he is the co-author in textbook of Periodontology and Periodontology revised by Shalu Bhatla, sir. Presently working as Joint Secretary, Indian Society of Periodontology for the year 2022 and 2023. He has been awarded as Outstanding Professional by Uttarakhand State ID Office in 2009. Along with all this, he has many more things to his credit, but we would like to invite sir on stage to start with his lecture. Welcome, sir.
Hello. Okay. Slide. कंप्यूटर क्या तुम्हारा ओपन नहीं हुआ क्या हो गया कॉपी करके कर ले कॉपी कर लो ना यू वांट टू आया था कॉपी कर ले बस अब तो स्लाइड देखेगी आप हाँ इसको बंद करो और निकाल दो पेन ड्राइव से इट इज नॉट कमिंग क्या हो गया तुम्हारा प्रेजेंटेशन अच्छा 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 हो गया it's done. So good morning, hope you all are well. First of all, I extend my gratitude and thanks to CynoDent, KGMC University and KGMC Society of Periodontology for giving me an opportunity to present my topic. A spirit the corp is better than the act of individual. It is nothing more than a teamwork, or you can say an interdisciplinary approach, which is to be considered as one of the best treatment planning and execution if you follow the same. But before we start, क्या हो गया? हिला दो। फिर हिल गया। Yes. Second. So before we start, we should always pray to the Almighty, and these are my gurus, my spiritual guru and my professional guru. So I bow my head to give me the blessings to accomplish the task. So as we all know, when we are dealing our cases as an individual clinician, there are certain limitations at our end, or there are certain flaws, or you can say there are certain dilemmas in the mind, because as an individual clinician, we are not well trained to handle the cases which are multidisciplinary, or you can say specialized cases, or interdisciplinary cases. And most of the time, when we try to become an hero and attempt such an cases by our own level, we are getting into trouble. And these things will happen most of the time. You can observe there are different cases has been reported against the dentists in South India and in other part of the country as well. They will not only spoil your image, but tarnish the image of your clinic, as well as you lost your patients or the clientage. So as an prior, first of all, we should remember when the patient reported to us, patient first is the first ethical principle that we have to follow. That means when the patient reported to you, he always come with the vision that I am supposed to receive the best treatment outcome at the end of expertise handles. But as an individual, sometimes we think so the case is very simple. A simple, you can say a simple radicular cyst cases, the endodontist also himself thinks so it will be resolved by non-endodontic therapies, and they still try to attempt. But most of the time, it is not like that what we are thinking about. Sometimes a very simple case become complex when we are not able to achieve our results by doing the different conventional treatments. So that is the stage where we should always, without any hesitation, without any thinking what patient thinks or doctors is not capable to handle such cases. Very simple case. Every case is different. So we should always encourage interdisciplinary approach, because where the team of doctors, they are working together so that the clinician should get the best clinical outcome and to reach the patient expectation. That should be the priority. Here we are discussing few cases that has been reported to the Department of Periodontology, because if you have maintaining good relationship with your consultants, you definitely get an benefit. Sometime out-of-pocket cases will come to your specialty when you are not, you can say, and specialize in those type of scenarios where the people prefer oral surgeon over a periodontist. But if you have a good reputation and the people will know that you are able to handle such situation very easily, they will refer you the cases. So this is the first case which was referred from the Department of Conservative. From the last 2 months, they are trying to maintain the lesion, which is an periapical cystic lesion, and they try endodontic conventional ways to manage it. All hooks and crooks has been attempted, but still after 2 months, still the discharge is not resolving. And at the last, the patient was disclosed that we are supposed to call in consultant, so that because the cyst is not resolving and we have to take an opinion and the treatment plan accordingly as they advise. One thing always remember, when you are managing the case at your clinic or at your practice or as a consultant, you should describe the patient clearly that if you are trying to attempt such cases, that the priority should be given to the normal conventional way, but we may require an surgical intervention at certain stages if the lesion is not responding, so that the patient mind will be clear that doctor try to save my money, save my time and do it in a conventional way. But if the lesion is not resolved, the patient himself know that it is not functioning. So doctor, why not to call in consultant? So the hesitation that what the patient thinks, so doctor is not capable to handle such things, or you are not specially trained to handle such situations, you can call in consultant. So immediately when the patient reported to the department of OPD, aspiration cytology has been taken, which showed it as an pus discharge with blood mixed solution. And on papilloma's smear formation, they find out there are intermixed inflammatory cells predominance has been observed, which is predominantly neutrophils and lymphocyte, which show the lesion is chronic in nature. So both these findings are suggestive of it may be an true radicular cyst which is not responding at its own way to the conventional therapy. So the patient investigations were carried out and disclosed about what are the things to be done. It should be enucleation followed by the regeneration, because when you enucleate such cyst from a palatal, huge residual defect in the bone has been observed. The people say it will heal automatically. It will heal automatically, but it takes a long time, and still it is not confirmatory that the residual defect has been restored with a normal bone. It might be a combination of the soft and hard tissue, which should not be the ideal structure that should be required at that particular place. So after routine investigations, clavicular incision has been given, and very precisely full thickness flap has been raised from the palatal, and the cystic area was completely visualized first of all, so that we can find out the margins, and using surgical curettes by keeping the scoop end towards you, and we can clear the alveolar bone margins right here, and in toto the cystic enucleation has been done, and the specimen has been sent for evaluation, where they find out there is specific typical pattern of, you can say, variable thickness of cystic lining has been observed with a Cardian pattern, which is a definite sign of radicular cyst. So immediately endodontic therapy has been accomplished, root canal has been done. You can say the huge residual defect has been observed, which has been restored with a combination of 3 type of you can say regenerative material, including PRF, DFDBA and beta tricalcium phosphate. As there is no single graft till date is available to be, say, the gold standard, and most of the people say the autogenous bone graft is a gold standard. I said no, definitely to certain extent, but the rate of resorption of autograft is very fast. It resorbed within few weeks, although it has an osteogenic potential, but it will not retain for a longer time. So we require certain factors that induce the bone, that is PRF. It includes various growth factors. It heals the soft tissue very easily and very rapidly. DFDBA has both the capacity of osteoinductive and osteoconductive, whereas osteoconductive beta tricalcium phosphate has long rate of resorption. So it will maintain the space and slowly induce the osteogenesis, and the bone reduction will take place. Here you can see after 2 weeks or 3 weeks, you can find out here the soft tissue heal appropriately, and the lesion within 3 weeks, it regressed from this huge amount and very well defined margin has been start forming. That means now the process is under healing process, and now it is the part, the Almighty that bless the treatment is to be accomplished. Similar case of swelling with the pain with respect to 2.1 and 2.2 has been reported. We show the pain and swelling since 2 weeks. When they find out the history, that is a girl of 21 years old from a village which has history of trauma 7 years back. But unfortunately, it start paining from the since few weeks. Aspiration cytology has been done, and it was confirmed that it is definitely a radicular cyst. But patient was duly informed, first we have to attempt the root canal. If it discharged through the system, through the canal, definitely it may regress. You can find out here, it is well defined radiolucent lesion between the central and lateral incisor, and it was not aggressive in nature, it is isolated in nature. So, after root canal preparation, find out that the lesion is not regressing even after the conventional endodontic therapy. The GP has been placed before obturation, and it shows the lesion is still independent from the site. That might maybe because the radicular lesion may be induced because of the epithelial cell restrophymolysis, which is normally present within the periodontal ligament space, and they get irritated, might be because of necrotic pulp or might be because of trauma. Immediately, the patient was duly informed that, as we all already know that it is a cystic lesion, so residual bone defect definitely exists. So, we have to prepare our mind and discuss the things in association with the oropathologist and the periodontist or regenerative specialist in reference to the consultant endodontist, that the things will go like this, only then we are able to achieve the good results. Immediately after full thickness flap reflection, as the lesion is extended beyond the mucogingival junction, you can right here find the lesion is approximately 20 mm to 1.5 centimeter in length. And when it is eradicated, you can see a well defined lesion right here, which has been restored by the PRF and DFDB and Austin bone graft. Endodontic therapy has been accomplished before periodontal therapy, so that any remnant which might stimulate the lesion further should be eradicated. Healing will be taking place, but during preparation, what happens? As the mucosa is very thin and we are supposed to eradicate the cystic lesion in toto. Pranam sir. So, slight perforation in the mucosal tissue taken place, but we secure that site. But unfortunately, when the initial healing will taken place and huge defect has been eradicated, the swelling might increase and it might tear the lesion. That happened in that particular case at 2 weeks. You can find out right here, post-operative, the mucosal fenestration is visible. Immediately, the patient was disclosed, we have nothing to do with it, don't worry. We are simply giving an incision, vertical lacing incision, do the scoring and place an PRF material so that it should be easily closed. So, after vertical lacing incision, the closure has been achieved and the PRF has been placed. You can see at 3 months and at 9 months, the lesion totally eradicate and it should be visualized that remnant is not still visible. And the patient is highly pleased with the outcome. That is the ultimate goal of the therapy. The next case is of recurrent gingival reactive lesion that has been reported. The local clinician has resected the lesion twice or thrice in the last 2 years, but it will reoccur again and again. It is not because we are not mastering that, we should evaluate which type of lesion it is and what is the prevalence of rate of reoccurrence and how best we can eradicate. Most of the time, if I ask you what you people are doing right there, we are simply say we are excising the lesion and leave it as such. But you know, when such lesion reported to the clinic and the clinician resect it, what happened? It will lead to the residual soft tissue defect formation right here. which may further contribute towards the recession, hypersensitivity, difficulty in maintaining the oral hygiene, and it may recede apically and further complicate the periodontal status, and ultimately you may lose the tooth. You may lose the teeth. So, it was discussed the patient that because the lesion is very vast, normally such a huge lesion in the posterior is rarely observed. So, immediately an incisional biopsy has been taken, which suggestive of diffuse lymphocytic scattered stroma has been observed in the connective tissue, whereas atrophic epithelium and dense fibrous connective tissue bundle has been observed, which suggestive of the lesion is of irritational type of factors which stimulate, and it is diagnosed as irritational fibroma. As we are very well aware that if we excise the lesion, it will lead to the soft tissue defect formation, which further complicate the situation. So, we find out the margins of the basal margins of this mushroom type of growth, either it is involving the attached gingiva or not. We find out right here, we cut the head first of all to find out the peripheral extension of that particular lesion, and then as we are very well aware that the attached gingiva is still existing beyond it, so we extended our lesion at least 0.5 to 1 mm away from the marginal and eradicate whole of the site. Here you can find out there are different types of bony irregularity with the granulation tissue and local factors has been observed, that has been thoroughly eliminated, followed by osteoplasty has been done. As we are not able to achieve the primary closure because the lesion is very big, so we do the scoring in the subepithelial periosteal structure and achieve the primary closure ultimately at 12 week, 1 month, 3 months and 9 months. You can see there is no recurrence and the healing was highly pleased. Already published in JSP. If you want to find out, you can find out with the name of residual defect managements. You can find out these articles. The fourth case and the last case is of implant. Nowadays, everyone is very much enthusiastic of putting the implant by learning by the short courses of 1 or 2 days, and they see the cases and start attempting those cases. But most of the implant complications, they are associated with the treatment plan, treatment execution, or maybe an iatrogenic or overconfidence and early jumping into the state. Implant should be done only when you are able to handle the complications, and for that you require a thorough learning, or either you should require to incorporate a consultant implantologist or a periodontist to your clinic. Only then they are able to justify the things for your benefit as for your patient's benefit. The patient has been reported 5 months before when the initial implant has been inserted, but the torque was very less. It is less than 20 because the bone is very fine, and that was a lady of approximately 45-year age with the postmenopausal disorders. And after 5 months, when the patient reported, they placed an abutment and to take an impression. After taking impression, within 2 weeks, they find out an sinus formation right here. When we obtained an history of the history of patient show there was a history of local factors and bleeding on probing initially also, but the in between and with a mild pain during the early 5 months when the implant has been inserted, but the antibiotics and analgesic has been prescribed, the pain vanished, but the bleeding on probing is still existing. But the patient ignored because it is mild in nature, so he ignored it. And he missed quite of the follow-up visits also. But when he reported, after impression they observed that. But there is no direct communication has been observed between the pocket and the sinus area. Might be because the angulation is slightly proclined and the buccal bone, which is the most predominantly having a habit of undergo resorption if you have not maintained the implant to bone distance, that is a jumping gap. Once you cross that jumping gap, definitely it is going to resorb the bone in any aspect which is approaching the implant very closely. So, as there is no direct communication and mild pus discharge is there, we try to eradicate it using diode laser. So that is a diode laser assisted cauterization has been done after thorough irrigation of the lesion and drainage has been established. Within 3 weeks, you can find out there is no sinus formation right here. Clavicular incision has been given. Here you can see the buccal bone is already almost near resorption. The osseous bed has been prepared and a combination of PRF and DFDB has been delivered. Closure has been achieved after 12 weeks, 2 weeks. You can see the healing is highly satisfactory. 3 months, implant is satisfactory with grip, good pleasing appeal by the prosthodontist. It's a nice work done by the prosthodontist, but only when you have a good prosthodontist or lab technician in hand with you. At 1 year, 15 months, that is total 15 months, because 9 month visit patient again missed and it reported at 1.5 year, approximately 1.5 year. But we want to see either, because the margins are very well developed, we want to see what grafting we have done anything else, or it is simply a static material right here. But the patient is not able to afford the CBCT. What other alternative we have in the interior segment? We have done the parallel profile radiography. It is simple, IOP X-ray की तरह ही होता है. आप apparatus लीजिए and interior profile आपने check करना है. You can find out. And here the tin foil has been placed over the attached gingiva from the marginal gingiva till the mucogingival junction. And we find out here, right here, you can see the amount of alveolar bone has been already progressing. And huge amount of alveolar bone defect has been covered thoroughly. And the patient is highly, that is a lady patient also again, highly pleased with the outcome. So, the take home message is always, yesterday dentistry is the act of individual and today's dentistry is the spirit of co-op. Choose wisely in order to deliver the best before you getting into trouble. Hope you understand and follow the same in the coming days. Thank you very much for your patience listening.
Thank you once again, sir, for the informative lecture. So our next speaker of the day is Dr. Shalu Rai ma'am. She is the Principal Government Dental College Agartala. She has almost 26 plus years of teaching experience and she is the Vice President of IAOMR. I would like to invite ma'am on stage to start with her lecture.
Good morning, everyone. The topic for today, what I have selected, is the need of the hour, importance of anatomic landmarks for the placement of implant on CBCT. At the outset, I would like to thank CynoDent and KGMU for giving me this opportunity to share my experience. I'll start my presentation by showing you a 2D image, that is an OPG, which we generally take before the placement of the implant. Here you can see the OPG, and when you're placing an implant, we actually are not able to view much of the quality of the bone here and even the anatomic structure. You can see the floor of the sinus. Sometimes the quality of the bone in the extraction socket is not visible. Here the implant has been placed taking into consideration the OPG itself. But when the the qualitative and the quantitative analysis is done, we come to a conclusion that the height of the implant is an important factor and the success rate is actually dependent on that. So here you can actually see what is the exact dimension. But when we are talking about a 2D, we talk about the distortion, we talk about the magnification, which is an inherent, the demerit of a 2D modality. Sometimes you see that yes, the implant has been placed very beautifully. So we are moving into digital imaging. We have moved from an analog, X-rays to technology into PSP. We have moved into the computerized radiography, and then ultimately we have come to the digital, that is the amorphous digital sensors. And we have now slowly moving into the AI system. So this is the era of digitalization. So I will be concentrating on 3D imaging modality, that is preferably CBCT, where the importance of placement for implant is concerned. So CBCT was first introduced in European market in 1996 by Newtom 9000 and US market in 2001. And it was initially used for angiography in 1982 and then later applied for maxillofacial imaging. So here the CBCT is the most significant technology in maxillofacial imaging, and the difference with CT is that this uses a cone beam shaped source of ionizing radiation. So in detail about the principle is, we'll just skip that because I'll be showing you more of a image. So why do we need 3D? We need 3D because we care for three-dimensional patient with three-dimensional disease and provide three-dimensional treatment. Shouldn't we use this three-dimensional technology for diagnosis and treatment plan? So the principle of CBCT is that you can just take out, from a pack of cards, you can just take out one slice and view the slice in all the three dimensions. This is how it differs from the 2D imaging modality. 2D imaging modality will not give you the buccolingual dimension. It will just give you the image in only 2 dimensions. Whereas in 3D, you will have the slice which is removed and you can view it in all the dimensions, whether it is an axial, coronal, sagittal. So other example, just take out from the, from the loaf of the bread by cutting it into thin slice and then viewing this slice individually. So whenever you are viewing a CBCT, you have to view in cross section when you are talking about implant, and every slice should be detail evaluated. So the scan volume is the field of view which we normally talk about, FOV, or the scan volume is able to cover the primary. It depends on the detector size, shape, the beam projection geometry, and the ability to collimate the beam. So there will be different field of views available, and those machines come from the small field of view to a largest field of view. You have the large field of view which will take care of the maxillofacial skeleton, medium which will give you maxilla and mandible, and then the focus or the restricted view which would be just restricted to the region of interest, that is known as the small field of view. And some machine do have a stitched scans where 2 regions of interest can be stitched together to make a larger field of view. So field of view is actually important to avoid unnecessary exposure to the patient. The clinician should know which field of view should be written with in his prescription so that the unnecessary exposure to the patient is avoided. Take into consideration the ELADA principle. So the need of CBCT in implant is to improve overall success of the implant therapy with possible reduction in surgical and post-operative implant complication. You cannot just jump to the investigation. We have to first see the clinical assessment. You have to clinically evaluate the ridge, see the general health of the patient, occlusal status and parafunctional habits, facial profile, periodontal tissue, and soft tissue. And then think whether, after evaluating everything, then go for the scan. So as you can see, the application of CBCT for implantology, you have around 40% of the cases of CBCT, 40 to 50%. Now with the case of implant, so many people are putting implant. So you have the most of the scans which I have also done generally comes for the implant. And even in research, this thing in the journals, it is clearly written that the CBCT gives you, as far as the the implant is concerned, the CBCT has a maximum scoring as far as the bone height is concerned, the bone width is concerned, anatomy localized, the quality of the bone, the quantity of bone is there, virtual planning can be done, guide fabrication facilities are available, and if you calculate the benefit, risk and cost ratio, it has a higher scaling value. So I have told you about this. Most important is the quality of the bone, the quantity of the bone, and whatever measurements that you are doing on CBCT is precise, that is 1:1. So when you are not, when do you go for CBCT? It is important when if you are getting sufficient information from the 2D, that is from the OPG, then CBCT is not required. When you can locate the inferior alveolar canal, you can locate the floor of the maxillary sinus, you can locate the, you can do the measurement on OPG with some amount of distortion and magnification is there, but then in that case, don't go for CBCT. When you cannot locate those inferior alveolar canal because sometimes you are not able to access those canals, then in that case, and you should go for a CBCT. So as I told you, there is a protocol, the scan protocol, which should be clearly followed when you are writing the prescription for CBCT. Small FOV can be used, better to include the opposing tooth for occlusion, few teeth on either side if planning surgical guide. So as I told you, there are different field of views that are available. Some machine starts with 5x8, some machine starts with 8x8, depending on their their specification, and it goes to about 23x17, which is generally needed for panfacial fractures. So preoperative imaging should reveal. Why do we need? Because we have to see the anatomic structure before we place the implant. It should include most important structures, which are inferior alveolar canal, mental foramen, your anterior looping, your incisive or the nasopalatine foramen, the nasal floor, shape and size of the antrum, including the position of the antrum floor and its relation to the adjacent teeth, and if any presence of underlying disease that would compromise the overall treatment. Any retained teeth, quality of the alveolar crest. Quality means density of the bone, noting the amount of cortical bone present, because we are now putting cortical implants also. Density of the cancellous bone, which will be in a form of gray values, and the trabecular space, whether it's a fine trabeculation, it's a coarse trabeculation. So let's talk about the anatomic structure. Most important is that there is a classification for this, and there are 4 regions which are known as the functional implant zone, which gives you a characteristic of the anatomy, blood supply, pattern of bone resorption, quality of bone, quantity of bone, so that it improves the success rate of the implant. Now we come to the implant zone 1, which is a traumatic zone, and it consists of the premaxilla of the teeth from right to left premolar. Functional, and their resorption is also very different when you talk about the maxillar anterior, when you go to the posterior region, when you talk about the mandibular anterior region. Functional zone 2 is the sinus zone, so you should be aware of any morphological alteration which is seen in the sinus floor, whether it is the floor of the sinus, whether there is pneumatization of the sinus, whether it is mucositis or the sinus polyp or the mucous retention cyst, or you have the posterior superior alveolar artery. So all these anatomic landmarks should be well versed before you place your implant. Zone 3, interforaminal zone, between the right and the left premolar. In this you will have the mental foramen, the anterior looping, any canaculitis, any extra neurovascular bundles, and then you have the zone 4, which is the mandibular posterior zone. So we have all talked about this. We come to the maxillary anterior zone. I'll just show you the pictures here and some of these scans which might pose a challenge to you. You have the challenge might be present as a form of nasopalatine canal or the nasopalatine foramen, and there is always a thumb rule which states whether it is a enlarged nasopalatine canal or it is just the palatine cyst. Then you should be able to see the morphology of bone in this region while placement of your implant. So your nasopalatine canal might differ because of the patient gender, age-related factor, status of the central incisor, and the time span since the tooth loss. So limited CBCT imaging, that is a small field of view, as an additional radiographic method has been proposed to be benefit to determine the dimension and morphology of the canal before the implant surgery. So this is a different type of nasopalatine canal which you should be aware of. So you should not consider this as some form of pathology. You have type A nasopalatine canal, and whenever I'm always giving the dimension of the canal also at the crestal, middle and the apical aspect. You have type B canal, and you have the type see variations. So these are all variations, physiological variation of nasopalatine canal. So this is how the measurement also should be given. And your implant placement will be determined accordingly. This is a foramen which you can see in the canine region. It's a cannulus cynosus, which is present at the canine region. Sometimes it is very small, insignificant for implant placement, but as you know, with sometimes a morphological variation, a larger size will be visible. Its tract, it comes from the infraorbital foramen, and it is generally seen in the canine region. So this is known as cannulus cynosus. So its distance with the teeth is measured here. Sometimes it might be through and through. So in that case, you might think that it is a fracture. Here the implant has been placed, taking into consideration the nasopalatine foramen. Maxillary posterior region, second pragmatic zone. Most important is the septa. Consider the maxillary septa, whether it is a single septa, it is a dividing into two compartments, whether it's a complete septa, whether there are multiple septae. So this is the image where you can see on the axial section, you can see a complete septa. But when you see the cross section, you see the half septa. So as I told you, you're not supposed to see just one section of the scan. You are supposed to evaluate in all the section, whether it's a coronal, sagittal, or the axial section. Presence of the view of the artery, that is the posterior superior alveolar artery. Sometimes it might be very significant, large, whether it is present at the outer cortex, in between, or inner cortex. There is a classification for this also. So these are few of the images that I am showing you. This is a normal variation, which everybody should know before they go for the implant placement. And these are the measurements that is done before any form of surgery. So this is a posterior superior alveolar artery. We come to the mandibular anterior region, the morphology of the bone in the anterior region, the trabecular pattern, and the type of resorption that is seen is different when you compare to the maxillary anterior region. So the challenges that you face is the presence of anterior looping. It is a very important, that is, this is a section of the nerve in front of the mental foramen and just before its ramification to the incisive nerve. And this can be defined as the anterior loop of the inferior alveolar canal, which is not very clearly visible on OPG. So in that case, you should go for a 3D modality. So this generally appears as a double canal when you see in the cross section. Sometimes there is a median lingual bone canal. Buccal foramen might be there, or there might be sometimes a lingual foramen also. So these are all the images that you see are the variations in the mandibular posterior region. The accessory canals, the buccal foramen, and then you have the lingual bony foramen. So you can see the mental foramen there and the inferior alveolar canal, as well as you have the other foramen, the accessory canal present. We come to the mandibular posterior region. The type of bone that is present is also different, can be classified as type 1, type 2, and type 3. So this all depends on the, the classification is based on the thickness of the cortex and the trabecular pattern. Lingual concavity is the major thing that you should consider while planning for an implant osteotomy. It might be a very severe concavity present on the lingual bone, or it could be a mild concavity. Morphology of bone on 2D cannot be determined, and that is why the reason we go for a 3D. Now in that OPG we were not able to see the bony concavity, but on CBCT if you see, there is a lot of bony concavity. This will all determine your implant success and failure. There is a depression in the lingual side. You can see this concavity on all the 3 sections I am showing you. Various canals, presence of thick endosteal thickening of the cortex. So this will help you for the placement of your cortical implant. These are various inferior mandibular nerve. These are various types of the inferior mandibular nerve. Mainly, sometimes I do see a double mandibular foramen also. Bifid mandibular canals are also visible on CBCT, which might be missed out on a 2D imaging. This is a various kind of canals that is there. So overall I would say that it is beneficial for a clinician to opt for CBCT. Keeping into mind your ALADA principle, which differs from your ALARA principle. So you should look for everything as far as all the anatomic structures I've told. So advantage of CBCT in implant dentistry is to evaluate all possible sites and anatomic structures. No superimposition is there. Measurements accurate within about 1 mm. Simulates implant placement with implant planning software, and the dose of the radiation exposure is less than that produced by the CT scanning. You can limit your radiation exposure using the FOV, different types of FOV which is available. It gives you precise information regarding the various maxillofacial pathology, less expensive than your CT scan, and it allows the complete 3D evaluation of an arch in all the 3 dimensions, whether it's coronal, sagittal, axial, as well as in 3D. As I told you, bone height, bone width can be measured, qualitative and quantitative analysis can be done. There are different classification for bone quality. I won't go in detail. It depends on what type of classification that you are following. This all is related to the CT actually, and it all gives you information regarding the cortex and the trabecular pattern, whether it's fine, coarse, and depending upon the thickness, and how the measurement is done, whether it's D1, D2, D3, D4. But when we talk about D1, D2, we are talking about the MISH classification that is relevant to CT. So when you continuously see a scan, you will be able to differentiate the gray values, and this will give you an indication of whether the bone quality is good or bad. This is one of the factors that should be taken into consideration when you're planning an implant, that is a triangle of bone. And your implant placement should be actually said to be within this triangle. So this is how the concept of TOB is formed. There are various other softwares, also a third-party software which are available, where a DCM file can be transferred, and then an in-depth, analysis of the for implant placement can be done, as well as surgical guides can be prepared. Challenges are mainly because of insufficient bone, neurovascular sensory disturbance, and hemorrhage due to injury to the neurovascular bundle because you're encroaching upon the anatomic structures, and damages of the anatomic structures. Perforation of the sinus, canal, perforation of the nasopalatine canal or mandibular canal, perforation of the lingual cortical plate in the posterior mandibular region when you are ignoring the lingual depression or the concavity. Various other factors should also be considered as far as the systemic condition, infection, oral lesions, various habits, smoking habit. So there is a predictor for using what is the success rate of the implant if all these factors are considered, and what is the success rate if something which is missed out. Few of the pictures that I am just showing you for implant failure, encroaching onto the mandibular canal, perforation of the lingual cortical, perforation of the buccal cortical plate, short implant, whether you have this dimension. So there is a guidelines, and there is also the factors that when and where you should refer the cases for CBCT. As I told you, initial examination is important, preoperative site specification is important, post-operative imaging you have to decide. Dosimetry should also be taken into consideration because the radiation plays a very important role. But when you say a typical CBCT scan has half the radiation of full mouth X-ray, we are aware when we compare this dental X-ray with other, radiation hazards, and you see that a CBCT, a smaller field of view, will give you just an exposure of 5 microsievert as compared to a Mumbai, UK return flight of about 150 microsievert. So I would say the illiterate of 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. Thank you very much.
Thank you, ma'am, for the lecture. As we are setting the presentation on the laptop, I would like to introduce our next speaker of the day, Dr. Professor Manish Khatri, sir. A brief introduction about sir. He is a gold medalist graduate from Maulana Azad Institute of Dental Sciences, Delhi, and he has done his masters in periodontics from College of Dental Sciences, Davangere in 2001. Since then, he is actively involved in academics and clinical training programs for undergraduates and postgraduate dental students, and he currently heads the Department of Periodontology, Institute of Dental Studies and Technologies, Modi Nagar, Uttar Pradesh. He is also a member of Board of Studies and Ethical Committee external expert for few deemed universities. He has been the executive member of the Indian Society of Periodontology for 4 terms. Thereafter, he was the vice president of the Indian Society of Periodontology for a few years. He has been the acting president of the Indian Society of Periodontology. There are many more things to sir's credit, but without further ado, I would like to call sir on stage so that we can start with the presentation. Welcome, sir.
दोनों में से कोई दोनों से Thank you so much, Doc, for the nice introduction. I'm thankful to God for keeping us all safe during all those difficult times of COVID. I'm thankful to Team CynoDent, Dr. Anmol, Dr. Ashish, for giving me an opportunity to give a talk here today. So initially I was planning to speak on lasers, but then I thought that lasers has been too much for you as a pre-conference course also, and you would be listening to a lot of lectures on lasers. And then when Ashish sent me this thing, and especially it was recent advances. So last week I was in a lecture of the Indian Society of Periodontology, and there I myself also got to know about a new technique of using something. And then after having 2 sleepless nights, I made this presentation, and I hope you gain something out of that. I'm thankful to my undergraduate college, the Maulana Azhar Institute of Dental Sciences, who inculcated the art and science of dentistry in me and made periodontology so interesting that I landed up in the College of Dental Sciences, Davangere. Dr. Vandana was my guide at that time, and she would remain guide for me forever. I'm thankful to Institute of Dental Studies and Technologies for tolerating me for the last 17 years. I am thankful to all my ex-postgraduate students and the present postgraduate students. They teach me perio, and say frankly, the students, the postgraduates are the ones who teach most of the guides now, because you are into a habit of doing journal clubs and seminars and all, and that is where from we learn a lot. I'm thankful to my family. The above 3 I hate because I was not there. I was busy with my professional commitments, and the lower 3 I adore a lot because I have time for my family. Please do give time to your family, because later on, because my daughter was a small one at that time, now she is pursuing her MBBS, no more with me for the next of the years. ये चल रहा है? Yeah. So the concept I got was, the nature knows the best. We all know that if we play with nature, what happens? If we play with nature, we all know what happened in Himachal and Uttarakhand these days. So if we take the help of the nature and we take it in the healing process of our body, that would be the best response which we can give our body as far as a healing of any defect. Like if I am a periodontist, I would be talking about more of perio defects and the implantology part. And if we are able to take the natural healing process or a natural substance to aid in healing, that would be the best possible way. So with this thought, I am talking about the natural power, the autogenous dentine graft today. Why autologous materials are the gold standards? Because they are not perceived in the body as a foreign body, so there is no foreign body reaction to an autogenous graft. They prove to be more faster for healing. They integrate well with the body. They are less risky. They are free of cost as such, but it typically requires a secondary harvest sites, which leads to the morbidity overall. That is the major disadvantage, because we need a secondary site to harvest the autogenous graft. So what is a graft? What is a bone graft? I'm not going into details of it. The basic concepts about bone grafts are 4. Number 1 is osteoconduction. Number 2 is osteoinduction. Conduction is the graft itself acts as a scaffold over that the new bone is forming. Osteoinduction is it has some certain properties like the BMPs, and it induces the bone cells to come there and form a new bone. Next. And osteogenesis, the graft itself forms the bone. So next. The best possible way is osteogenesis, then osteoinduction, then osteoconduction. Dr. Salaria made my life a bit easy because he told a lot about that slow resorbing and the fast resorbing grafts. If we evaluate the grafts, we evaluate according to the biocompatibility, whether they are compatible, their bioactivity, whether they are conductive, inductive or genesis. Next. So mainly what we are looking is osteogenesis, osteoinduction, osteoconduction, space maintenance, and also what matters is the vascularity where we are placing a graft, the long-term site stability and optimally conversion to a natural laminar bone. If it is conducive and not able to make a natural bone, say years after if we open up that site, that bone graft is still remaining out there. So we don't want that, we want a natural laminar bone to be formed over a long period of time. Next. So what grafts we use are these autografts which are taken from the host itself. The allografts or the homografts, it is a different individual from the same species. Then the xenografts or the heterografts are different species, and the alloplasts, which are the artificial grafts. Next. So these are the grafts. Autogenous bone is considered to be the gold standard. It is osteogenetic. Then the allograft, which Sir was telling, the DFDBAs and the FDBAs. Then the xenograft, mainly ethical concerns because they are taken mostly from the pig and the ox. So there is a lot of ethical concerns to be used in which type of individuals. You have to take quite a lot of consents for these. And the synthetic grafts, which are like nowadays available in the market, ranging from 550 rupees till few thousands of rupees. So you have to be very judgmental in using which type of graft you are using. Next. So the best possible nowadays is an autogenous dentine, which requires just an extracted tooth and a preparation time of say around 8 to 10 minutes, 7 to 8 minutes or 8 to 10 minutes, depending on which type of dentine also you are, because I would be talking about two protocols for that. So which are you talking about? So 7 to 10 minutes max. Next. So this is what we want after a placement of a graft. If there is a bone defect, we place an inductive or a conductive graft material. After say few months, the graft is replaced by woven bone. Again after a few months, the graft is replaced by laminar bone, and later on we want a typical natural bone to be formed after we place a graft. Next. The overall things which we have to remember while placing a graft is the presence of inflammation, the foreign body reaction, the time, the vascularity, the overall health of an individual, and we have to consider the secondary resorption of the graft also. So how the grafts work? On the one side, it is the turnover, what Sir was talking about. It can be either a fast turnover or a slow turnover or a never turnover. And as far as the ability to regenerate the bone is low and high. So I have divided into these 4 quarters. One would be low and fast resorbing, one would be low and slow or never resorbing, one would be high and fast, and one would be high and slow or never. Next. So this is what? Fast resorbing materials, fast resorbing, high regenerative materials will not sustain the site on their own. Fillers, slow resorbing materials, slow resorbing, high regenerative, these are the optimal for most of the conditions. Next. So this is what all these grafts are which we use. The synthetics are fast resorbing, autologous is high potential but fast resorbing, autologous dentine falls in the best possible group, allograft falls in the center, whereas the synthetics and the xenografts, they have a low potential and a slow resorption pattern. Next. So if we evaluate the osteoconduction, induction and all those things, the autologous dentine falls in the best possible group because it is inductive, it is conductive, it maintains the space and it has a slow turnover. Next. If we compare a teeth to a bone, composition wise, BMPs are more as compared to bone, HA is more, collagen is a bit less, water is a bit less. Next. So enamel, if we are taking a tooth as a graft material, so we have to compare each and every component of a tooth to the graft. So enamel is a super xenograft, dentine is supercortical, cementum is supercancellous, pulp and PDL we would be eliminating while using as a graft. Next. So these are what? How we start, the parts we use and what we get later on. Next. So if we evaluate again the graphs, it is slow resorbing. Is it bone? Yes. If we are using it as a ridge augmentation procedure, we can re-enter after 2 to 3 months as compared to other grafts of re-entry of 6 months. Inflammation is very less, secondary resorption is very little, invagination, there is no invagilation, and the amount of bone formation is abundant as compared to the other grafts. Next. So in a 4-step process, we extract the tooth, we clean and dry it, we grind and sort it, clean, rinse, and the autologous dentine graft is ready for use. Next. So the time taken is from 7 to 8 minutes. Mechanical cleansing, after the extraction, the mechanical cleansing and drying takes about 1 minute. Grinding and sorting takes about 1 minute. Cleansing with a dental cleanser takes about 5 minutes. Graft rinsing with a phosphate buffer saline takes about 1 minute, and the graft is ready to be used. Next. So the protocol: clean the debris, clean all the restorations, the amalgam, the GIC, the light cure restorations, and specifically the gatta bacha points. Dry the tooth, dry the tooth, place it in the chamber, grind and sort, extract the graft, apply the dental cleanser, apply the phosphate buffer saline twice, place the graft at the available site wherever you want to place, and the time is there. So a total of somewhere around 8 minutes. Next. So this is what I was talking about, a 2 protocol. One protocol is just use these step 1 and step 3 after we have grounded the tooth, sorted that out, place it in a sterilized container which we get. Then first of all, put this dentine cleanser, which is nothing but sodium hydroxide and ethanol, place it for 5 minutes. Straight away with a sterilized gauze, remove the extra dentine cleanser, put the phosphate buffer solution for 30 seconds twice, once. Again, take out the extra one with a sterilized gauze, put it again for 30 seconds. With this type of protocol in which we are using step 1 and step 3, we get a mineralized dentine graft, usable in most of the situations. But if we want a demineralized dentine graft, we have to apply EDTA also in between for 2 minutes. It would be step 1, 2 and 3, 2 minutes of EDTA. So that's why I was telling 7 to 8 minutes to 10 minutes. So what's the, and with all these things, from a single tooth, we get somewhere around 1 to 2 cc of the graft, which is an abundant amount. Next. So why we need the demineralized graft? Demineralized graft, biologically speaking, it is more active as compared to an undemineralized graft, because the removal of the mineral increases the osteoinductivity by releasing more of BMPs. Conversely, the mechanical properties of this demineralized graft, if we are using the EDTA, it significantly is diminished. Use of EDTA demineralizes approximately just the 30% of the dentine particles. This 30% has a tendency for fast resorption, but it is highly regenerative. So if we see that quarter 1, the fast resorptive but highly regenerative, it is used in delayed cases if we have to use more of delayed placements. And the rest of the 70%, which is the undemineralized graft, it is slow resorbing and continues with its regenerative potential for a long period of time, and it is used in mostly immediate cases. Like if we are extracting, placing a graft, use an unmineralized one. If we want a ridge augmentation procedure, we can go in for demineralized graft. Yes. Next. So this is what a dental cleanser and a PBS rinse is. Dental cleanser is used for 5 minutes, sodium hydroxide ethanol, the phosphate buffersaline. It eliminates the residual dentine cleanser, and it also buffers the graft at a pH of 7.2, which is approximately the pH of the body. Next. So if you see, there is a lots and lots of evidence regarding this. This is as such a video which has got n number of articles and books published on this. Next. Again, an article by Gorado says that the dentine cleanser or EDTA appears to be an effective disinfectant method of tooth particulate prior to use of such particulate as an autologous graft. So a dentine cleanser removes all the bacteria. It makes the graft sterilized. And an article by Santos said that over an 18 months, newly formed bone with an autologous dentine was significantly higher as compared to xenograft, and the residual graft was significantly lower as compared to a xenograft. So over an 18 months, the autologous dentine graft gave you good bone formation with less residual graft remaining. Next. So these are some of the advantages of using an autologous dentine graft. No secondary surgical site is required, X-rayed site healing, predictable bone regeneration can be observed, often does not require a barrier membrane, which gives an additional cost if you are using a membrane, allows re-entry at half the time, excellent osseointegration, long-term dimensional stability, no secondary resorption, low cost, patient loves the concept, it's easy handling and storable for later usage. This is a major advantage. If you have a tooth of a patient, you can store it, use it later after many, many years. If you have made a graft out of it, the graft is abundant, you can dry it, store it with the patient's name, use it later anytime. And provides excellent payouts if charged to medical insurances. Few of the medical insurances are ready to pay for the autologous dentine grafts, but not for any xenografts or alloplasts. Next. So in most of the instances, we mainly dispose of the extracted tooth. So why not take advantage of this, of the fantastic properties these teeth possess? Next. Once we grind it and sort the material, there are two compartments. I would be just showing a video after this. There are two compartments. It's like that chai ki channi. So the upper compartment takes the larger particle size, and the lower compartment goes, and the lower compartment, the smaller particles settle down in the lower compartment. So the lower compartment has got smaller particles which are fast resorbing, great for immediate implant placement, and the larger are great for vertical and horizontal augmentations for doing any GBRs. Next. So if we see the incisor to molar, we can get from 0.75 cc to 2.5 cc by using this autologous dentine. And this autologous dentine is osteoconductive and osteoinductive. Next. The biggest question is whether we want to place a membrane to reduce the cost or not. If we are able to achieve a primary closure, no membrane at all. If we are grafting a socket which has got 4 walls around it, no need of a membrane. For more challenging defects, the best membrane can be PRF or a resorbable or a non-resorbable membrane if needed. If the cases are like a great bone loss is there, I would be showing you one case for that. So in that case, you can use a membrane. Elsewise, a PRF membrane, which is again an autologous, would suffice the purpose. The extracted tooth can be indefinitely stored for the same patient. The excess graft can be dried and indefinitely stored for the same patient, because the mineralized dentine will protect the collagen and the BMPs that are in it for many, many years. Next. The patient will react to this very, very easily, because if we tell the patient that we are using your own tooth, he would be happy to do that. If we say that we are using a graft which would cost you X amount, Y amount, Z amount, he would be quite apprehensive in using, because frankly speaking, if say I'm charging around 30,000 for a flap surgery and say I charge you 45,000 for a bone graft, the patient would not ready to be paying for that. So using an autologous, the patient would be very happy. He would love it. Might be we become their superheroes. It would be easier for us to convince them. It is the best thing for them. Often it will reduce the cost, almost no inflammation and very little pain. Next. Indications, n number of indications: socket preservation, full arch cases, impactions, ridge augmentations, root fractures, periodontal osseous defects, and most importantly in medically compromised patients, where mostly if we don't have any indication for using bone graft in a medically compromised, an autologous graft can always do the purpose. The outcomes are phenomenal: fast healing, excellent bone regeneration, predictable long-term results, no inflammation, excellent soft tissue response with minimum of billing to the patient. Next. So what we cannot do is, we cannot use an endodontic restoration. We can't use other people's teeth. I cannot put my teeth into somebody else or somebody else into my body. And we can't use the grinding chamber across patients. Like we Indians do have a tendency of that jugaad, ki can this grinding chamber be sterilized and reused for another patient? No, you have to throw it away. Next. So the economic value is the price comparison to standard grafts. If we say this 1 cc, 2 cc, 3 cc from 1, 2 or 3 teeth, a 3 cc graft, a good graft 3 cc graft will cost me somewhere around 30 to 40,000. Cost me. So what cost to the patient? Changes. We save on the membranes. Again, the membrane is costing me somewhere around 18 to 22,000. So a 30,000 graft within 18,000 membrane costing to me is somewhere around 50,000. So what charges to the patient? So we save on the membranes. We save due to the predictable outcomes. We increase the clinical revenue, because if we are able to convince more patients, we are increasing our revenue. And if the medical insurances are giving us money, we are again increasing our clinical revenue because of that. Next. So what's the cost as such? A grinding machine, a smart dentine grinder, costs us somewhere around 1.25, which you take it as an investment. And a disposable kit per patient costs us 4,400. So ultimate cost to the patient would be 4,400, because the tooth is his own. In which you get a grinding chamber, you get 2 disinfection, the 1 and 3, and a disposable sterilized dish, mixing dish, in which you can put the graft and put these solutions. And if we want to use an EDTA, it is an additional cost of 400 rupees. Next. So again, the protocols, if we are using a mineralized one, it is a 7 to 8 minute protocols. If it is a demineralized one, it is 9 to 10 minutes protocol. We can use sticky bone out of these this dentine graft, in which you have to put a PRF, might be an LPRF, IPRF or an APRF. A whole tooth storage can be taken for future use, and excess dentine graft storage can be taken for future use. Next. Clinical cases. Before the clinical cases, I would be presenting a video. Iska video hai yaar, play karna. हाँ. Iska next. हाँ. Play. आवाज नहीं चाहिए यार, छोड़. So the grinder is of Comet Bio. This is what the grinder is. These are the chambers which we get, like 150, you get 6 chambers also initially. So you have to place the chamber. Extract the tooth, clean the tooth of all the debris, the restoration, dry it, Put it in the chamber. Set the timer for grinding to 3 seconds. And the timer for sorting to 20 seconds. So it is total of 23 seconds. The above chamber, that is the below chamber. The larger particle size, the smaller particle size. Take it in the mixing dish. Apply the dentine cleanser. This says for 10 minutes. This is an older protocol. The newer protocol says 5 minutes. Sterile gauze to remove the excess. Put PBS saline, again a older protocol said 3 minutes. Now the newer protocol says around 30 to 45 seconds for twice. So you have the graft ready for to be used in the patient. So this is what you get. All products are sterile and can be reordered. Grinding chamber should be discarded. Endodontically treated should not be processed. Rinse the cleanser with PBS is very important. And if you store the graft, not the tooth, if you store the graft, using a PBS later on is essential. So we all know that the clinical facts after extraction there is loss of horizontal and vertical bone. Next, in order to reduce that loss, there are 3 things. One is alveolar ridge preservation with bone graft and membranes, which is in most of the consensus. Either place an immediate tooth graft or do a socket shield technique, which is a good technique, inspiring technique, but technically very sensitive. Next, the next thing is doing bone grafting. Say the above thing, it is the side is not grafted, the horizontal is still, the vertical is still maintained, but the horizontal has shrunken a lot and it's difficult for us to replace a tooth either by implant or any other things. If we graft it, we maintain the vertical and the horizontal defects, and many options are there: synthetic, ceramic, xenografts, human bone origin, autogenic grafts, and autogenic tooth, which is mineralized dentine or demineralized dentine. Next. So this is a case. A disclaimer is I have not used this myself till date because I also I have heard the sessions for quite a number of times now, but I had a first-hand experience a week ago. So all these cases are not mine. Author's name are there, and official permission have been taken from the company. So this is a disclaimer which I am making. So a case 1 in which 3/7, the patient reported with pain. There was a deep intravoni pocket, a deep intravoni defect. Me as a periodontist would be very happy to save this tooth, but somehow the patient was not interested in saving the tooth. The tooth was extracted, dentine graft was made, socket was preserved with it, and in turn the distal defect on relation to 3/6 was also taken care of. Next. So the tooth was extracted, socket, dentine graft was made, socket was filled up with the dentine graft, a primary closure was done, so no membrane was required. This is 2 weeks later. Next. This is the X-ray at the first visit. Next. At 3 years follow-up, a good alveolar ridge preservation with a good amount of bone on the distal aspect of 3/6 also. Next. So another case in which 4/7 and 4/8 were presented with deep pain and mobility. Extraction was done. 4-7 was discarded because there was an endodontic restoration in it. 4-8 was used as a dentine graft. It was cleaned of all the debris. Graft was made. Next. Immediate implants were placed. Again, I don't know why in relation to 4-8 also. Immediate graft was placed, implants were placed, and the gap junctions were filled up with the dentine graft. Next. And this is a 2-year follow-up after grafting of the implants. Next. So another case in which grafting and implant placement was done in the same session. 1-3 and 1-5 were extracted, immediate implants were placed, the jumping distance was covered with the dentine grafts, sutures were done, and the second stages were done later on. Next. Later on, the crowns were delivered to the patient. Next. Another case, another case, 4-7 was deeply involved with the periodontal disease. It was extracted, cleansed, put it in the grinder, dentine graft was made. The socket was filled up with the dentine graft, primary closure was done. After 3 months, once the site was reopened, a good amount of horizontal and vertical bone was there. Implant was placed, later on the implant was loaded. Next. This was a defect in relation to 3-6. In the CBCT, if you can see, there is a large buccal bone defect also. The tooth was extracted, dentine graft was made, the socket was loaded with the graft, sutures were given. Later on, a guided implant surgery was done. Say in May 2020, this case was done with the dentine graft, and July 2020, implant was placed using guided surgery. But as there was a deep bone defect on the buccal aspect, so that dentine graft was not able to make up that buccal, to eradicate that buccal defect. So once the implant was placed, there was need for more grafting at that time. So there was a supra-erupted 1-8 which was extracted, used as a dentine graft again. The graft was made. Next. In this case, a membrane was used. A membrane was placed on the buccal side. Dentine graft from 1-8 was placed. The membrane was covered on the occlusal surface also. Primary closure was done. This was immediately after grafting and placement of membrane. After 3 months, the implant was loaded. If you see the top end of the healing abutment on the premolar side, there is a line which was bone. So this is the capacity of the dentine graft, and later on the second stage was done. Next. A vertical root fracture of 3-4, the tooth was extracted, grafting, after cleansing, the dentine graft was made, it was grafted, sutured, later on it was opened, somehow there was a defect in relation to 3-3 also, which was remaining on the right hand of the lower photograph. Implant was placed, but in this case the graft of the patient was stored by the patient's name, and that graft was only used in this patient again. After placing the implant, the defect in relation to distal of 3-3 was also sealed with the graft, and later on at the second stage surgery, the loading of the implant and the placement of the crown later on. Next. Cystic lesion, a large cystic lesion was present in the anterior mandible. After raising the flap, the cystic lesion was removed. Dentine graft was made from the lower third molar, which was impacted, which was extracted. Dentine graft was made out of it and mixed in the platelet-rich fibrin. Platelet-rich fibrin was made and mixed with the dentine graft. Next. Initially, if you see above, the PRF membrane was placed, the PRF plugs were placed. This was the sticky bone which was made using the dentine grafts, over which again a PRF membrane was placed and primary sutures were given. Next. This is the X-ray after say 1 month. Next. 3 months. Next. And a year. So beautiful healing using all these products. Next. So one page summary is, we should take advantage of the unique properties of the teeth, and we should know how does it help us and what do we see in that. Next. And what these 8 minutes can do is provide us peace of mind that your augmented site will succeed every time in short and long follow-ups, provide you with peace of mind that your implant will maintain stability, always allow you to have implant ready site a lot faster, maintain the site dimensional aspects both horizontally and vertically, patients more inclined to do the procedures and reduce the cost of the graft. Next. Thank you very much, and you can reach me out on my numbers or my email. Thank you so much.
Thank you so much, sir. Now, before we proceed to the next guest lecturer of the day, I would like to call upon Dr. Ashish Chandra sir and Dr. Anmol Bagaria ma'am for the felicitation of our guest speakers. Dr. Pavitra Rastogi sir also, if he is present here, please join sir and ma'am on stage. So the first speaker to be felicitated is Dr. Shalu Rai ma'am. We welcome ma'am on stage, and it's our immense pleasure to have you amongst us today, ma'am. Ma'am has been the PG guide of Dr. Ashish Chandra sir and has guided and helped sir a lot to reach the heights and become the person he is today. Thank you so much, ma'am, for being here amongst us. Thank you, ma'am. Next is Dr. Manish Khatri, sir, who has just finished with his lecture. Dr. Sanjeev Salaria, sir. We welcome you on stage, sir. Sir has also been awarded as Magnificent Periodontist of the Year. Sir wasn't present with us yesterday, so we are giving this award today. Please give a round of applause for Sir. Magnificent Periodontist of the Year, Dr. Sanjeev Kumar Salaria, Sir.
इनका सिर्फ ऑर्गेनाइजिंग का होगा, चेयरपर्सन नहीं देना है, 2 होंगे ऑर्गेनाइजिंग की किनको आलोक सर और कीर्ति.
Thank you, sir, and congratulations, sir. Next speaker is Dr. Alok Singh, sir. Next is Dr. Kirti Bua ma'am. Thank you, sir and ma'am. We'll proceed with the lectures now. We'll proceed with the lectures. So the next speaker of the day is Dr. Chinmay Hazarika, sir. A brief introduction about sir is that he is a general dentist who has been practicing since 2011. He is the CEO of Gentle Dental AI and an advisor for Muskan.ai. As an oral healthcare startup entrepreneur, he is continually working to bring AI, IT, and healthcare together to offer better patient care. Dr. Hazarika also writes for Dental Tribune, South Asia, and the topic that Sir is going to cover today is unveiling the future, elevating dental care using AI, artificial intelligence. I would like Sir to come on stage, to join us on stage and start with the lecture. Please give a round of applause for Sir.
Sir, it is already connected, everything is connected here. You want a collar mic, there is a collar mic, there is a hand mic.
It's fine, I'll just use this one.
Okay, and there is a slide changer.
It's fine, I'll just use the
Okay, okay.
A warm afternoon to everyone. There's this saying by a very famous American actress, playwright, songwriter called Connie Stevens. She is the proponent of the first Hollywood smile that became the norm for all Hollywood stars to put on their teeth and smile widely into the cameras. She said that there is nothing you can wear better, which is more important than your smile. I'll just play a small video for all of you to watch, which will set the tone for what we are going to listen to. Okay. video, audio भी.
In the world of modern healthcare, where precision meets innovation, one field is experiencing a remarkable transformation: dentistry. And at the heart of this revolution is the fusion of artificial intelligence with dental care. AI in dentistry isn't just a leap forward, it's a game changer. Welcome to our AI dental ecosystem, where we've harnessed the power of AI to simplify dentistry and empower individuals, clinics, and dental care organizations. At the core of our vision is an ecosystem that's intuitive, interconnected, and effortlessly simple. Let's break it down. First, our AI-based oral hygiene app. Take a few images, and our AI engine analyzes it, providing personalized recommendations for better oral health and an ability to connect with dentists instantly. Next up, the AI-based radiograph assessment and PMS tool, a complete solution for dental clinics and hospitals. It seamlessly integrates AI into your dental practice, ensuring precise diagnoses on radiographs, smoother operations with PMS, and happier patients in the end. Lastly, the AI-based oral cancer screening app, a vital tool for healthcare professionals and NGOs. It swiftly identifies early signs of oral cancer using AI, potentially saving lives through timely interventions. So, who benefits from this revolutionary ecosystem? Individuals gain control of their oral health. Dental professionals enjoy enhanced precision and efficiency, while healthcare organizations and NGOs empower themselves with early cancer detection. Ready to be part of the future of dentistry? Reach out to us today. Let's reimagine dentistry with
Did anything seem off about the video that you watched? Is there anything off that you noticed? Okay, let me rephrase the question. On a scale of 1 to 10, how much would you rate this video that you just watched? No answers? 6, 7? Okay. What if I told you that this was made by AI? This video, there has been very minimal human involvement in the making of that video, but did it not get the point across effectively? It did, right? So basically, we are here to discuss the scope and the application of AI and machine learning in dentistry in the clinical sense. Okay, so basically, what is AI? AI is a very broad term that's been thrown around. It's becoming a buzzword, even in financial circles. People are investing more and more in companies that are very much which are developing AI. Right now, companies are on the it's a bullish market out there for companies who are investing and developing AI, specifically building businesses around AI, right? So AI is basically, it's like giving computers the power to make things happen and make decisions, right? ML, machine learning, is a subset of AI, which helps train the processes that help computers make decisions, right? It's not a if I give you an example of if I give you an analogy of how things work in the real world, it's like a person like a 5-year-old being taught how to recite nursery rhymes more by rote learning and repetition. So if you have a large data set, you can train the computers to do stuff for you just by prompting them and not actually doing anything to them, right? So that is what AI and ML is all about. So there are two different types of AI that I will want to discuss, and further we will go on to discuss the applications of these two types of AI. One is machine learning, cognitive computing, which is a little bit on the higher end of the spectrum of AI. There is computer vision, which is very much essential in diagnosis. Deep learning, which helps you draw inferences of what your cameras see. Neural network, which Elon Musk is working on. And natural language processing, which helps humans and computers communicate with each other. Then there is this new type of AI, which is all the rage these days, which is called generative AI. Examples are ChatGPT and Midjourney. So how long before AI becomes the norm in how we as human beings function? Just like in today's age, how we cannot function without a smartphone. How long do you think AI replaces the importance of what the smartphones have in your life right now? Any answers, please? How long? Let's say in a scale of 1 year to 10 years, how soon do we think AI is going to take over our lives, the way we function in society? 5 years? Any two more answers I can take? 10 years, a decade. Okay. What if I tell you that our lives are already being governed by AI as we speak? What if I tell you? It's already being done in the medical field. Maybe not as the mainstream in India right now, but there are many use cases of AI in medicine right now. A small example would be how breast cancer is being screened in the US on a large scale as we speak, right? In the automotive industry, we already have companies like Tesla, which have self-driven cars, right? In business, Google Ads is a company that leverages AI capabilities in delivering services to advertisers, right? In cybersecurity, if you use computers a lot, you will know that every now and then your virus library gets updated on its own, right? Don't you think it's a very it's like a preventive it's like a prevention of a cyber attack that could have happened, but because the library is getting updated on a daily basis or maybe a weekly basis, your cyber attacks are always on the down low. E-commerce, those Amazon ads you see that gets prompted to you after you have left the cart as it is a long time ago. That's how AI leverages how you think and how you buy. Job searches. Maybe 10 years ago when you were a newbie in dentistry, when you were looking out for jobs, maybe you put in something, you uploaded a CV of yours, a resume on one of the job portals, and 10 years down the line, you get called on to jobs which fit whatever it is you do in the current timeline, right? So that's because these job portals have already used your data to show you personalized ads and personalized information regarding where you were at that point in life, and it's already working behind the scenes to show you personalized information. You can create new jobs using AI. These days, HR professionals are using ChatGPT to generate job offer letters and such, right? Creating art. You just fit in the prompts regarding what kind of art form or any kind of creatives you want to create for your clients if you are an artist. Companies like Midjourney, they generate art which is very uncanny and very, very unique, and no two prompts can give the same output. So that means it creates unique art only with the prompt of a real human, right? Transforming government. There are rumors that China uses computer vision to detect how human beings behave in crowds so that they can do effective crowd control when there is a big rally or when the Chinese Communist Party has a big Samaro kind of thing. So they use computer vision for crowd control. You can transform how you do governance based on what kind of content is being watched by people, whether this content might go on to incite violence and riots. So it can also help with police work. It can also help with your passport processing. All kinds of things can be done with AI, and it's being done as we speak. Maybe it's not there in the mainstream news if you see, but it's being done, and there are many companies which help governments put controls over the people. There is manufacturing. I'll give you a small example how manufacturing is is being transformed by AI. These days there are tools that help you make crowns inside your clinic with only 2 or 3 touches or clicks. It's also transforming education. The video that you just saw, we can make generative content and relevant content, and it can change the way we can reach the masses in their own vernacular, even if they don't speak English in the American accent that you heard, right? It can be, the machines can be taught to speak in vernacular languages, provided it has got a large subset of words, languages, nuances, and accents, and and dialects that it can be trained on. The current situation in dentistry, I'll talk in terms of how clinicians perceive the dental field as of now. Okay, so it is growing definitely. For example, if you had access to say 100 patients today you'll have access to 500 patients because of technology and because people are becoming more and more aware of their dental needs. But at the same time, it's also becoming very, very competitive. If I had access to 100 patients, we also have, our dentists, the number of dentists have also swollen up by about 5-fold in the last 2-3 years, right? So the field has become so competitive that we may not be able to provide effective dental treatment to all our patients in the same clinic or in the same vicinity. Also, because there is so much to do, so much to learn, and so much to apply, dentists are having to wear multiple hats inside the clinic. You are the person who the patient wants to call to take up an appointment. You are the person who is in charge of managing the finances. You are in charge of the of procuring your dental materials, to take stock of what needs to be done. You are the person who is constantly in touch with the lab. You are the person who is also the primary caregiver inside the clinic. You are the person who hires and fires your employees, right? You're basically running a business inside your clinic, while not being able to focus on what actually needs to be done at your end, which is providing excellent care to your patient, right? Also, patients are becoming more and more tech savvy. There is this term called the Google patient. We make jokes about them, but it's something that we cannot control. So patients are becoming tech savvy. They know what they want, especially aesthetically demanding cases. Patients want to come to you. They want a certain type of smile that they might have seen on their favorite celebrity's mouth. That's what they come to you with. They want that exact. They don't take into consideration whether the parameters will be met, but they want that, and they are demanding. And if you cannot somehow, if you're suboptimal regarding how you are delivering care, they were immediately, switch to a very negative mode, right? As per a study by MIT, it has been seen that dental examination has missed the detection of caries. Mostly because, one, we usually go by what the patient complains about. The first thing that we record when we make a case history about the patient's condition is the chief complaint in the patient's own words. Is that not how we do it? If we do that, that means already our focus is more towards what the patient wants to be treated for. So mostly we know that caries usually are very much subacute. They do not usually cause any discomfort unless it's a deep one, unless the patient complains of sensitivity and food lodgement. Till then, they do not complain about it, which is why our focus is mostly on what the patient complains about. So mostly I have seen patients with root stumps in the posteriors, and that patient is coming to us to get whitening done on their social sixes. That is definitely how you make money, I understand. But is that how care should be given? Is there no priority list of how patients should be treated and what for? So that is how you deliver suboptimal experiences to the patient, right? You go with what the patient wants, but at the end of the day, when a second opinion or third opinion makes it known to the patient that this is what should have been done earlier, they will always go back to blaming the previous dentist. So that is something we can totally avoid if there would have been a way to minimize our bias, right? So as per ADA, suboptimal patient experience results in only 41% retention rate. That means out of 10 patients that come to you, only 4 will come back to you for other work. In general healthcare, AI has one of the top 5 use cases as in applications and indications. So AI caters to the healthcare industry in a very big way. In multiple cases, there have been documented cases in which AI has given better outcome in detecting breast cancer in the US, which is why there has been multiple companies which have come up and monetized AI in the healthcare segment. AI-powered radiography image processing is 32 times faster with an accuracy of around 96%. If this can be somehow be brought to 99% according to HIPAA rules, this technology can also be monetized, which means you will not have to rely on your eyes only to detect whether a periapical radiolucency will warrant treatment, or do you think the prognosis is going to be bad to poor? Okay. AI has also accelerated diagnosis as well as discoverability and marketability of new drugs and treatments. It's obvious because if you have an accelerated diagnosis, it will give you more leeway in order to formulate treatment plans and formulate drugs specific to whatever the diagnosis is being meted out for, right? In the dental segment, detection of caries, decay, and periodontal disease detection, these things are being worked on as we speak. My company is already working on this. I own a very small startup which helps train computer vision and AI to detect caries and periodontal problems, right? So we can also use AI for orthodontic treatment planning. There are softwares which can be trained to show the progress of how malaligned teeth can be brought into alignment. We can use AI for oral cancer detection and treatment planning. And the sooner we diagnose oral cancer, the better is the survivability rate of a patient. It's totally dependent, the patient's survivability is totally dependent on how soon and how early we can diagnose without the need for second opinions, third opinions, and unnecessary spending of time for referrals. If you could find a way to somehow make the diagnosis prompt on the day one, right? We can provide improved patient care and treatment acceptance. It has been seen that patients rely on doctors who rely on machines to deliver your investigative inferences and your treatment planning, right? Which is why patients usually take 2 or 3 opinions before they commit to treatment. So AI has upped the game. It has provided an upgraded process in which the need for second and third opinions can be minimized, and thereby saving much time, much needed time for the patient to recover fast. It also gives diagnostic confidence to the clinician. If I have, in the current scenario, if I have an RVG in the clinic, it makes me tell the patient that this is what needs to be done to your tooth in order for us to save it, right? And also, insurance companies, because finance is a huge issue in India for treatment acceptance, insurance companies usually rely on definitive treatment plans and diagnosis when they have to process any claim. So these numbers you see on the screen are the results of a lot of camps that we have done. So we have seen that when we tell patients to get treatment done, only half of them turn up because they just heard what was being said, but they didn't have access to how we came to that conclusion, right? A lot of restorative treatments went undiagnosed. For example, something that we mistook for a stain turned out to be a caries, an enamel caries. It happened 28% of the times. A lot of periodontal diseases went undiagnosed, okay? Because we went with the traditional clinical method of inducing bleeding on probing. Some of those patients, they didn't bleed, so it was recorded as no periodontal disease found, right? It could be an error from the clinic, from the operator's part also. Maybe they used a blunt instrument, maybe they used an instrument, or maybe they didn't use it correctly. So these are forms of biases that form when you have the human element which is at the topmost part of the pyramid, right? We missed out on a lot of periapical radiolucencies because we relied on only our eyes and our brain, and the eye and brain interface need not be correct 100% of the time, right? So here's the number. We could diagnose we could diagnose periodontal problems about 45% of the times, and periapical radiolucencies 45% of the time, and when we benchmark these numbers against an AI tool, we found that we performed very poorly. Also, the depth of caries is misdiagnosed 40% of the times if you do it the traditional way. We cannot know for sure how deep caries goes. Sometimes if we push the probe or the explorer hard enough, we might get the tactile feedback as reaching hard caries, and that is how the depth of the caries has been known to be determined. If we use bite-wing radiographs, we do not know where the caries, the transition line between healthy dentine and the caries end. There is no demarcation line there. So we have to solely rely on what we see and what our brain thinks is supposed to be the demarcation line between infected dentine and caries. However, when we benchmarked all these numbers using the same data set, using the same audience, using the same sample, we found that the patient's acceptance jumped by about 25% from the previous test that we did. So more patients, 25% more patients. So if we had a data set of 1,000 patients, 250 more patients supposedly wanted to take treatment then and there, because it was made known to them that dental diseases are progressive in nature. They don't stay the same all the time, right? And the improvement in insurance claims and billing, this study was done in the US. It was seen that 18% more money was being reimbursed in terms of claims, and more amount of money was being released for dental treatment. Improvement in operational efficiency increased by about 20% from the doctor's perspective, right? It left him more time to arrange his instruments. It gave, the chair side time of the patient was reduced. There was a 22% increase in the patient's confidence. Okay, you don't have to refer out treatment which you cannot diagnose to your MDS colleagues, right? Because of the confidence in which the machine gave out the inference, which told you that this can be managed then and there. You don't need to refer him out, right? And there was an increase in because of the increase of the acceptance of treatment, there was an increase in the perio and restorative treatment also. Things and problems that went undiagnosed in the first data set, there was an increase in the same amount of, in the same data set of about 20%. This is what happens when you have technology backing your already formed knowledge base. From the patient's perspective, 85% of all patients preferred if their doctors used advanced diagnostic tools and investigative modalities, which is why most doctors, even in Lucknow I have seen, so many doctors are advertising what kind of diagnosis they use. I saw one doctor advertising that he uses RVG he called it digital X-ray of single tooth. That's what he wrote in his clinic. And I'm sure it's working wonders for him. That's how patients know that this doctor is not only relying on his bias for me to take treatment. He also has a non-living entity which has no bias of his own. That machine is also telling that doctor that theek hai, what you are doing is correct, and also I'll give you my idea of what I know. You form your own judgment, and then you start offering treatment to the patient. Also, patients, because they have access to information everywhere on their smartphones, patients will always turn their head when you are taking an X-ray. They'll want you to explain what you saw on the X-ray, and about 74% of them will not understand a word that you said. Even then, the patient will rely on you because you used the technology, right? They will not understand a thing on the X-ray, but they rely on you because you use the machine. So it's a kind of behavior that you must leverage to your advantage. And not just to your advantage, I mean, there's no other way out from what I'm seeing, from what the trend is going towards. So let's unveil how AI, that is how we are leveraging AI and how we are going to redefine how dentistry is going to be in the next 10 years, okay? In clinical dentistry and periodontics, we'll start with that because the Department of Periodontics and Periodontology is doing a great job at helping organize this event. So these are real images that we have used to train our software. What you see is an image analysis of what biological width should look like, right? Our software also helps with AI-enabled caries detection and tooth part segmentations. The image that you see on the bottom right side is of similar X-rays, but you are seeing the view of how the computer sees an X-ray and from how it draws inferences. So those 4 blue colored images that you see, those tiny green dots on the first image among those 4 is the CEJ, cement enamel junction. These all look like the same, look like the same X-ray, but they are not. They are similar X-rays of different patients. What you see on the second image is the enamel part of how you demarcate enamel from dentine and the rest of the tooth. The one directly below it is the bone, so that any kind of odontomes can be eliminated. I mean, the possibility of any odontome can be eliminated. And restorations. Okay? So this is what the computer sees and draws inferences from. If you train the algorithms regarding what all inferences can be put on a compiled report, it will also help you recommend what needs to be done and what needs to be communicated to the patient. This is basically for patient education and awareness. Here patients love if you use technology, but they are not being able to understand what the technology is doing and why. Even they don't understand why we are coming to the doctor because he uses technology. This is why. In operative dentistry, we have made a simple workflow in which, in the first step, we acquire dental images. Then we do a little bit of pre-processing. That means you orient your camera, your device, and then you you have to select the category in which the patient falls under. Okay. Then you adjust for quality. Then after acquiring the image, you send it for processing, which is actually deep learning. Deep learning is an advanced form of machine learning. Okay. So in the processing stage, the computer vision will help determine whatever findings come up. It could be an apical lesion. Is there a bridge there, a crown, an implant? Is there any form of bone loss? Are there any tooth that is missing? How many of them are missing? Is there a root canal done there previously? Is there any form of calculus buildup between the teeth? Okay. Is there any caries detection that the doctor might have missed out in the clinical evaluation? Is there any filling? What is the type of the filling that is there? What kind of restorations are there? Whether an implant placed is already very near to the sinus, or if is there any impacted teeth? Is there any proximity of a placed implant near the inferior alveolar canal? Is there a retained root piece inside? So all these things, the deep learning helps to segregate the machine. I mean, helps to segregate what kind of problems are already there, the clinical presentation, and helps to put out an output in the form of a finding or an insight. So if you can somehow find a way to summarize the report of what's being done at the back end and offer recommendations to the patient as well as the doctor also, that so and so things need to be done, and then you can push this information to your patient management software or hospital management software, and then from there on you can start communicating and engaging the patient to, and incentivize the patient to get treatment promptly done. In oral and maxillofacial use case, we have the oral submucous, your squamous cell carcinoma screening. Okay, we have a pre-malignant lesion diagnosis and screening. We can do histopathological image analysis using only computer vision. We can do treatment planning as well. Okay. These green labels that you see on the right hand side picture are called annotations. These annotations, this is what we use to train the software on. If we, if I am an oral pathologist or an oral and maxillofacial surgeon, if we, or an oral medicine specialist, we train the computer by annotating what we perceive to be the problem. Okay. So these are called annotations. So the hallmarks of oral cancer screening is that we have made it very easy for patients to self-diagnose on a very preliminary level. This is just for screening. It's not supposed to be the definitive diagnosis. This is just a screening a screening model that we have created. It is very easy to use. It's self-intuitive. There is no big learning curve for the patient to learn and then do later. Okay. It can be made multilingual. The instructions that the patient has to follow is very multilingual. About 11 Indian languages have been used in the software. It's multimodal. Not only does it detect cancer, it can also detect and classify your premalignant lesions. Okay. It helps in screening. It helps in the generation of reports easily, so that it will facilitate early diagnosis. Okay. It will at least motivate the patient to seek early treatment. Okay. Then, if you motivate the patient to seek early treatment, the treatment planning can be made as early as possible. And like I told before, the sooner the patient seeks treatment, the higher the survivability of the patient is going to be down the line. So this is a little bit about us, and we are always welcoming younger people, researchers, practitioners, college faculty to come and work with us, NGOs even. If you have your cell phones ready, I would like you to scan this QR code and check us out. We will need your help to make this into a reality and the norm in a couple of years. There has been so much talk about AI. Would you like to experience it firsthand right now? Yes? Say yes. Before that, I'd like to ask you a question. This AI, and I talked about the stock exchanges, I talked about high finances and how people are, wanting to invest more in companies which are leveraging AI. Do you think AI is complex and expensive? Is it complex, very complex? Is it very difficult to understand, difficult to comprehend, difficult to wrap your head around? It is, if you are developing it, right? But if you are a user, it's supposed to be affordable to you. It should come to virtually at no cost to you. It should be accurate. It should be accurate to about 99%. Humans can never be 99% accurate. At best, we can be about 75-80% accurate, right? It should be actionable. The moment AI gives you an inference, it gives you a recommendation, you should be able to promptly act on it. That's how AI should be. That's how beneficial AI should be. I'm not talking about Terminator AI. I'm talking about AI for healthcare. And most importantly, it should be accessible. There should be no monopoly over AI, which is why we want as many stakeholders as we can. Okay? Do you want to check how much how many of you here are clinicians? All of you? Could you kindly check how much AI is going to help you earn more in your clinic? You can just scan the QR code. There's a link to a calculator that we have created. It will help you know for sure how much it's going to help you save and help you earn. And I also like you to share what you find at the end of the calculation. Anything at all? You can just tell me what the IRR is, the last line, the last number that you find that has been sent to you on the email. That will be in the form of a percentage. That's the percentage I want to know. Anyone? 142, which means if you are earning, say, 10 lakhs rupees a year from your clinical practice, you will be earning 1,44,000 rupees. Sorry, 10 lakhs, 14 lakhs. Yes, sorry. 14 lakhs 40,000 rupees the year you start using AI for your practice. Okay. So that's how we use calculations for upgrading our practice. So what I do is, if I buy a scanner this year, how much should I earn the next year? And whether this scanner will help me buy another scanner for another clinic, right? I believe that data acquisition, AI, and treatment plans done using machine learning is going to be the norm in 2 years flat, if I'm not wrong. So this is the mission that we have started this work with. We are on the mission to improve the lives of 1 lakh Indians with our free to use oral hygiene AI engine. Okay. If you want to try this, you please scan this QR code, do a scan, and send us the results later on. This is how we leverage, it's a small demo of how we leverage computer vision for diagnosis of, not a diagnosis, but a preliminary screening of what's going on inside your mouth. The first step to taking action is awareness. If you're not aware about what's inside your mouth, you'll never take action on them. The hallmarks of what you're using right now is that it's self-serving. That means you don't need a third party to help you do it, which means a patient can get this screening done at home, right? It's personalized. That means we are not using any third party data sets. We're using the patient's own findings to give them a visual of what's going on inside their mouth at that point in time. Okay, it's informative. The reporting is very detailed, very colorful, and it's made in a visually appealing manner so that the patient will know that a carious tooth is not the same as a normal tooth, so that they will know that tooth that they keep on brushing and which always stays yellow is not a normal tooth. Okay, it's also engaging. It connects the patient to their dentist so that automatic. And we use automation a lot here. We use automation to keep the doctor as well as the patient engaged with each other. Automated emailers, WhatsApp messages, we keep sending them back and forth so that the patient will always be in touch with the doctor. Out of mind, out of sight. We believe in that. If the patient's doctor is out of his sight. He's not seeing his doctor every time, all the time, all day, 24/7. He's not seeing him, right? So there's a chance that they might have a timeline in which caries tooth has gone for root canal or tooth loss, right? That can be prevented if the engagement between doctor and patient is kept very, very frequent. The benefits and outcomes of AI are several. I'll just wind up by saying, by mentioning 6 of them. It reduces costs and improves quality of dental care, okay? Not just what the patient receives, but primarily what the doctor can provide, right? Artificial intelligence and computer vision for the dental industry is becoming the norm day by day in real time. It's happening. But it's been done by big companies and they keep their proprietary information very close to their heart. They don't share it. I am on a mission to democratize this process and I need your help to do this. AI can help dentists detect pathologies in the imaging. That means one of the other things which might miss your eye because you are very much focused on placing that implant, AI will bring it in front of you. It will tell you that this is what needs to be done. It provides robust data to prescribe better treatment options. It helps patient understand the treatment. The communication lag between dentist and patient can be eliminated. And it also improves compliance and claims processing if insurance companies are involved. Also, a word of caution here. AI can also hallucinate. It can also form biases and form discriminations. Just like how early men, they used to kill off their babies if they didn't look similar to their parents. There's evidence for that, right? Because they used to form biases and discriminate based on how closely they resembled what kind of species they are. There was a time in which Neanderthals and Homo sapiens used to live together, okay? And if the babies didn't resemble the parents, firstly they used to kill off the babies. Just like how any kind of primitive culture develops, AI can also develop similar idiosyncrasies, okay? Because it's very early stage as of now, okay? There are privacy and security concerns. If we do not have enough checkpoints in which to prevent data theft from happening, this can cause problems in the long run, okay? There is lack of transparency and accountability because here we are using the help of a non-living entity. So who becomes accountable here? Also, it's not very clear how machine learning happens at the minutest level. There's no clear method of knowing how the machine learns and why is repetition the benchmark for gaining knowledge. Just like how we keep on repeating and then we make ourselves understand by falling back on what we already know. How that thing works, that's still not clear, but the applications are already here, okay? Then there's the ethical concern of whether machines should tell people what to do, okay? But we're already doing it. We're already being told what to do on a daily basis. We are doing it. So I don't think there should be much problem regarding that. I'll take your questions and answers now. I'll take your questions, I'll answer them now.
If anyone has any query or want to ask sir anything related to the topic, then you are welcome.
I'll just give a very stark closing remark. AI will not replace dentists ever, but dentists who use AI will eventually phase out dentists who don't. And this will happen next year onwards. This will happen, okay? Because this is how we are reimagining how dentistry, clinical dentistry is going to work. Thank you.
Thank you, sir, for the presentation. It's time to invite the next speaker of the day. She is Dr. Pinky Mathur, ma'am. Brief introduction of ma'am. She has done her MDS prosthodontist, making her maxillofacial prosthodontist, implantologist, and honorable secretary of Indian Dental Association of Ajmer branch. She is running the dental department of St. Francis Hospital, Ajmer, along with being a clinic practitioner of a dental clinic in Ajmer. Along with all this, she is a consultant at 13 other clinics in Ajmer. Her achievements are Indian Dental Diva Award 2023, along with outstanding contribution in rural dental health. She has been awarded Nari Shakti Ko Pranam Award and 51 Most Influential Women of Rajasthan 2023. This list will go on along with all the PubMed publication and everything. And I would like to invite ma'am on stage to start with her presentation. And the topic that she is going to cover today is conquering the art and science of porcelain laminate and veneers.
So a very good afternoon to everyone. I know it's been a very taxing session for all. So are we interacting with students behind? Are you all students or faculty? Students, okay. So can I know what grade are you all in? Interns or final year? PGs? Second year. So fine, I know it's been very exhausting. So let's just put our hands up and just thoda brain ko exercise karo so that whatever I speak, it gets absorbed. Come on guys, upar haath rakh ke thoda fresh ho jao. Perfect, perfect, perfect. So I got a very nice introduction here. I'm Dr. Pinky Mathur. Okay, so I'm a maxillofacial prosthodontist. I've done my BDS from Nair Dental College, Mumbai. I did my MDS from Krishna Institute of Medical Sciences, and I did my maxillofacial fellowship from Tata. And currently I'm the head of department at St. Francis Hospital in Ajmer. I'm from Mumbai, got married, got settled in Ajmer. So I have some publications, some patents, and I'm the Rajasthan Ratna for this year. So let's start. So now as we've been talking about everything being like, what are these flowers that you see here? What are these? What are these part of what? Come on guys, let's make it interactive. मैं आप प्रवचन नहीं दे रही हूँ. एक announcement कर दूँ. हाँ sure.
All the delegates whose pre-conference course certificate was pending or they did not take it, you can collect it from the registration desk, stall number 1. Please go and collect your course certificate that was pending. Thank you.
Okay, so what is all these flowers that you see here? Aesthetics, right? I got an amazing answer. Can I hear who said that? Aesthetics? Cool. So basically, nowadays, everything we want is aesthetic. We want everything to look good. Would you like your actresses to have those fluorosis and bad teeth when they smile? No, right? So basically, I'm here to talk about porcelain, laminate and veneers. Everybody knows what porcelain is, everybody knows what laminates are. I'm not going to put any emphasis on that, but the major thing what I'm here to talk about, and I've also got a time constraint from the organizers that I have to complete in 20 minutes. So basically, I'm going to tell you how not to fail in your porcelain laminate veneers, to have something which is long lasting, to have something where the patient says, yaar kya dentist hai, ek baar gaya, dusri baar jana hi nahi pada. Not good for our pockets, right? So let's start. So do you remember, do you know these faces? Everybody knows them, right? Do you know this face too? Right? Do we know this face too? Are you all seeing the transformation in smiles here? No rocket science, but they are just laminates. Initially, these laminates were only for those people who were from the Hollywood or Bollywood industry, and initially they used to put adhesive acrylics and stick those laminates to the teeth, but now it's for everybody. You'll have patients walking up into your practice and saying कि मेरे ये दांत बहुत पीले हैं, मुझे इनको ना white कराना है लेकिन मुझे bleaching नहीं कराना. So here I am to talk about something permanent which all of you all can use. Are you guys with me? Yeah? So let's talk about laminates and veneers. So now what is laminate and what are veneers? First, get the concept right. You have your tooth with say whatever discoloration, and you have a covering on that. That covering is what? Your laminates and veneers, right? It sounds quite easy, but it's a very technical thing, and I'm very sure that after my lecture, you guys are going to be so good at not doing what causes failure. So why am I talking so much about facial aesthetics, dental aesthetics? Why? Why so much aesthetics? Because everybody wants to look good. Everybody wants to look nice. You remember initially we used to have auditoriums where we used to have those wooden chairs. But now look at the paraphernalia now. Plus the biggest example, we have all moved from this to this. Right? So teeth and face make a very, very important aspect of your personalities. Right? So now if you work in bigger cities, like my target, not only with people, but in my clinic, I tie up with these salons. So when you have these bridal females walking in, they can do anything to look good on that big day. So I do porcelain laminate veneers for almost every bride who walks in, even for a cleaning if she has any defect. So porcelain laminate and veneers is the future even in smile designing, because bonded restoration is something which is going to upcome like anything. Like I was just recently speaking at the International Aesthetic Conference, where out of the 25 presentations, 24 people spoke on aesthetics. So let's go ahead. Now when to do it? ये भी जरूरी है कि लैमिनेट विनियर्स कब करना है. ये नहीं कि कॉन्फ्रेंस में एक डॉक्टर पिंकी माथुर आई थी, उसने कहा था सबको उठाओ बिठाओ और लैमिनेट्स चिपकाओ. Not right. So you should know when to do laminates and when to do veneers. Now, as usual, we have so many scientists and researchers who love to classify everything and publish an article. So we have a classification even for the indications of laminates. So if you see here, discolored teeth, of course, you can see here when you have teeth with diastema, mild diastema closures, not very huge ones where ortho needs to be done, but very mild ones, or in some cases you will have where the ortho has come back and the slight black triangles or slight diastemas where you can go in and correct it with your porcelain and laminate and veneers. You have fluorosis. So I don't think Lucknow is a place where you see too many fluorosis cases. Now I practice in a place called Rajasthan where you have a lot of fluoride problems. So we have so many fluoride cases where we put these laminate and veneers. So what do you understand by this till now? What are laminate veneers? Anybody from the crowd? Come on guys, let's make it interactive. Tabhi maza aayega. Anyone? Come on, yaar, volunteer, the lady, the first lady in pink. Pardon? I just love the words you all use, yaar. I just love the words you all use. Aesthetics, aesthetic crown, too good. Half the battle is won. So can I give a good round of applause for you? Great. So now, laminate veneers मैंने बता दिया क्या है, करना है, दांत पे चिपकाना है, अच्छी स्माइल देनी है, मोटा पैसा कमाना है. But this does not mean that you do it on every case. You should also know where not to do it, right? Now, because laminate and veneers are expensive treatment plans, and if they fail, you're going to have the patient holding your neck really tight and giving you calls in the midnight. So basically, you should know when there is severe crowding, when you don't have enamel, you have class 4 defects, don't do laminate and veneers, because I will tell you why enamel being there is so important. By the end of my presentation, you guys are going to be pros with bonding, pros with aesthetics, and you all are going to know that what not has to be done so that your treatment plan is successful. वॉल्यूम देना है ना. So this is what happens when you have a veneer patient walking in. This is what they want from you.
Excuse me, ladies seat है. लिखा भी है.
किधर? हमें तो नहीं दिख रहा है.
लातों के भूत जब काबू ना आए, थोड़ी सी लाइट मारो सच्ची सी, दिखा पत्ती सी कर बात अच्छी सी.
हैप्पीडेंट व्हाइट, दिखा बत्ती सी.
So now you know what your patients want from you when we talk about laminate and veneers. So moving ahead, I'm not here to elaborate composite क्यों करना है, porcelain क्यों करना है. I am a prosthodontist. I love my porcelains. I love my porcelain veneers. I do composite veneers, but mostly I do them for temporaries. Now, of course, all of you all know the properties of composites. It's not a long-lasting thing. So I believe in going for porcelain veneers for strength, for better appearance, and you don't have the patient coming back and saying कि ये तो मेरा पीला पड़ गया and all. So basically, I'm talking about porcelain veneers. So now, khatam ho gaya, we know what veneers are, we know where to put them. Now the main problem with veneers is that you put ceramic which is very thin, and these thin ceramics either will debond, where the patient comes and says, ये तो निकल गया नाखून जो चिपकाया था दांत पे. Second, we also have a big problem of chipping off, because ceramic over here is going to be all by itself. It's going to be an all ceramic restoration, and it's going to be very thin as 0.3 to 0.5. So we need to do something कि हमारा restoration लंबा भी टिके and the patient doesn't come back and we have a successful restoration. So my first tip would be, whenever you start your work, please take your shade first. Don't take the shade after preparation. Don't take your shade in the following appointments. Before you start, take a pre-op photograph and make your shade. My second and the most important tip of the day is going to be in enamel. Now, why is this enamel emphasized so much? Porcelain bonding to the tooth is the ultimate success plan or the ultimate success road when we talk about a successful treatment planning here. So, whenever I see these porcelains chipping off or come out, it really reminds me of this accident. Do you guys remember? This guy actually met with an accident, lost his life in the car which is claimed as the safest car of the world. Right? How many of you all know this guy? Everybody knows him, right? So, moving ahead, let's go to adhesion and bonding. Now, when I talk about adhesion and bonding, now I want all ears here so that this 20 minutes is successful. When you walk out of here, you know, I know what adhesion is, I know what cement to buy, I know what bonding agent to buy, and you'll start treating your cases like a pro. Two things, enamel and dentine are 90% of tooth dentistry. I am not talking about the gums, but the tooth dentistry, the white dentistry depends on these two structures. Now, you need to know one thing, the enamel is a structure which contains more of mineralized content. I'm so sorry, yeah, inorganic or mineralized content. Now, what is inorganic and mineralized? Anybody? बहुत बार सुना है inorganic, mineralized, पढ़ा भी होगा first, second year में. Just simple, हाइड्रोक्सी एपेटाइट बहुत ज़्यादा है, डेंटिन में हाइड्रोक्सी एपेटाइट बहुत कम है और पानी ज़्यादा है. You just need to know two things. right? The first thing, enamel has a lot of inorganic content, a lot of hydroxyapatite, and dentine has water as well as organic content. I'm very sorry, I'm not able to hear you. Absolutely correct. We have proteins, we have a lot of things, we have mucopolysaccharides, we have a lot of things, we even have glucose. I want a very good round of applause for this guy. Please stand up, doctor. Fantastic. What's your name, doctor? Pardon? Rishabh. Very good, Dr. Rishabh. I really like your spirit. So, everything is going to revolve around this. So now, we etch. All of you all know what etching is, right? Fine? So, when we are going to etch the enamel, what are we going to do? We are going to dissolve the inorganic content, the hydroxyapatite. This is your enamel. You add your etchant, it's going to make these tags inside, which you can see here. You can see these resin tags. I don't think the slide is working on this. Can you see these resin tags here? They are going to act like fingers and space where they are going to hold each other, and you are going to have a micro-mechanical retention. Simple as that. Etching इसलिए करते हैं to increase the surface area. So, when you place your resin cement on this etched surface, you are going to have more area for cementation. Now, is it same for dentine and enamel? No. Your main game starts here. Even if you are doing your class 5 defects, if you are doing your class 5 restorations, you should know where to use your phosphoric acid, where not to use your phosphoric acid, and why not to use a phosphoric acid. Now, when your phosphoric acid, that is, when you are going to etch, the 37 phosphoric acid is going to act on your tooth, it is going to dissolve the hydroxyapatite. It is also going to dissolve the hydroxyapatite in the dentine. पहले से ही वहाँ hydroxyapatite बहुत कम है. And where is hydroxyapatite present, you need to know. Now, these are your dentinal tubules here. वीडियो नहीं है एक्चुअली, आपका स्लाइड चेंजर वर्क नहीं कर रहा है. ये जो इस पे है ना, ये पॉइंटर्स नहीं आ रहा इस पे. कैन यू सी द पॉइंटर्स गाइस? Okay, great, thank you. Can you see this? These are dentinal tubules. These are full of water. Okay, the tubule has water here, and apart from this, around the tubules, the structure which you see around the tubules is peritubular. Tubule ke around is peritubular, right? That is made up of your hydroxyapatite. Apart from that, between two tubules, you have intertubular dentine, which is made of collagen fibers. Again, lesser mineral content. Okay? So now, whenever you have you ever got patients who says, filling karaya, uska mein sensitivity hua? Anybody? Have you ever thought kyun hua? It is the culprit. The culprit here is the dentinal tubules. You have to learn to seal the dentinal tubule. If you will seal your dentinal tubule, this fluid movement in and out is not going to cause any sensitivity or pain. Right? So now I am going to teach you how to seal this tubule so that it acts as an adjunctive to your procedure. So whenever you are doing any tooth preparation, you have a smear layer forming on it. So smear layer is nothing, those shavings in layman terms. When you prepare, there is always going to be tooth shavings. और यहाँ पे tubules है, it's going to go and sit in the tubules. Now, if I am going to use phosphoric acid, it is going to remove this entire smear layer from here. Once the smear layer is removed, the fluid inside the dentinal tubule is exposed and the patient comes with sensitivity. Whenever we do a GIC filling, why do we isolate a tooth? कोई भी restoration में isolation क्यों करते हैं? Anyone? Very good. Can I have that brilliant lady? Can I see you? Because I really want to see your faces. Amazing. Too good. A good round of applause for you. To avoid saliva contamination. Of course, because you know, जहाँ fluid होगा वहाँ bonding नहीं होगा. It's going to interfere, right? So similarly, you also have to learn to avoid this fluid from the dentine to come in interaction with your resin cement or your bonding agent. Correct? So that is why you need to seal it. So wo seal kaise hoga? By not removing the smear layer. So when it is enamel, remove the smear layer. It does not have any water content. It does not have too much of other compounds. It is full of hydroxyapatite, a hard body substance. So you can nicely remove the smear layer. When it comes to dentine, you need to seal this area so that the water inside the dental tubule does not cause any post-operative sensitivity to the patient. Are you guys with me? So now, and the second concept, why you don't do phosphoric acid and why do you need little moisture when bonding is needed with the help of when you are in dentine. Now as I told you, dental tubule, area around the dental tubule, the peritubular dentine, and the area between two tubules, this is the intertubular dentine. This is your collagen matrix. Now collagen matrix is suspended in say in another matrix where you need water. You need water for those collagen matrix to be erect or to be in their particular position. If you see here, these collagen matrix are suspended in little bit of water around them. If you use phosphoric acid, it's going to pull out all the water, it's going to make it extremely dry, and you're going to have collapse of these collagen matrix. So jo aapko pehle ye dikh rahe the, these are going to be covered, everything is going to be covered. So you're not going to have any area for bonding left. Correct? So you need little bit of water to maintain this structure of the dentine, to maintain this area around the peritubular dentine. So when you are going to etch dentine surface, you are going to have this structure, and on this your smear layer which is being modified. Okay guys? Are you all with me? Why is the yes so halka? Didn't understand? I'll explain it again. Okay, so now there is a lot of confusion. अब dentine है, कहाँ तक dentine है? We don't know. जहाँ तक enamel है, we don't know. So something came into picture which is called as a primer. Have you all read about the primer in your books? Right? Everybody has. So what, I think second year is here, correct? Second year? Final year? Which class is this? Interns? I'm not going to ask you any questions, don't worry, just tell me what class are you all? PGs, okay. So anybody from endo here? Conservative? Okay. So basically what happens is now the primer is going to come into action because the primer is going to say कि जहाँ से पानी निकालना है वहाँ से निकालूंगा और जहाँ maintain रखना है वहाँ maintain रखूंगा. For example, when you're going to apply the primer, what's going to happen? It's going to, see this matrix is collapsed because it doesn't have any water, it was washed out with phosphoric acid. So now when your primer comes, whatever water is required for the collagen, it's going to absorb it, and whatever extra water is going to be present here is going to be washed out with the help of ethanol present in the primer. So it's going to have dual action. It's going to act as a plasticizer for your collagen, and it's going to also keep it dry so that your hydrophobic resin comes into it. So now this is what you have. You have this resin tag formed here. For example, this is your enamel layer, and here you have your hybrid layer where you have your collagen fiber which is partially etched, which is partially the hydroxyapatite is dissolved, and in this layer is going to be the bonding because the collagen has water content, it is not going to collapse, it's going to be a brief matrix present there. So is the etching for the enamel and dentine is the same? No, I just hear one person. एक ही इंसान को समझ में आया क्या? Who says no? Only 3. Rest say yes. How many say yes? Come on, this side, guys. Tell me, how many of you all say yes? Anybody? Is the etching of the enamel and dentine the same? Perfect, I got the answer now. So now you all know the water content in the dentine is the mischief maker, correct? So when you are going to etch Enamel, you will use perfect, perfect. Now what will you do if you have to etch dentine? वहाँ पे क्या करोगे? So here is the answer in the forward, the next slides. Now, before we go to dentine, let's go to total etch technique. So what happens in total etch technique? You have your generations. So initially, you have your first layer, which is your smear layer. You have your etchant, which has been applied here. It is going to make your tags here, and your resin cement is going to bond to your enamel. Now, when you come to dentine, you are going to believe in modifying the smear layer. So there is no washing out of the smear layer. There is going to be water content here, that is your primer, which is going to help your collagen matrix to be intact, and there's going to be acetone in your primer, which will wash out the extra water, and you have the hybrid layer present here, which will also seal your dentinal tubules. Sealing of the dentinal tubules will prevent this liquid from moving in and out. It will prevent temperature sensitivities, and hence you have no sensitivity, you have longer bonding strengths, you have longer lasting restorations. So, etchant plus primer when it comes to your dentine. Now, instead of doing so much tamjam, there is a new thing which has come, which is called as universal or all-in-one bonding system. Etchant alag nahi karna, primer alag nahi karna. You don't have to do the bonding system or unfilled resin separately. It all is a part of the same thing. Right? So all of y'all have to take back from here, either use the 5th generation where your etchant plus primer is in one bottle, adhesive is in another bottle, or y'all use the universal system. You have so many of them, just click a picture, order any one of them. So next time when you all are ordering a bonding agent, you all should know why you all ordering. ये नहीं कि bonding agent, the dealer tells you, हाँ ये बहुत अच्छा है, 7th generation बहुत अच्छा चल रहा है, और ये डॉक्टर यूज कर रहे हैं, आप यूज कर लो. You should know, if you are an enamel, you want to etch and you want to use an unfilled resin. You should know, if you are in dentine, you are not going to etch, so you need something which has excellent bonding agent, which has a self-induced primer in it. Correct? So next time when you are choosing, you need to know, मैं enamel को etch कर रहा हूँ या enamel को restore कर रहा हूँ, या I am restoring the dentine. So which system would you use then? Total etch, enamel, self etch, dentine. Now there's another thing which is called as the self etch, selective etch technique. What if you are in such a situation where you have the enamel also, you have the dentine also? You can't put the phosphoric acid inside. Do you all have cases where your class 5 keeps coming out all the time? You have so many cases. Why? वहाँ पे क्या problem हो रहा है? आप सब कुछ etch कर रहे हो. That is the reason. So what you're going to do is, on the dentine part, just go ahead and apply your universal bonds. You don't need to etch this area, or even if you need you feel the need of etching, 10 seconds. And if it is, you're in the enamel, you're going to etch this area for at least 30 seconds, 15 to 30 seconds. One thing when you're going to look for, when you're going to buy your next universal bonding agent is, look if there is MDP in it. MDP is like a magic thing, bought by Curare. MDP is something, it's a monomer. If present in your bonding agent, you are going to have successful bonds and restorations, because this MDP monomer bonds with everything on earth. It can even bond to zirconia, right? So use MDP. See if you have MDP in your bonding agents, you are going to have successful restorations. So I am going to look for what in my bonding agents? MDPs, perfect. So these are some of the bonding agents which have MDP in them, available in the market. So now you all know why in enamel? Better will be the longevity of your prosthesis, better will be the bonds, because no water coming in and out. Everybody is clear? So when you are doing a porcelain laminate veneers, you have to be in your enamel. And the worst part is the enamel is very, very thick. You don't know when you are going to chip it off. You don't know when the enamel just comes off and you reach the dentine. But when you prepare for your porcelain veneers, you have to they are just veneering or laminating the outer layer. So here you know how do you take care of that. So you have two techniques here, that how can you be only in the enamel. ये करने से ना दुनिया की कोई भी ताकत, कोई भी चीज आपको डेंटिन में एंटर नहीं करा सकती. दैट इज माई क्लेम. If you do these two techniques which I tell you, you all are going to be only in the enamel, having long bonded restorations and having an amazing time with your preparations. So just listen to this concept. So the first thing is your preparation guides, right? You all know when you all initially, everybody's talking about katori cut. So now the katori cut, katori haircut. What is that katori haircut? सर के ऊपर कटोरी रख दी, अगल बगल का ट्रिम कर दिया. Is it possible to enter inside and trim extra? You will have that perfect shape, isn't it? So basically, here these two techniques are going to help you stay outside the katori and trim only things outside the katori. So the first thing is going to be your preparation guides. So now whenever you get a case of laminate veneers, what do? Take a diagnostic impression, do a wax up. Wax up as in whatever you want to be restored. If you think there's a diastema, do a wax up for the diastema. If you feel that there's discoloration on the tooth, if you feel there's going to be discoloration, that's going to be a different technique. I'll just tell you following. Next, if for example you have a chipped off anterior, if you have something, you have an attrited or you have abfracted anteriors, just do a diagnostic perfect wax up. Next, you take your silicone putty, you make an index out of it, and in the index just make these indentations. I'll tell you why. Just cut through and through. So now you have a perfect diagnostic wax up how the patient wants to be looked, and you have this putty index on it. So the second one is going to be your incisal prep guide. Now in incisal, the first guide was that guide initially which I showed you. Your second index now, adapted to the entire surface, and cut this guide through and through from here. Now this initial guide was adapted on your wax mock-up cast, okay, and it was checked inside the patient mouth. This patient came to us, for example, say because of attrition, he wanted longer incisal edges. So on the cast, it was touching everywhere. When we saw in the mouth, we know that this area ko prepare nahi karna hai because you want to add on it. Correct? So now you are going to prepare only those areas which need space for the ceramic. For example, see here, can you see the space here is very less? So you know you need to prepare this area. You know the space is too much here. You don't need to prepare this area. Again, this area you need to prepare. So this is what your guide is going to help you do. Are you guys with me? Okay. So now going to the ahead slide, just see what these, how do you prepare these guides. तीन नंबर क्या आ रहा है? तीन नंबर आ रहा है. एक मिनट रुकना. नहीं ये नहीं, प्रीवियस वाला है, 4 नंबर. Now just see how do you make these guides. This is another facial plane guide. You just saw the incisal. Now this is for your outer surfaces. Itni volume नीचे. Adapt it. Don't cut it through and through. It should be like a page of a book. So now you just give a vertical incision here, but you don't cut vertically here. cervical third and for the middle third here. Now for the cervical third. Okay, so what has happened here? Okay, so what happened here is you have 3 different planes. So when you have to prepare your cervical area, you put this part of your facial plane page, and when you have to make your incisal area, you put this part. That simple as that. So it's not going to be difficult for you to cut excess. चाहो तो भी आप excess नहीं काट सकते. So now how using this? A little bit confused here. Now look at this area here. Now your guides are ready. You have 3 different guides here. The first guide, you know how much to reduce from the incisor. Now this guide was made on ideal wax mocked up cast. You place this guide in the mouth, and now you know where all you have to prepare. You can see this area, this needs to be prepared, but this area doesn't need to be prepared. Basically this patient must have come for some crowding or correction of, you say they want the incisor in one plane. So you don't need to prepare this area here. If you prepare this area, you might enter the dentine. So you know you need to add here, you know you need to subtract here. This is why your guides are used. This is another case where it's from Gallup Gurel. He's like the god of porcelain, laminate and veneers. So now this patient in the book presented for, say, correction of this crowding. So now to correct this crowding, he used the index, mocked up a cast and made the index on the cast, and when he placed it in the patient's mouth, what he sees is he does not need to reduce here, he does not need to reduce here, but he needs to reduce here. So he exactly knows where he needs to be in the enamel and where he doesn't need to do extra shaving of the enamel. So the second part here is going to be the depth control. Now this is also going to prevent you from entering into the dentine. Now when I'm talking about dentine laminate veneer preparation, आपको saw और burr के साथ नहीं बैठना है. It's not that you are doing a tooth preparation. I won't suggest even to sit with a saw when you're in a tooth preparation. So basically when you're here, you have specific burrs which are going to help you stay only in the enamel. They're going to help you reduce only 0.3 to 0.5, which is the thickness of your porcelain. So it's called as the aesthetic prototype. So remember the initial guide we made. So you're going to do, what you're going to do is add some temporary material into this, adapt it onto the wax mocked up cast, and then you're going to have something like this where the acrylic has stuck to the tooth, and now you will use these burrs, these depth control burrs, and adapt it to the portion of the tooth, and this will help you reduce only 0.3 to 0.5 mm. उतना ही कम होगा जितना आपको ज़रूरी है. So now if you see this, these depth cutters or these aesthetic prototypes are going to help you to stay in the dentine, are going to help you to prevent from entering into the dentine and just stay in the enamel. So to be very precise and to summarize this APT or aesthetic prototype, which is going to help you stay in the enamel, ये slide देखो सब समझ में आ जाएगा. Now when you see this, acrylic को आपने बाहर के portion पे tooth पे adapt कर दिया है already after taking your wax mock-up index. This is extra acrylic stuck on the tooth. You use your burrs, the depth cutting burrs, and you start trimming it in 3 different planes. Now these depth cutting burrs, they have a depth of 0.3 or 0.5. So you know how much ever you have reduced is required for a porcelain, laminate or veneers to come there. So now here you take your round burr and you polish it. This, if you apply these 2 techniques, you are never going to enter into the dentine, that's my guarantee. Okay, so this is something which is upcoming. This is something which you start implementing for all your porcelain and laminate veneer cases. Any prosto PGs here? what department PGs do we have here? Periodontist. So the next slide is very important. So my lovely perio PGs, can you tell me why have I done this here? Anybody, it's just a cool session, any one of y'all. Perio PGs here? Where are perio PGs? Okay, anybody can answer. Why have I done this here? What is this? Pardon? Biofilm, okay, acceptable, but what is this I have done here? Can you see the retraction cords that I have packed inside? Can you see that? These are retraction cords. Why? So that my better finish margins, I can finish my margin near this laminate veneer and not damage your marginal gingiva, because if in case I damage it, I am going to have a horrible time maintaining the isolation, making the impressions. You all agree, right? Right? Okay. So let's go ahead to the next thing. So now, taking a gist of it, you all know you all need to make these guides. You all know you need to make the aesthetic prototype, and it's done. This is your main part of preparation. If you do this, trust me, you're going to have amazing time. So can you please tell me what are the 2 thumb rules or 2 tools which are going to help you with successful laminate restorations? Anyone? You all have been an amazing crowd, very interactive. Anybody? Anyone, please tell me 2 tools? Please stand, ma'am, please stand. Can I see your lovely face? Please a good round of applause for this lady. Sitting right in the end, she has been so interactive. I am very proud of you. Yeah, please tell me. Absolutely, absolutely correct, absolutely correct. So now you make the impressions. We've been talking so much about digitalization. You make the impressions however you want. So now the next important quick tip here is you have done the entire preparation for the tooth. But an important part which as a clinician we miss is preparing your porcelain restorations. Your porcelain restoration needs to be prepared too. Laminate lab से हाथ में आया, अब कौन सा laminate है? Zirconia है, IPS Impress 2 है, Lucite है. That also I'll just tell you. So if in case you have say you have a glass matrix ceramic, you have a feldspathic ceramic, you have a lithium disilicate ceramic, IPS Impress 2, IPS Impress, you need to apply hydrofluoric acid on it. Hydrofluoric acid, जो etchant आपका दांत के ऊपर कर रहा है, the same thing your hydrofluoric acid will do on your tooth. It's going to just increase your surface area. So basically, you're going to etch your, the battery is low. You're going to etch your ceramic with the help of hydrofluoric acid, and what your hydrofluoric acid is going to do is going to just dissolve some part of the glass phase. Now ceramic में difference क्या है? Okay, when you give your lab person, lab वाले को आप जब कोई instruction देते हैं, we just go, अरे zirconia का बना देना यार, अरे यार IPS Impress 2 बना देना. Have you ever thought कि इसमें difference क्या है? How to choose your ceramic? You should be the person telling the lab person, I want this type of crown, not the lab person guiding you. Have you all come with the experience where you had amazing shade matching, 3D master use कर लिया, but when the crown is coming or the laminate or anterior tooth comes and you cement it into the mouth, you have a very different color? Happens, right? And then you send it to the lab. If it's a darker colored shade, repeat. अगर light है तो add. So you should know which ceramic to use. Now how would you know that and what is the difference? Now ceramic has 2 phases. Okay, one you have your glass phase and then you have your crystalline phase. This is the glass phase. It's like a matrix. उसमें crystals होते हैं. Now when these crystals are there in the form of lithium disilicate, it's called as an Impress crown, IPS Impress 2, nothing else, कोई rocket science नहीं है. And when you don't have too much of glass phase, more of crystals, compacted, they are mostly aluminium or they are zirconia. So when you talk about zirconia, it's going to be more compact, that is why it is more harder, क्योंकि glass phase है नहीं, उसमें से crack propagate होगा नहीं. Simple as that. But zirconia, because it has more amount of crystals in it, more compaction, it is opaque. This has glass phase, so it is more aesthetic. Now is it clear कि zirconia और lucite और disilicate में क्या difference है? More the amount of crystals, jitna aluminium, zirconia, magnesium will be added to your crown, more radio opaque it's going to be. Okay, and more is going to be difficult to aesthetically do cases where you don't need something which is going to be so opaque to match your shade. Now for example, if you are supposed to do a case where you have fluorosis on the teeth, there opaque chalega, koi problem nahi, you have to cover everything up. But if you need a case where there's just one tooth which is say chipped off or it has a initial failed composite restoration, you can't be playing around with the shade. Correct? So you should know how to choose. So I hope अब आप अपने lab वाले को बताओगे कि कौन सा ceramic करना है. Are you guys with me? Can you please put your hands up with me? Okay, great. Let's go ahead. So this is what I just told you all. You have another thing, silane application. Now silanization is important. Why? जैसे आपने etch किया, there is going to be little bit of water which ceramic always keeps it. ये silane वो सारा water wash out करेगा. It will make new bonds. After doing silanization, please cover your restorations because silane is going to be increasing the wettability. It's also going to attract the moisture from the environment. Apply your silane, let it evaporate, and cover your restoration till you are going to cement it on the tooth. So, what are your procedures when you are going to do your cementation? You are going to, of course, after your silanization, apply the bonding agent. So, your technique is going to be etch your tooth, rinse your tooth because you are in. Why are you etching? Because you are in. Great. I just love this crowd. Very interactive. Okay, so you are going to do it because you are in enamel. Okay, you rinse thoroughly. You apply your bonding agent. Now you go to your ceramic veneers, you apply the etchant on it, the porcelain etchant, put your bonding agent, and here is one small very important tip I want to tell you guys. If you all are cementing anterior veneers, please use only light cure resin cements. No using dual cure. Reason being, dual cure resin cements are full of amines. Okay, so when you talk about a light cure resin cement, the polymerization is only going to stop, or the polymerization is only going to happen, or curing is only going to happen when you cure with the light. The dual cure cement is going to keep curing till it does not achieve its stability. In those cases, the shade of your laminate is going to be affected. Laminates are very thin, very thin. उसके अंदर अगर आप कुछ भी opaque रखोगे, it is going to take the color. So keep it in mind. If you want to do cementation for laminate porcelain veneers, invest in a porcelain cement or laminate veneer cement. I use the one by Relix, which is specially for and it's a light curing one. Rest all you can use your dual cure cements, no problem. But this is one important tip you all need to notice. So just asking you a question, when I want to cement my veneers, what do I use? A light cure or dual cure? Great. So if I have a fluorosis patient, okay, I would like to show you this patient who came to my clinic, which was a big headache for me. I'm very sorry I'm saying that. This patient was unsatisfied by 3 previous dentists. And this patient came to me saying कि मेरा shade match नहीं होता है और मुझे नया laminate चाहिए. आपने मेरे दूसरे पेशेंट के कुछ काम किया था, उन्होंने रेफर किया है. First 2 sittings I said कि we always have that patient जिसको हम कहते हैं यार देखते हैं यार अवॉइड हो जाए, काश ये पेशेंट कभी वापस आए ही नहीं, कॉल ही नहीं करे. और जो पेशेंट हमको मोटा इम्प्लांट का पैसा देने वाला होता है वो कॉल नहीं करता, पर ऐसे पेशेंट जरूर करते हैं. So I told my husband that I don't want to do this case. I don't want to do. बहुत टेंशन है यार, ये तो डेंटिस्ट को, ये तो समझ से डेंटिस्ट सबसे बड़ा दुश्मन है, मुझे नहीं करना है केस. My husband gave me one small advice. He's right here, Dr. Sarthak Mathur. He's a dentist too. We practice together. So he said, do one thing. You charge her double. I said, why double? If you charge her double, you will be more precise in working on her. You will be like, यार पैसा आ रहा है, चलो काम करो और ध्यान दो. You will be able to take the risk. And if she pays you double, if she is not interested, वो ऐसी भाग जाएगी. Right? So we did this case We had 6 trials for her shade, and finally she was happy with this. A patient who had fluorosis, we gave her nice successful laminates like this. We were very happy because she was happy, right? So basically in fluorosis, what do? Fluorosis mein kya hota hai? The upper layer of enamel does not form, all of you all know this. So isme you will double the etching time so that the fluoride jo layer bani hai, it can wash out from there. So the only tip, whenever you see a fluorosis case, double the etching time. Got it? So here, now this is the guide for this patient. So we knew we had to prepare here. The initial preparation according to me was insufficient. So I made a guide, I prepared this area only, and then you all can see what the results were. So now you know which ceramic to use. Everybody is clear here what ceramic to use, won't waste more time on it. And you have 2 types of patients when you choose your ceramics. Type 1 is going to be in the cases where there are no color alterations, and type 2 where you need color to be alterated. Now where you need color to be alterated, what laminates can you go in for? What laminates, what material of ceramic can you use? Zirconia or Ypres Impress? Correct. Okay, so this is a case of zirconia laminate, where there was this patch. We used a Curie's indicator for her, but there was no indication, but she had this discoloration, maybe an instinction stain, and we gave her an amazing zirconia laminate here. So this is another case where I had to do diastema closure. Basically, if you can avoid doing mandibular laminates, because the enamel is very thin there, but still I did it because I used my guides, and probably you all can also do it because you all know how to control the depth now. So this is another case, a very old case, 5 years back, when I actually got into laminates. I've been practicing from the past 13 years, but I was into, my first case which actually fascinated me was when I closed this diastema. I was like, this gave amazing results. The patient didn't have to go for any ortho treatment. I have another case where this tooth was, of course, I had to use biodentine here, something done by old dentist. Now this tooth was restored by laminate, this tooth was restored by laminate, and this tooth. Can you all see? They all look so similar. And here, can you see the shade here? Okay? Yeah, I'm done, just done. So this is another case where this patient came to me because she had failed composite restoration, and she said कि वो dentist में जो कर रहे हैं बार-बार निकल रहा है. I said to her, कोई dentist नहीं चाहेगा कि उसका restoration fail हो. The only thing, I just changed her treatment plan and she's happy. Give night guards to your patients if you all think your patient is a bruxer, so that there are no lateral, no parafunctional habits, and no chipping off of the area, because I told you laminates are expensive. Once the patient pays you for an expensive treatment, he's going to come knocking your door all the time. So, summarizing the entire thing, be an enamel, use the depth guides, use your particular laminate preparation burrs, no cutting your tooth like a saw, and do the final preparation of your restoration also, and do the cementation of your veneer. So, if you look the way you look at things, the way things look at you change. So, thank you everybody to be such an amazing and such a lovely audience, and thank you so much. You all can always contact me, discuss your cases with me. This is my ID and handle wherever you can contact. I would dedicate my entire journey of being a prosthodontist to my PG guide, Dr. Pranop Kumar Sanyal sir. He is a person who has touched my life in many ways. One of the best guides I can ever have, who taught me not only to be a good prosthodontist, but also to be a better person in life. I have one more slide. Just go behind. One more slide, no problem. So, happy veneering to everybody. Thank you so much, and I hope to be in contact with most of you all. Can I have a big round of applause for yourself? A very interactive audience. Thank you so much.
Thank you, ma'am. So this was Dr. Pinky Mathur, ma'am, and she covered the topic Conquering the Art and Science of Porcelain Laminate and Veneers. Now, before moving on to the next speaker, it's time for felicitation. So I would like to invite Dr. Anmol ma'am, Dr. Ashish sir and Dr. Pavitra Rastogi sir on stage for the felicitation of the guest lecturers. I would like to invite Dr. Chinmay Hazarika sir on stage for his felicitation as a guest lecturer. Sir has also been awarded as the Innovative Dentist of the Year, but as sir wasn't present here yesterday, so we are giving the award today. Congratulations, sir. Innovative Dentist of the Year, Dr. Chinmay Hazarika, sir. Please give a round of applause for sir. Thank you, sir. Next, I would like to invite Dr. Pinky Mathur ma'am, who has just finished with her lecture. We would also like to felicitate Dr. Prashant Gupta sir, who is about to give the lecture. He is the next lecturer, but we would like to felicitate him first. Please give a round of applause for Dr. Prashant Gupta sir. Thank you, sir. Thank you, sir and ma'am, for joining us on stage. We'll now proceed with the next lecture of the day, and that is by Dr. Prashant Gupta, sir. A brief introduction about sir. He has finished his BDS and MDS in the field of oral medicine and radiology from the renowned Bapuji Dental College and Hospital affiliated to Rajiv Gandhi University of Health Sciences, Bangalore. He has been associated with research for the past 12 years. He also holds a fellowship in forensic odontology. His research for fellowship was awarded the best research at National Conference on Forensic Odontology held at Chandigarh. He was also awarded the A.K. Bhovir Award for the best research paper by Indian Academy of Oral Medicine and Radiology. During the last 13 years, he has engaged in several clinical cases and their treatment, mostly the red and white lesions, diagnosis of oral cancer and potentially malignant disorders. Dr. Prashant Gupta sir is here to cover the topic differential diagnostic and management of vesiculobullous lesions. We welcome sir on stage.
Good afternoon, all the respected respected faculty members sitting here. Especially, I know my specialty, ma'am, Dr. Neeta Mishra, ma'am, who is also the president-elect of our Indian Academy of Oral Medicine and Radiology. The topic I have chosen is because I want to stray on the importance that oral medicine and radiology is no more a non-clinical branch, because a lot of students in our graduation days, they feel that oral medicine and radiology is a non-clinical branch and our duty is only to refer patients. But this is no more the case now, because we are treating so many cases of ulcerative lesions, we are treating so many cases of red and white lesions, we are treating all the cases of mucosal lesions which are present in the head and neck region, and we are into advances in all the maxillofacial radiology. Before I start my presentation here, I would like to remember my teacher, my guide and my mentor, Dr. Ashok Lingappa sir, who is presently the professor and head of Babu General College and Hospital, Davangere. I have studied my graduation and post-graduation both from this college. So I start my presentation with this short note. The topic is, again, I told you that we are treating so many cases, so oral medicine should not be considered no more as a referral branch or a non-clinical branch. That is why vesiculobullous lesions and oral lesions of the oral cavity. So we come across a lot of lesions. We need to understand the terminology of these lesions before we actually go and explain these lesions. What is a macule? It is a flat lesion which can be described from the change of color, which is a flat. Vesicle or a bulla, vesicle and a bulla are elevated blisters which are fluid filled blisters, and the dimension is less than 1 centimeter is called as a vesicle. If the diameter is more than 1 centimeter, you call it as a bulla. So coming to the briefly about the classification, depending on their clinical presentation, they can be classified if the lesions are occurring in acute less than 10 days duration, they are having multiple signs of inflammation, that is redness, swelling, then you call it them as acute multiple lesions. The brief examples for these acute multiple lesions are herpes simplex, varicella zoster virus. Recurring oral ulcers, if we have recurrent oral ulcers, ulcers are appearing every month or every in a 3 months or 4 months period, then we call them as recurrent oral ulcers, example being the recurrent aphthous ulcer. Chronic multiple lesions, if the lesions are occurring over a period of 6 months or 1 year and they appear very regularly and they are seen in female patients with more than 40 years of age, then we call them as chronic multiple lesions, and the example being the pemphigus vulgaris. And the last of the group is the single ulcers, when the ulcers appear secondary to patients suffering from chemotherapy or radiotherapy. If the patients are given treatment of chemotherapy and radiotherapy, we have big ulcers in the oral cavity, they are called as single ulcers. So depending on the epithelium or where there is a loss of attachment which has caused the ulcer, we have classified them. Just quickly I'll go through it. If is in the suprabasal layer, then you call it as pemphigus vulgaris. If it is in the basal layer, we call it them as lichen planus, and if it is in the connective tissue, it is bullous pemphigoid or cicatricial pemphigoid. Coming to herpes simplex virus infection, which is the most common viral infection present in the head and neck region. They are acute lesions, they are present in they have two types of onset. Predominantly when we have primary lesions, they are present in the younger children population, and we call them as acute herpetic gingivostomatitis. They are present on the gingiva, that is the attached gingiva. This is a case, all the cases which I am showing in my presentation are all being treated by me, are all being seen by me. None of the cases have been taken from the book. So these are the lesions which we can see which are present on the gingiva. It's a 4-year-old boy with multiple lesions. We did not give any, we gave only symptomatic treatment and topical acyclovir ointment for these patients. Now, once these lesions start healing, they are self-limiting lesions and they heal in 10 to 12 days. Now, I told you about the viral infections. The viral infections are generally happen in the immunocompromised host. The host has to be immunocompromised to see the severity of the viral infection. All the cases of viral infections need not to be treated by antivirals or steroids. Only few cases of viral infections need to be treated. We saw in COVID cases also, all the COVID cases need not to be given remdesivir. Some cases were given only paracetamol, some cases were given symptomatic relief from antibiotics. So it is not necessary that all the cases has to be given antiviral treatment. Depending on the immunity of the host, we have to decide the treatment plan. So once the primary lesion subsides, the secondary lesions happens, and after a certain period of time, the secondary lesions happen. This is a classical example of a secondary lesion, secondary herpetic vitiligo, which is seen in adult population. It is seen involving the red and white lesion, which is seen in the nail beds and the skin over the nail beds. What is the pathogenesis behind this is there is inoculation of virus which gets inculcated into the epithelial cells, and these viral cells, they get multiplied inside the host cell because they do not have their cell body, so they have to be inculcated. And once they get inoculated inside the human cell, they start multiplying because of the DNA. All the herpes viruses are DNA viruses, remember this. So their DNA get integrated into the host DNA and they start multiplying, which is an abnormal DNA. Coming to other oral findings of herpes simplex viral infections are these vesicles, they are multiple vesiculobullous lesions. And remember one thing, I have striked one point here is the herpes simplex viral infections appear on the keratinized mucosa. We divide the mucosa into two types, keratinized and non-keratinized. So herpes virus infections happens only on the keratinized mucosa, that is gingiva and the palate, and sometimes the dorsal surface of the tongue. This is again a presentation of a recurrent herpes virus infection. This is called as recurrent herpes labialis, which is seen at the junction of the skin and the vermilion border of the lip. We can see another presentation of recurrent herpes labialis involving the lower part of the skin over the lower labial mucosa, the vermilion border of the lip and the lower labial mucosa. Again, one more presentation. All the dentists who are present here, remember one thing, if you are seeing these patients or patients with presentation like this, always tend to follow certain protocols when you are, you have seen this, because lot of times during the dental treatment and after dental treatment you get these kind of presentations. These are nothing but recurrent herpes labialis, that is herpes simplex virus type 1 infection has happened which has recurred. That is the secondary type of herpes simplex virus infection. You have to wait for 5 days or at least 7 days and you have to stop the dental treatment for the time being because two things, because this might happen to you also and this might exacerbate and occur in the other sides of the oral mucosa also. This is one of the classical presentation of recurrent herpes labialis occurring in patients who are either immunocompromised or under any kind of stress. Coming to differential diagnosis of herpes simplex virus infection, if you come across these kind of lesion, investigation is a must. What are the investigations I will suggest is go for an ELISA, but ELISA will be positive only when we have antibodies to these herpes simplex virus infections. So ELISA will be done only after the latent period has subsided and we are seeing the clinical symptoms of the disease. So another differential diagnosis apart from Coxsackie virus is the clinical presentation mimics like necrotizing ulcerative gingivitis. I have told you that herpes simplex virus infections occur on the keratinized mucosa apart from the vermilion border of the lower lip. So necrotizing ulcerative gingivitis also has to be considered because it also appears on the keratinized mucosa, that is on the gingiva. Then traumatic lesions will not be surrounded by an edematous halo. There will be white keratotic borders in case of traumatic ulcers, and the patient will not have any prodromal symptoms like fever, arthralgia and myalgia and headache. So, lab diagnosis can be done by ELISA test, but other confirmatory tests that can be done are fluorescence, direct or indirect immunofluorescence, polymerase chain reactions, and ultimate diagnosis can also be done by the biopsy. Coming to treatment of herpes simplex virus infections, we can give symptomatic treatment in the form of local anesthetic, that is lignocaine. Apart from this, non-alcoholic mouthwashes should be preferred. Initially, lot of people used to give tantum, but tantum is not so beneficial because sometimes it has seen to increase the burning sensation. So, another mouthwash that is available in market which is non-alcoholic is an Cool Aura mouthwash. Cool Aura mouthwash is definitely not alcoholic and it will not cause any increase in the burning sensation. If the severity of the disease is more and the immunity of the patient is not so good, then we have to give antivirals. What are the antivirals that we are supposed to prescribe is, in case of children's or less than 15 years of age, then we are supposed to give 200 milligram of acyclovir 5 times a day. If the age of the patient is more than 20 years, probably 400 milligrams of acyclovir 5 times a day for at least 1 week to 2 weeks. Apart from this, other antivirals can also be given, but the primary choice of antibiotic in case of herpes simplex virus infection is acyclovir. Other things that can be given is you have to hydrate the patient very well, you have to give antipyretics to patient to subside the fever, and some analgesics also. Coming to another family of herpes infection, that is the herpes simplex type 3 virus, we have varicella zoster virus. Now, primary infection, all of us know that it leads to chickenpox, but we are not concerned with chickenpox here, we are concerned with the secondary infections caused by varicella zoster virus. So, once the virus has caused the chickenpox or subclinical chickenpox, it resides in the ganglion, most commonly in the trigeminal ganglion. And once there is the immunity of the patient is compromised, then we get reactivation of the virus and we get the infection that is called as shingles. Now, we always diagnose herpes zoster and varicella zoster depending on the presentation. Herpes zoster will not be unilateral, but varicella zoster will always be unilateral. It will be on the dermatome of the nerve supplied by the nerve. It will be happening on the skin of the face, of the trunk, wherever the nerve is supplying in that area. It will not happen anywhere else, and it will always and always be unilateral. Remember, in case of varicella zoster virus infection, the infections will always be unilateral. There will be vesicle formation, it will rupture, and there will be scab formation. I told you about varicella zoster, the lesions will always be unilateral in presentation. So, this is again a case reported to our department with unilateral vesicles which are present on the dermatome of the nerve supplied by the mandibular branch of the trigeminal nerve. It will characteristically be seen on the skin over the nerve which is supplied by the nerve in that area and will be confined to that area only. Another complication of varicella zoster virus infection is there will be necrosis of the alveolar bone in that area, and if the necrosis of alveolar bone or the supporting bone happens in that area, then we will have loss of tooth structures or loss of alveolar bone in that area. See, characteristically the patient had only the loss of teeth in the lower right mandibular teeth because the infection has happened only in the mandibular branch of the trigeminal nerve of the right side. Rest of the teeth, there is a bone loss, but there is not loss of any tooth structure. But because of severe loss of tooth structure, because of the involvement of the varicella zoster virus, there is loss of tooth structure on the right lower branch of the mandibular division of the trigeminal nerve. Now, another complication of varicella zoster virus infection is it causes post-herpetic neuralgia. Post-herpetic neuralgia has to be differentiated from trigeminal neuralgia. How we can differentiate post-herpetic neuralgia from trigeminal neuralgia is there will be episodes of vesicle formation. There will not be any vesicle formation in case of trigeminal nerve. Second thing, trigeminal neuralgia will have trigger points. Varicella zoster virus induced post-herpetic neuralgia will not have any trigger points. These are the two very, very classical differences to differentiate between a post-herpetic neuralgia and a trigeminal neuralgia. See, the patient has vesicles on the left side of the face, and the patient had severe pain very similar to the trigeminal neuralgia pain. So, this case was diagnosed as post-herpetic neuralgia, and the patient was, the treatment for post-herpetic neuralgia is different from the trigeminal neuralgia. We have to give tricyclic antidepressants in case of patients with post-herpetic neuralgia along with opioid analgesics in case of patients with post-herpetic neuralgia. And gabapentin is also one of the drugs. In case of trigeminal neuralgia, we always start with carbamazepine. And along with tricyclic antidepressants, we have to add antivirals also, because it is a case of a varicella zoster virus infection. What are the treatments that are given is acyclovir is the first drug. If the patient is not responding well to acyclovir, then probably we have to turn up to valacyclovir or famiciclovir. Another vaccination that has come into market nowadays for varicella zoster virus is the Zostavax, which might prevent you from the serious complications caused by the secondary herpes zoster virus infection. Now, coming to another complication of herpes zoster virus infection, that is a Ramsay-Hunt syndrome. Ramsay-Hunt syndrome, if the virus resides in the facial nerve ganglion and causes eruptions in and around the ear along with the facial nerve paralysis, and then this condition is called as the Ramsay-Hunt syndrome. It also causes loss of taste sensation because of the involvement of the cauda tympani nerve or the lingual nerve, which is the branch of the facial nerve. So, if it involves a trigeminal nerve, it causes post-herpetic neuralgia. If the virus resides in the ganglion of the facial nerve, it causes Ramsay-Hunt syndrome, which has the features of facial paralysis, loss of taste sensation, and vesicles around the external ear. I am rushing through because we have already lost so much of time. So, coming to third disease of most importantly vesiculobulous or ulcerative lesions is the erythema multiforme. It is an acute mucocutaneous disease. Why I am discussing this disease is it is very complicated disease with lot of manifestations, and it is only oral physicians or oral medicine people who can diagnose and treat this condition. That is why it is very important to understand this disease process, because sometimes it might be associated with herpes virus, sometimes it is associated with drugs. And why drugs? Most commonly drugs which we use in dentistry are penicillins and NSAIDs. These are the drugs also that causes this erythema multiforme apart from carbamazepine and phenytoin sodium. So, we need to understand this disease. It has multiple forms, that is why we use the term erythema multiforme. As I told you that this disease has multiple forms. One is the minor form that is associated with herpes simplex virus, otherwise it is called as herpes associated erythema multiforme. The major form, which is associated with drugs, that is especially the penicillin group of drugs and the carbamazepine and gabapentin. Then we have the most severe form of the disease, that is Stevens-Johnson syndrome and toxic epidermal necrolysis. If the mucosal involvement is more than 30%, probably it is Stevens-Johnson syndrome or toxic epidermal necrolysis. These two conditions needs urgent hospitalization. So, identifying this disease becomes very important. Then we have another presentation in the form of bullous erythema multiforme also. As I have told you, etiological factors, various infectious agents, among them is herpes associated erythema multiforme and mycoplasma pneumonia associated erythema multiforme, and then we have certain drugs. Certain drugs is carbamazepine, phenytoin sodium, penicillins and NSAIDs. I've told you about the certain drugs, so we should understand while history taking that which are the drugs that can cause if the patient has taken such drugs and the lesion has happened on the anterior part of the oral cavity, especially the labial mucosa and the tongue, anterior part of the tongue, that is the mobile part of the most mobile part of the oral cavity, that is the lower labial mucosa as well as the anterior part of the tongue. Then we have to suspect that this condition, and if the patient has the history of drug intake or fever, myalgia, headache as prodromal symptoms, probably this is the most likely diagnosis. Remember, this is an acute condition and needs urgent attention. Drugs usually get metabolized by the cytochrome C pathway, but if there is a failure of cytochrome C pathway because of genetic intolerance to the drug, then probably these metabolites of the drug gets as antigens and the body acts as antibodies, and this antigen antibody reaction causes these kind of reactions. Coming to eczema multiforme major, we should always diagnose this as major if there is any history of drug intake and there is less than 10% of the body surface area or the mucosa being involved. Most commonly is the oral mucosa involved. After that you have eye as well as the genital mucosa, which are other frequent mucosas being involved. They have typical onset which have crusted and hemorrhagic lips, that is the classical presentation of erythema multiforme. Stevens-Johnson syndrome also have less than 10% of the body surface, but other mucosa are definitely involved in case of this. There is lot of loss of body fluids in case of Stevens-Johnson syndrome. So, patient needs hydration, patient needs urgent medical attention. If you are suspecting that, please admit patient to hospital immediately. Toxic epidermal necrolysis, if more than 30% of the body mucosa is involved, then we call this condition as toxic epidermal necrolysis. And mucosal involvement is more than 95% in these patients. It is a very, very severe acute onset disease which needs urgent attention and frequent hospitalization. So, these are the target lesions which are classically seen in patients with erythema multiforme. It will be present on the skin over the mucosa. The classical presentation will be red erythematous area surrounded by pale area, and in that there will be in that further pale area will be surrounded by hemorrhagic area. These are the classical presentation or the typical targets. If the lesions are other than these target lesions, then probably they are called as atypical target lesions which are present on the top part of the my picture. This is again a patient of erythema multiforme. The patient reported to our department with the history of paracetamol intake 1 week back for fever. He had only fever for which he has taken this, and because the patient was allergic, acutely allergic to this, patient had developed incrustations on the lower labial mucosa as well as on the tip of the tongue. The lesions are also there on the palate. See, the lesions are on the palate, the lower labial mucosa, most mobile parts of oral mucosa, the lesions will be present, and sometimes on the buccal mucosa as well. After giving proper steroid treatment, the patient has properly responded to the treatment, and now the patient is doing very fine. Now, coming to differential diagnosis for erythema multiforme, we have a lot of conditions which can mimic like erythema multiforme. We have herpetic lesions which are very similar and they are milder in nature. Pemphigus and bullous pemphigus and cicatricial pemphigoid, they all are chronic lesions. They will not be appearing on the anterior part of labial mucosa, they will be rather appearing on the buccal mucosa, and there will be 1 or 2 with the history of vesicle formation. Remember, these patients will have history of vesicle formation. That is why I am repeatedly telling you that history taking is very, very important in diagnosis and of these lesions. If you are able to diagnose, then only probably you are able to treat successfully these conditions. Coming to treatment of erythema multiforme, immediately have to identify the drug. If you have identified the drug, then only you will be able to probably stop the drug, because if the patient continues to take that drug, probably the lesion is going to get severe and the lesions are going to become worse and worse. So, probably identify the drug and stop that drug. Once you have stopped the drug, start the patients on systemic steroids, and while giving systemic steroids to the patient, always make sure that you are tapering the dosage of steroids after 1 week. Suppose, for example, if you are giving 10 milligrams 3 times a day for 1 week, probably after 1 week you have to taper it to 20 milligrams in a day in a divided dosage, that is 10 milligrams BD. Then after that 1 week you have to give 10 milligram OD. So, all these things you have to take into account when you are treating a patient with systemic steroids. Some of the immunomodulators are also being listed here. Because of the shortage of time, I am just rushing through my presentation. Then apart from that, if you are thinking that the patient is on any kind of antivirals, that is herpes associated erythema multiforme, probably you can start with acyclovir also in these patients. Another very good immunomodulator that can be given in patients, if the patients are not healing, the lesions are not healing properly, then probably you can give dapsone also, which is a very good immunomodulator. Mycophenolate mofetil, there are a lot of research work has been done on mycophenolate mofetil, and they have given very, very good results. Coming to pemphigus, this is the chronic vesiculobullous lesion which is present on the buccal mucosa. Most commonly it happens in female patients. Again, I will tell you, this is a chronic lesion, so it will not be bothering patient much, but it is, the patient might get irritated because of the continuous presence of these lesions. They are not acute lesions. There will not be any kind of fever, headache, myalgia or body ache in these patients, because there is no prodromal symptoms. And the lesions will have an always they will have an episode of vesicle formation, which will quickly rupture in a day. It will not stay for a very longer period of time, because there is a split in the supraepithelial layer, that is in the suprabasal layer. So, the roof of the vesicles are not very thick. If the roof of the vesicles are not very thick, probably the vesicles will rupture very soon, and these vesicles after rupturing, they will form pseudomembrane or an ulcer, which is very similar to the secondary lesions. And once these lesions they appear, the patient will have very much difficulty in eating, swallowing, and burning, severe burning sensation will be there. So, we need to identify and then treat this disease. There are a lot of types of pemphigus, but the most common pemphigus which the oral physicians are concerned with is the pemphigus vulgaris. So, small pathogenesis, the immunity of the oral cavity is compromised because it is an autoimmune disease. There are desmogleins. There are two types of desmogleins. The desmogleins which are present in the mucosa are desmoglein 3. The desmogleins which are present on the skin is desmoglein 1. If the antigens are directed against desmoglein 3, then probably we will have more lesions in the oral mucosa. If the antigens are directed against desmoglein 1, then we have more and more presentation in the skin. So, apart from normal genetic, lot of things others that play a role is human herpes virus 8, then certain drugs like penicillamine, and some autoimmune disorders also play a very important role as an etiological factor in case of pemphigus, such as rheumatoid arthritis, lupus erythematosus, pernicious anemia and myasthenia gravis. If these diseases are present in patients along with a vesiculobullous lesion, probably we have to give importance to the diagnosis as pemphigus vulgaris. 80 to 90% of the patients will have oral lesions, and 60 to 70% of the patients will have the first presentation as oral lesions. So, the role of oral physicians become more and more important in patients with pemphigus vulgaris. The buccal mucosa, the soft palate are the most common and the favorable sites for pemphigus vulgaris. I have told you that the lesions in pemphigus vulgaris will have a history of vesicle formation without any history of fever. There will not be any history of fever, there will not be any history of body pain or myalgia or any kind of things which we see in patients with viral infections. So, remember this, If there is a history of vesicle formation which ruptures and leads to ulcer formation without any history of fever, headache, then probably we have to start thinking of pemphigus vulgaris. The classical presentation of history of vesicle formation present on the palate, soft palate. And very important thing that we should note here is that the patient will have Nikolsky sign positive in most of the cases of pemphigus. Nikolsky sign positive is application of tangential pressure on the normally appearing mucosa or the skin leads to appearance of the fresh vesicles around that lesion. That is the Nikolsky sign, and it will be positive only in case of pemphigus vulgaris, not in case of bullous pemphigoid or cicatricial pemphigoid. So, that is because there is a suprabasilar split in pemphigus. There is no suprabasilar split in pemphigus, in pemphigoid, that is cicatricial pemphigoid or bullous pemphigoid. That is why we do not see these suprabasilar split and Nikolsky sign positive in pemphigoid. If this picture can be understood, the basal layer, above the basal layer we can see there is a split, and because of the split the vesicle formation will rupture very fast because the roof of the vesicles are very thin. Indirect immunofluorescence is a very good indicator or diagnostic for pemphigus vulgaris because the antigen antibody complex will be shown as a fishnet or chicken wire type of appearance. Treatment, the corticosteroids remains the mainstay of treatment. Apart from this, because corticosteroids are given because they are very good immunosuppressants, and since it is the autoimmune disease, always good to give steroids. And once you are giving a steroid, remember, never forget to taper the dosage of steroids. Never abruptly stop the treatment of steroids because it will lead to acute adrenal insufficiency. Acute adrenal insufficiency is a type of a medical emergency which can arise if you have suddenly stopped the treatment of steroid. Steroids should be tapered and stopped because the body will stop production of steroids once you are giving external steroids. So, once you taper the dosage and stop the steroids, probably the body will be able to recognize and then it will start its production. So, remember, once you are giving patients with steroids for pemphigus vulgaris or any other disease such as erythema multiforme, do not forget to taper the dosage of steroids before you actually stop the treatment of steroid. Dapsone, again a good immunomodulator that can be given. Mycophenolate mofetil is a new drug. Right now this drug is not so well available in India, but they had given good results in patients with erythema multiforme as well as in patients with pemphigus. Topical symptomatic treatment can be given as non-alcoholic mouth rinses and topical analgesics or systemic analgesics and anti-inflammatory drugs. Prognosis in patients, if the patient's immunity is not so good and the patient will have debilitating illness in case of patients with pemphigus, especially if there is a huge skin involvement. So, in those patients always refer the patient or take an opinion from dermatologist so that they can start with the pulse therapy, and always the pulse therapy in case of patients with pemphigus helps. This is description about Nikolsky sign. The application of a tangential pressure on the normally appearing skin or mucosa leads to formation of a new vesicle or a bulla. I will skip this recurrent abscess ulcer because to conclude my presentation, I would like to stress on few important points here is, first is a good case history is very important for a good diagnosis. If you have failed to take a good case history, probably you are failing as a clinician for the diagnosis. That is why you should always have a good case history and a good workup of the patient before you actually start the treatment of the patient. Do not hurry on treating the patient for giving steroids. If you have diagnosed this as a erythema multiforme and suppose it has come out to be a case of herpes zoster or herpes simplex virus infection, probably steroids will not work, but steroids will worsen the disease. So, always take a good case history and always have a good follow up of the patient before you start actually the treatment. Do certain investigation, do not do all the investigation possible you have the list, because if you do all the investigation, then probably you will be only investigating, not be treating the disease. So, you should be very careful in choosing what all investigations you want to do, such as if you are suspecting a patient to be a herpes simplex or varicella zoster, go for ELISA. Don't go for multiple investigation, don't go for PCR, although lot of books say that sensitivity and specificity of PCR is good, but still I will recommend go for ELISA. If ELISA is positive, start doing the treatment for herpes simplex and assess the immunity of the host, especially in virus infection. If you think that the immunity of the patient is good enough, it is a self-limiting disease, no need to give multiple drugs or fill the prescription with 20 drugs. I have seen lot of doctors writing 20 or 30 drugs, which is not so important at times. Just give plain paracetamol as per the weight of the patient, it will help. But if the immunity of the patient is compromised, probably yes, you have to go with antivirals. Proper follow-up of the patient is very, very important to determine the prognosis of the patient. Thank you so much. I would like to thank all the organizers of the event, especially Dr. Ashish Chandra, for giving me opportunity to speak for today's session. Thank you.
Thank you so much, sir. It was a very informative lecture. Before moving on to the next lecture, I would request Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir to please come on stage for the felicitation of few of the guests. And Dr. Pavitra Rastogi sir as well. So this is the felicitation of the 3 scientific chairperson who chaired the scientific sessions for CynoDent. So thank you, sir, first of all, for the help for chairing the sessions. We would like to felicitate you for that. First one is Dr. K.K. Gupta, sir. Thank you, sir, for chairing our scientific sessions. I would request, sir, to please stay on stage. Next one is Dr. Umesh Pratap Verma, sir. I would like Dr. Nandlal sir to please come on stage. Thank you, sir. Next one is Dr. Mohammad Amir, sir. Dr. Mohammad Amir, sir, for chairing the scientific sessions on behalf of CynoDent. Next, there was an award yesterday for the Best Aligners Company of the Year. We would like to present it to the awardee today. So, the Best Aligners Company of the Year award goes to Clear Aligners, B. Nitin Kumar, sir. Then we would like to felicitate the guest speakers of the day. They are yet to give the lectures, but we are felicitating them right now. Dr. Jagriti Gupta ma'am. I would request Akshita to join ma'am on stage for a photograph. Next, I would like to call upon Dr. Neeta Mishra ma'am. Dr. Neeta Mishra ma'am, who is yet to give the lecture. And the last one for now is Dr. N. Padmapriya ma'am. Thank you, ma'am. Thank you, sir and ma'am. You may proceed to the seats. Now we'll proceed to the next lecture of our day. That is by Dr. Jagriti Gupta, ma'am. She is oral and maxillofacial pathologist and dentofacial cosmetologist. She is the director of Aestheticos Academy of Facial Aesthetics and Trichology. She has been the ex-professor, Department of Oral and Maxillofacial Pathology in Vyas Dental College, Jodhpur. She has various international and national publications to her credit. She has been the guest speaker at various international and national conferences. There is much more to her credit, and the topic that she is going to cover today is botulinum toxin therapy in orofacial region. We welcome ma'am on stage to start the lecture.
Hello.
Thank you for the wonderful introduction. A very good afternoon to the esteemed dignitaries and my dear friends. I am Dr. Jagriti Gupta, oral and maxillofacial pathologist and also a dentofacial cosmetologist. So I also run an academy of facial aesthetics and trichology called Aestheticos. So today I will be talking about a topic that is little deviated from the hardcore dentistry, that is about botulinum toxin, or we commonly refer to as Botox. Starting with the introduction, the horizons of treatment options in dentistry are broadening rapidly. The applications of unconventional treatment options like use of botulinum toxin are gaining momentum nowadays. It offers a transient, reversible, relatively safe treatment options to many conditions of interest to a dental practitioner. Starting with the history, in the year 1980, it was first used by Dr. Alan Scott for strabismus. In the year 1989, it was approved for strabismus and blepharospasm. By the year 2000, it was approved for cervical dystonia and severe primary axillary hyperhidrosis. In the year 2002, it was further approved for glabellar lines, that is for wrinkles in facial aesthetics. Talking about the microbiology of botulinum toxin is produced by the Clostridium botulinum, which is a gram-positive anaerobic spore-forming bacilli. It is the same bacteria which causes human botulism. This botulinum toxin is broken down into 7 neurotoxins, which are labeled as A, B, C, D, and further, which are antigenically and serologically distinct, but are structurally similar. The serotype A is the only commercially available form of botulinum toxin for clinical use, and it is the most potent toxin. Coming on to the mechanism of action, botulinum toxin acts at 4 different sites in the body. First is the neuromuscular junction. Second, it can act on autonomic ganglia. Third, it can act on postganglionic parasympathetic nerve endings. And fourth, it can also act on postganglionic sympathetic nerve endings that release acetylcholine, because acetylcholine is a neurotransmitter which is responsible for the contraction of the muscles. So this botulinum toxin binds to the neuronal cell membrane and blocks the release of acetylcholine, which inhibits the muscle contraction. So wherever the causative agent is the muscular contraction, it inhibits the muscular contraction and relieves the pain or the various ailments. So it is available with various trade names like Botox, Dysport, Xenom. Various companies dispense in the form of these botulinum toxin. How it is prepared? So most commonly available type of botulinum toxin are Botox and Dysport. We must have heard of Botox. We all watch Instagram and Facebook Reels, so it is very common to see Botox treatment done, and we, especially the youngsters, must be very much aware of these Botox treatments. So it is marketed as single-use, sterile, 100 unit or 50 unit, or also in 200 units of vacuum-dried powder. Botulinum toxin is stored in a frozen vial at a temperature of 2 to 4 degrees centigrade until it is ready to use. The preferred syringe for injection is a calibrated tuberculin syringe or insulin syringe having a 26 to 30 gauge needle. So before injecting, it has to be reconstituted, and the reconstitution is done with the help of sterile, preservative-free 0.9% sodium chloride solution. The reconstitution should be gentle. It should not produce any froth, because this froth, due to vigorous shaking, can lead to denaturation of the toxin. This toxin requires 24 to 72 hours to show its effect, and the complete effect is achieved after about 10 days. And the effect of it lasts for about 8 to 12 weeks. So as we know, botulinum toxin is used for both cosmetic as well as therapeutic modalities. Coming on to the contraindications, it is contraindicated with the patients having hypersensitivity or allergic reaction to botulinum preparations, or if we have to inject at the active infection site and in pregnant and lactating females, or the patients who are receiving aminoglycosides, anticholinergic drugs, or interfering with neuromuscular transmissions, or muscle relaxants, because this toxin is going to relax the muscle. So we do not want any drugs that are already relaxing the muscle. and also in neuromuscular disorders like myasthenia gravis, in psychologically unstable patients, and also in immunocompromised patients. Coming on to the applications of botulinum toxin, the uses of botulinum toxin as accepted by FDA are as follows. It is used for glabellar lines or the wrinkles on the forehead, and overactive bladder, urinary incontinence, which is associated with neurological conditions, prophylaxis of headaches in adult patients with chronic migraine, upper limb spasticity in adult patients, cervical dystonia in adult patients, severe axillary hyperhidrosis, blepharospasm, and also strabismus. So, use of botulinum toxin in maxillofacial region can be broadly divided into cosmetic and non-cosmetic applications. Botox or botulinum toxin A offers substantial benefits as an adjunct to cosmetic dental procedures, as well as it is a minimally invasive alternative to conditions which are refractory to routine medical management or require extensive surgical intervention. So instead of going for extensive surgical intervention, which is having a more downtime, more pain for the patient, and if the patient is not ready for it, so we can go for botulinum toxin injections in many cases. So botulinum toxin can be successfully used to treat many dental ailments. So we'll see how Botox can give benefit to dental treatments. So some of the dental treatments that can be done with the help of botulinum toxin are reduction in the gummy smile, masseter hypertrophy, trismus and TMJ disorders, bruxism, and many more. So how do we treat gummy smile with Botox? So gummy smile is a high lip line or where the exposure of the gum is more than 2 millimeter. As we know, we already have seen the star Akshay Kumar, he has a gummy smile. It might suit him, but not everybody will like this gummy smile. A gummy smile shows more than 3 millimeter of the upper gum. So people with a gummy smile may be reluctant to smile, or they are self-conscious about the smile. They do not smile much in public gatherings. So this gummy smile problem can be sorted with the help of just few injections. That is botulinum toxin injections. So there are various causes of gummy smile. One being gingival hypertrophy, another being size and shape of the teeth, another next being vertical maxillary excess, and the most important, that is short or hyperactive upper lip, which can be treated with the help of botulinum toxin injections. So muscles that are hyperactive and result in gummy smile are levator labii superioris muscle, levator labii superioris muscle alachnesi, zygomaticus minor muscle, zygomaticus major muscle. So these are the muscles majorly involved with the gummy smile or high lip line. So how does this Botox work for reducing the gummy smile? Botulinum toxin type A relaxes the muscles in the upper lip. Since the muscle is relaxed, it is not retracted while smiling, and there is no longer contraction or elevation of the mouth or the lips while smiling. So the gum remains covered. So as we can see in this diagram, the muscles that are responsible are zygomaticus minor, levator labii superioris, and levator labii superioris alachnesi. There is a point just 1 centimeter below and lateral to the ala of the nose. This is the intersection point of all these three muscles, where this is known as Yonzai point, where we need to give the injection. Other muscles may also be responsible for gummy smile. That you have to evaluate the patient. So whichever muscle is responsible, we have to target that while giving the treatment. So what are the benefits of treating gummy smile over other procedures, especially the surgical procedures? These injections cause little discomfort because we are giving it with the help of insulin syringe, so it does not hurt much. It is a very thin needle. The recovery is immediate, like no downtime or the patient has to take rest or anything of that kind. And it is cost effective also as compared to other surgical procedures. And injection dose can be adjusted depending on the results required. So if there is more of gummy smile, you can give more dose. If lesser gummy smile, you can always alter the dosage. It can also be given for masseter muscles and jaw reduction and face slimming. Nowadays, it is very much in to have a good chiseled jawline and a thin, slim face. So people are going for it. The results of botulinum toxin use in cases with masseter and temporalis muscle hypertrophy are very encouraging and appear to be safe and effective in treating chronic facial pain associated with masticator hyperactivity. So in this temporalis and masseter muscle hypertrophy, the muscle is generally associated with clenching or other parafunctional habits of the jaws. So the injection sites is identified by palpating during clenching or ask the patient to chew. When the patient clenches or chew, you can palpate the masseter muscle more firmly. So you have to make the point, you have to draw an superior border, inferior border and anterior and posterior border, and then you have to jot down the masseter muscle, which is a deep muscle, and you have to inject perpendicular at 90 degrees into the muscle. For treating temporomandibular joint disorders, we know it is a spectrum of disturbances associated with function of masticatory system, which are often intermingled with other chronic pain disorders. So TMDs may be either myofascial, that is those related only to the muscles, or it may be due to arthrogenic, that is related to TMJ. But majority of temporomandibular disorders are myogenic component and muscular spasticity in relation to bruxism. So this can also be treated because we are going to treat the muscles that are responsible for this parafunctional habit. So botulinum toxin has been proposed as an adjunct in managing temporomandibular disorders, particularly in the cases involving muscular hyperactivity. So the sites of botulinum toxin injection in TMJ disorders are temporalis muscle, superficial and deep masseter muscle, medial pterygoid muscle. Temporomandibular joint disorders can cause severe pain from hyperactivity of the muscles, and treatment options have been limited in the past, but now Botox will relax these muscles and dental professionals can offer quick and efficient pain relief. Bruxism we know is associated with severe clenching of the teeth. It is a parafunctional habit and it is always associated with generalized attrition, TMJ symptoms, headache and muscular pain. So injection of botulinum toxin bilaterally into masseter muscle can relieve the pain. These injections can make a useful adjunct therapy to night guard appliances. We know for bruxism we give night guard appliances. So along with that, if we give botulinum toxin injections also, it will relax the muscles and further hyperactivity of the muscle is reduced. In dangerous patients, the patients have also been benefited from Botox treatment where lip muscles have been repositioned due to decreased vertical dimension, especially in the cases where the patient is not wearing denture for a longer time. So in such cases, the Botox can relax and retrain these muscles around a new denture to make the transition much more successful. In implant cases also, wherever there is a failure due to any stress or any excessive functional force or any parafunctional habit, so Botox injections or botulinum toxin injections into these muscles which form the bite force relaxes those masticatory muscles, sparing the implant and leading to better osseointegration of the implant. So we can also give in implant cases. It can also be used as an adjunct to orthodontic treatment and prevent the relapse. Usually we have seen sometimes that following an orthodontic correction due to strong muscle activity of the patients, there is especially those of the mentalis muscle, there can be rejection of the or relapse of the orthodontic treatment. In cases of oral and maxillofacial trauma also, the administration of Botox into masseter muscles causes temporary paralysis or weakening of the masseter muscle, so fewer or little in number of mini plates or microplates are required in zygomatic fractures. It is also used in the drooping of corner of the mouths. The hyperactivity of depressor anguli oris can lead to drooping of the corner of the mouth. So bilateral injections in DAA or depressor anguli oris relieves this condition. It can also be used in siluria and salivary secretory disorders. Siluria, as we know, is excessive salivation or drooling, and it is due to poor oral and facial muscle control. The botulinum toxin injection is given into the parotid and submandibular glands. Coming on to the aesthetic indications of botulinum toxin, Apart from dental indications, we can also do the aesthetic, that is the facial aesthetic treatment with the help of botulinum toxin to treat horizontal lines, that is frontalis, we can target the frontalis muscles, frown lines, crow's feet, bunny lines, nasolabial folds, radial lip lines, marionette lines, and chin lines. In our clinics, we also see patients having perioral lines or wrinkles around the lips, which are commonly called as smokers or wrinkles. So botulinum toxin are injected superficially at or above the vermilion border, sparing the corners of the mouth to avoid drooping of the corners. So we can also treat the glabular complex and vertical frown lines. These lines are created by three muscles, that is corrugator supercilii, procerus, and depressor supercilii. So when we target these muscles with the help of botulinum toxin, we can reduce the glabular complex or 1-1 line or vertical frown lines. Similarly, crow's feet or the wrinkles that you see on the sides, on the lateral aspect of the eye, can also be treated by injecting into the lateral orbicularis oculi muscle. Bunny lines, these are lines on the lateral side of the nose, which can be treated by injecting into the nasalis muscle. We also encounter dimpled chin or cobblestone appearance of the chin, which can be treated with the help of Botox injections by injecting into the mentalis muscle. Marionette lines, which give you appearance, a sad appearance or drooping of the angle of the mouth, this can be treated with the help of botulinum toxin and can be injected into the depressor anguli oris muscle. It also has a diagnostic application. In patients with chronic or intermittent toothache, botulinum toxin can be used to verify the origin of the pain, that whether the pain is of a muscular origin or from pulpal origin. For example, in cases with referred pain from anterior temporalis, thus botulinum toxin in such cases can be used in prophylactic as well as diagnostic applications. So what are the general guidelines? The preparation has to be used within 4 hours of its reconstitution or preparation. The area of injection can be anesthetized using topical anesthetic, cream or ice. So you should always start with a lower dose, and later on when you assess the patient's condition, you can always increase the dosage. Muscle should not be paralyzed completely to give a frozen look. Instead, it should be in a little lower quantity. Males generally require larger amount due to larger muscle mass and the strength as compared to females. The treatment with botulinum toxin is based on palliative rather than curative approach, as the blockade is temporary. It lasts for only 3 to 4 months. After 3 to 4 months, there is sprouting of new axon terminals, resulting in a return of neuromuscular function. So to conclude, botulinum toxin has traversed its journey from a deadly poison. Earlier we used to know botulinum toxin or by the name of botulism, which was a deadly toxin. So now from that toxin, deadly poison, it has become a therapeutic agent. It has broadened the horizon of dentistry and aesthetic world. So dental surgeons, by the virtue of being extensively aware of the maxillofacial anatomy, can use botulinum toxin with minor scale enhancement and thus upgrade their treatment list. However, the practicing dentist must ensure that the treatment is within their scope of practice, has appropriate training, and not just to administer the Botox or botulinum toxin, but also to deal with its potential adverse effects. So proper training is mandatory for this. So the motto is to provide a complete dentofacial aesthetics, not just the dental component, because a face is a complete dental component of dental and facial aspect. So to give a complete treatment, we can indulge into botulinum toxin treatments as well. Thank you all so much for patient hearing, and I would like to thank Dr. Anmol Bagaria, Dr. Ashish, Team CynoDent, and Indian Society of Dentistry and Department of Periodontology for providing this great opportunity to be a speaker for this event. Thank you one and all.
Thank you, ma'am, for the informative lecture. Now I would like to request the next speaker of the day to please come on stage, and that is Dr. Neeta Mishra, ma'am. A brief introduction of ma'am. She has done her BDS in 1991 from KGMC Lucknow and MDS in Oral Medicine and Radiology in the year 2000 from Rajiv Gandhi Health University. She started her teaching career in the year 2000 in prestigious college, KD Dental College, Mathura. She is currently working as senior professor in BBDCODS, Lucknow. She has around 70 international and national publications in reputed and PubMed index journals, and she has conducted many hands-on workshops on laser. Along with all this, she has been awarded as Best Professor in Oral Medicine subject by the UP government. She is National President-elect, IAOMR, and the list goes on and on. The topic that ma'am is going to cover today is private practice, a dream or reality. We welcome you, ma'am, and we eagerly wait for your lecture.
Hello. Good afternoon, everyone. And I request all the students who are sitting backside, यार आगे बैठने के लिए बड़ी साल मेहनत करी हम लोग ने, तुमको हम ऐसे ही आगे बुला रहे हैं, आगे आ जाओ, पीछे बैठ के मत दो. So, you all know me. Who don't know, they have just told about me. I am a senior professor in Babu Banarsi Das, as well as I am a practitioner, and I love practicing. That is the best thing that I want all the people sitting here, they should think of practice. So many people like they want कि हमारे पास private jet हो, private ये हो, अरे सबसे पहले अपनी private practice शुरू करो, वो सब दिलाएगा. So we are just going to talk of dental practice. I am just going to take your 15 minutes, I suppose, 15 to 20 minutes, and I am going to give you mantras. अब ये कहेंगे mantras? Yes. You should have a mind to take that mantra and be awake. नींद आएगा तो थोड़ा खड़े होकर उठक बैठक कर लेना. So the topic of today is excellence in practice. Is it a dream or a reality? What do you say? आज आपकी ये ड्रीम है, कल आपकी रियलिटी होगी. इतना जोश, इतना आपके अंदर कॉन्फिडेंस होना चाहिए. If it is not there, please build up. See your seniors, see your other people who are doing. They were same people who were sitting backside, but they are coming forward. So a private practice is a dream for everyone, reality for some. So I want all of you to come in that reality phase. There are many types of practices. First one is private practice, which I am keeping at first. That is my personal choice. Yours can be other. Second is hospital-based practice. Third is consultation part and partnership practice. These are different type of practices. They have their rules and regulations, and each one is good, best, better, all those what you think. Then first I am going to talk what is private practice. A private dentist or a private practitioner is a dental care provider who sees patient by appointment. So, आपकी सुविधा अनुसार, first thing, this type of dentist usually smaller clientele, not a very big clientele but smaller clientele. Definitely hospitals will have more. Then we can give more personalized services. We can be called as family dentist. आपने family physician सुने, why not family dental surgeon? So, we are focusing on family dental surgeon or family dental physician. It is very easy to do. You have to just motivate yourself to be one of those. And what is the best part of it? You can give time to your family because we have one life, one family, one dental practice, everything one, you can easily balance. So, in this life only you are a practitioner also, you are a father and mother of someone, you are daughter of someone, you like that all रिश्ते भी निभाने हैं आपको, तो private practice is best thing. Another benefit of private practice, wide range of services. आपकी मनमर्जी है, आप इतना करना चाहते हैं, आप नहीं करना चाहते हैं. So, private practice give you wider range of services. Then public dentist. Private practice may offer cosmetics. Just now Dr. Jagriti Gupta has told so nicely about all the aesthetic dentistry which can be practiced and we all can do in our own practices. It is not that you have to open up another practice for that. So, that also can be taken. Morning, one of the doctor has come and he has told about AI. So, you can introduce that. These things are very nicely be taken up in our private practice, which is not so easily done in public places like public hospitals. There will be rules, regulation. They will tell you, they will guide you what you have to do, what you can't. Finally, private practice typically can have more experience than other public dentists because you are whole soul in charge. So, you have to decide, you have to see what all things you are going to do. Then comes the hospital based dentistry. What are the good things about hospital based dentistry? Large number of patients. Your clientele will be too many. You will have a bigger platform. As same time you have many like special patient population who face barriers like they do not have so much of that kind of money. So, they can also come there. You can offer medically compromised individual and mentally or physically disabled person can also be treated. These programs also tend to serve as a community safety net, like you can't, you can get money from the other NGOs and all those part to treat these kind of patients. Now, other thing is consultation. This is a type of practice in that you are not making up any clinic, your name is circulated in the nearby areas and you go for consultations. It has its own terms and conditions. Here keep your terms and conditions clear. Why I am putting this picture? A person you know can have a double face and accept that. So, keep it clear, whatever you want to ask, whatever you want to tell them, this is my fees, this is my cut, this is my partnership, this can be easily told. So, but we are not focusing on consultation. Corporate practice is also type of practice. Corporate practice, they have chains of practice. In that one, like the first clinic which has opened, they give their logo, they give their pamphlets, they tell you the materials what has to be used, and everything is around that. They have multiple chains of clinic. This type of dental organizations may have national recognition is there, but there are also some drawbacks, like if you leaving that chain, there will be no identity. Now I am coming to now the private practice which I started with. First thing, I would like when you enter your clinic, just sit for some time in the waiting area when there are no patients. आप में से कितने लोग ऐसा किए होंगे, कभी अपने वेटिंग एरिया में थोड़ी देर बैठ के देखे होंगे आधे घंटे कैसा लगता है? किसी ने ऐसा किया? Good. Because we hardly sit in our waiting areas. बंदे को जो बैठ रहा है वहाँ कभी कभी आधे घंटे, कभी 1 घंटा भी बैठना पड़ सकता है, तो उस बंदे को लग कैसा रहा है, वहाँ क्या कमियां हैं, वो मैडम देखो बैठ के उन्होंने देखा होगा कि यहाँ पे क्या अच्छा लग रहा है, क्या चीज़ यहाँ पे सुधारना पड़ेगा. Because we are already sitting in our consultations room or in our operatory, we are not sitting in waiting area. So your waiting area is drawing room of the clinic. It should be best. It should be very much in the like उतना ही पेशेंट को आराम मिले जितना वो अपने घर में बैठा है, तो थोड़ी देर बैठ भी ले. थोड़ा टाइम लगता है, कई बार काफ़ी टाइम लग जाता है, तो बंदे को लगे ना कि वी आर सिटिंग इन अ नाइस प्लेस, कंफर्टेबल जोन, देन ओनली दे विल वेट. अदरवाइज दे विल स्टार्ट कि डॉक्टर साहब बहुत देर लग रही है, चलो हम कल आते हैं. Then your success rate, practice success is often required the dentist take change in stride all the technologies which are coming. You should be updated. Every time a new thing comes, it should be in your clinic. Not like everything, the thing which you can use, it is not just like keeping the best thing but not using the same old things, which you can use, which is giving you money. And पहली चीज़ कि हमेशा ये दिमाग में नहीं रखना चाहिए कि we are just practicing money. Money will come. If you practice good, money is going to come. There is no if and but there, because your hard work will always give you success. Highest quality of oral care should be given. A dentist should be well dressed. That is, no book will be writing these all things which I am talking today. No book will write. This is not the thing to teach actually, but I felt in my many years of as a student, as a teacher, I felt so many things we are missing, we have never been told, and we are getting it by experience. So why not to tell our students in the teaching time only, when we are teaching, when they are students, when they are budding, that time only these things should be known to the students. That your patient sees you as a role model, so they want you to be well dressed. You itself think that if you are going to physician, a physician is very shabby, dressed and all those, you won't get treated. वो एक का 4 गोली दे देगा, आप ठीक नहीं होते हो, पर बंदा वो प्यार से अच्छे से मुस्कुरा के 1 गोली देता है, गोली देने से पहले ही आप ठीक हो जाते हो. So in that dentistry also comes in same thing. Balance your home and practice. Practice में बैठ के कैविटी बनाते बनाते 4 ठो गालियां घर पे मत देते रहो, नहीं तो आप बिना कैविटी के बजाय RCT पे चले जाओगे. And your 30% of your profit, whatever you are earning, 30% of the profit, not the whole I am telling, the profit part should be reinvested in your clinic. In any means, मरीज अगर 2 साल तक आ रहा है तो आपकी क्लिनिक 2 साल तक वैसी की वैसी नहीं दिखनी चाहिए. नहीं, हर साल आप दिवाली पे घर ठीक करते हो, क्लिनिक भी ठीक करो. So put some money in clinic in all the phase, like not only in instruments, interiors, sitting area, पेंटिंग वो 10 साल से वही लटकी है पुरानी, नहीं भाई चेंज कर दीजिए, बोर होता है बंदा जो बैठता है सामने, आप तो पैसे गिनते रहते हो। एंड इंटरनेट मार्केटिंग इज मस्ट नाउ डेज, हाइएस्ट like number of followers and all, that is different thing, but आपकी गवर्नमेंट, आपके जितनी भी चीजें हैं सब किस पे चल रही हैं, इंटरनेट मार्केटिंग। तो why not we, why we are getting lagging in this, we should also go for internet marketing. And it is not that a professional should do, you yourself are well equipped to do all these things. Don't put so much of effort, so much of money to give those people who are not much studied, they can't properly write all those things, they don't understand, just come for you to give money, आप इतने पैसे ले लो हम आपका इतना promotion कर देंगे, no need, you are well equipped to do all these things. So do that, make clinic pages, not your pages are just like that only, we just for our friends or family, that for not for our practice. For our practice, it should have exclusive practice page. That should be exclusive for your patients. Your patients things, it should not have your personal photos. It should have your clinic photographs. Your patients, not all patients, no procedure patient का तो identity चले जाता है, इसलिए procedure का, your some good wishes for your patients, that should be on your Insta, social profile for your clinic. That should be totally different. I think last time also in CynoDent when I came to for lecture, I was very much interested in telling about practice, because nowadays students, they are searching after final year, after their internship, they start searching for some other courses, some other stream, they are going to some other streams. Why? We have got the best thing. You are skilled, you have so much of knowledge plus skill, so you are best person to earn money or earn reputation and earn success. Why you are changing your field? Because you are not guided for that. You think कि अरे MDS नहीं किया अभी कैसे हमारा कुछ होगा? Everything, you are general dentist. Why you are thinking that you have not equipped? You are totally equipped, you are totally skilled. So don't get certain that MDS is the only thing. Study is okay, study MDS करने से भी कुछ नहीं, PhD भी कर लिया कुछ नहीं, everything comes on. But if you have that confidence, that skill, you can do good in after BDS also. Don't run here and there. So many career launchers and all those are coming to BDS people and they are telling they will launch their career. The person who have still itself not launched their career, they are asking they will launch your career. So these things should not be there. Then comes the communication parts. You should have a good communication with patient. Give some time. ऐसा मत करना कि किसी जूनियर मोस्ट बंदे को बैठा दिया जिसने अभी अभी कंप्लीट किया है, वो आपको कॉन्फिडेंटली बात नहीं कर पाएगी. हिस्ट्री टेकिंग, फिलिंग द फॉर्म इज डिफरेंट थिंग, कम्युनिकेटिंग इज डिफरेंट थिंग. History taking is not the only communication. History taking is a part of your treatment only, it comes. But communication is eye to eye talk to a person. To आप आँखों के रास्ते दिल में घुसिए मरीजों के, तो भाई वो पॉकेट में हाथ डालेगा. आप आँखों के रास्ते दिल में ना घुस के आप नीचे बैठे हाँ क्या हुआ करके लिखे, तो उसने भी आपको वो जल्दी से नहीं निकाल पाएगा पैसे. इसलिए सीधी बात, आँखों से बात करिए, आँखों से बात, उसकी बात समझिए, उसकी तकलीफ को समझिए वो कितना. और कई बार मैंने देखा है कि व्हेन वी आर डूइंग टोबैको काउंसलिंग, आपने जैसे ही टोबैको का नाम लिया नहीं, पत्नी ने उठा के धड़ 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 पति के ऊपर, हाँ अरे मेरी बात सुनते नहीं, आप समझाइए, मेरी बात बिल्कुल नहीं सुनते हैं. तो भाई दोनों तरफ से बैलेंस कर लेना, उनका झगड़ा करवा के मत भेज देना, नहीं तो पति वापस आएगा नहीं. पैसे पति देने वाला था इस बार. The goal is to communicate with patients, so trust of the patient comes to you, and if there is no trust, the person will not come after 1 or 2 visits. And we want the patient कि वो आए, बाद में बेटे आए, बाद में पोते को भी लेके आए. Words create mental picture. Now I am going to talk on words. So उस mental picture, दिमाग में जब भी आप बात करते हो ना, अभी हम बात कर रहे हैं, आपने एक mental picture बना ली है. So we are just, it is important to pay attention to that mental picture. Now this is the slide. सबसे पहला वर्ड किसी को क्या दिख रहा है? Positive. Because positive is the word we all like eager to know. कभी भी आप चाहेंगे ना कोई अच्छी खबर मिले, कोई अच्छा चीज आए, अच्छा सा चीज खाने को, that छोटे थे, बच्चे थे, तब से हम पॉजिटिव ही ढूंढ रहे हैं. तो पॉजिटिव वर्ड्स आर वेरी इंपॉर्टेंट फॉर अस. So, the mental image associated with appointment, जैसे ही हम बोलते हैं ना appointment, तो एक mental picture बन जाती है कि भैया ये अब हमारा appointment है, और ये appointment हमें मतलब एक बंदे के ऊपर stress आ गया, और normal routine से हटके है, बंदे को half day अपना खर्चा करना पड़ेगा, ये सारा एक चल रहा है, उसको आप थोड़े से उससे हटा दीजिए कि negative term उसमें से निकल जाए. आपने क्या कर दिया? Kindly visit. आप बोल दीजिए कि आपका योर विजिट इज शेड्यूल्ड, प्लीज कम टू द. बंदा एकदम विजिट है भाई, विजिट करने जा रहा है. सो दीज टाइप ऑफ वर्ड्स आर देयर. आप कहेंगे अरे आपका मुंह में तो एक प्रॉब्लम है, हटाइए, प्रॉब्लम को ना बोल के चैलेंजेस बोल दिया आपने. आपने कॉस्ट, इतना कॉस्टली है, आपने लाइक दैट मेनी वर्ड्स आर देयर, एंड आई फेल्ट दैट वी आर यूजिंग जनरली दीज टाइप ऑफ वर्ड्स. और धीरे धीरे ये आप भी धीरे धीरे प्रैक्टिस में वी स्टार्ट यूजिंग गुड वर्ड्स. आई सी मैनी टाइम आई एम टेलिंग सो मैनी नाइसली थिंग्स एंड बिल्कुल फ्रैंक होके सारी चीज़ें बता रहे हैं, पर बंदा मेरे से नहीं, डॉक्टर साहब से ज़्यादा इम्प्रेस हो जाता है क्योंकि वो ज़्यादा सॉफ्टली बात कर लेते. सो दिस इज द डिफरेंस. सो वाई टू टेल कि जिरकोनिया कॉस्टली है एंड पोर्सलिन ये है. अब आपको देख रहे हो दे तो नहीं पाएगा इस जिरकोनिया का पैसा. वी आर नॉट चीपर, जहाँ बोला आपने तब वो नहीं लगवाएगा, तब वो पशु पेश में पड़ गया. नाउ यू टेल इकोनॉमिकल, आई एम जस्ट गोइंग टू पुट. इकोनॉमिक सीट होती है ना, पैसा तो वो भी उतना ही ले रहे हैं, बट इकोनॉमिकल. सो दीज ऑल स्लाइड्स आर जस्ट one पार्ट. This can be a full lecture itself, but I am not dealing with full lecture, I am just giving you food for your thought. So many of you must not be keeping your clinic finances yourself. Someone else will be filing the ITR, someone else will be taking care, you don't know the things. So it is very easy for you to get fooled. So why not yourself? Know the things. आपका जो भी सीए होगा आपको बोलेगा बस इतना जमा कर देना है, उसकी फीस मोटी सी उसमें लगी हुई है, आपको पता ही नहीं चल रही है. सो व्हाई नॉट यू ऑल्सो नो द थिंग्स. इफ यू आर स्टार्टिंग एट एज ऑफ 25 to 35, ये इसी टाइम पे लोग क्लिनिक खोलते हैं. सो यंग डेंटिस्ट में बिलीव दैट डेब्ट इज अ नेचुरल वे. लोन लेना बहुत नेचुरल है, बट द थिंग इज बहुत ज़्यादा लोन ले लिया आपने तो आपको उतना पे करने के लिए उतने ज़्यादा साल काम करना पड़ेगा. सो स्टार्ट विथ वेरी स्मॉल क्लिनिक, डोंट गेट रश फॉर किसी की आपने देख ली बहुत अच्छी, उतनी बड़ी ही क्लिनिक बनानी है. द इशू दिस यंग डेंटिस्ट नीड टू मैनेज इंक्लूड स्टूडेंट लोन भी होते हैं आजकल, स्टूडेंट लोन भी चुकाना है. सो वाई टू गेट सो मच ऑफ लोन. Established practitioners who are in between of 35 to 55 of year age, all students should be paid off by the time. So the dentist can begin to save the earnest for their repayments of other loans. Guideline for the established dentist is the age is to designate 25% of net income to personal living, 25% to all loans and 20% to all savings. it should be our 25 to taxes and 5% for large purchases. अब large purchases क्या होते हैं आपके पास? आपने अभी क्लिनिक बनाई थी, छोटा एक एक्सरे ले लिया था, फिर आपने आरवीजी ले ली, फिर अगले साल आपने लेज़र लिया, ऐसे करते करते एक एक चीज़ ही लेना है. हाँ, पहले दिन पहले ही आपने 3D प्रिंटर ये सब लगाने की ज़रूरत नहीं होनी चाहिए, पहले क्लाइंटेज प्रिंट करना चाहिए. Then one more thing which we are neglecting these days, that is go green. That also can be, you can make your model clinic. People who are from NGOs, who are very much in environmentalist, they will appreciate that. They will come to your clinic. Try to remove the things. Energy efficient LED bulbs can be used to replace the light bulb. Your product selection should be good, it should be environment friendly. Your recycling should be such that it should not hamper the environment, and simply turning off lights, equipment when not in use. So this is my social work which is I am sitting in my clinic and doing. We are not doing for anyone else, we are doing for our future generations. Thank you. So I just told 15 minutes. Thank you.
Thank you, ma'am, for the lecture. Now I would like to invite the next speaker of the day. She is Dr. Shantala R. Naik, ma'am. She has finished her BDS from SDM College of Dental Sciences and MDS in the field of oral medicine and radiology from Bapuji Dental College. She has been in the field of research for the last 12 years and has been involved in several research programs, especially on oral potentially malignant disorders and oral cancer.
Shantala ma'am.
Along with all this, she has alternative Ayurvedic medicines in that she has done research programs on alternative Ayurvedic medicines and their treatment, and she has several publications representing her research work. Today, ma'am is going to cover the topic oral cancer for all of us. I would like to invite ma'am on stage to start her lecture. Welcome, ma'am. before the lecture starts, there is a change first of all in the lecture schedule, but before that, I would like Dr. Pavitri Rastogi sir, Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir to please come on stage and Dr. Nandlal sir for the felicitation of one of our guests, Dr. Arunesh Tiwari sir. Dr. Arunesh Tiwari sir, please come on stage. Thank you, sir and ma'am. We'll proceed with the lecture, but there is a change in the lecture schedule. Instead of Shantala ma'am, Dr. N. Padmapriya ma'am is going to present first. So I'll give the introduction of ma'am. She has done MDS in orthodontics and dentofacial orthopedics. She has done PGDHM, that is postgraduate diploma in hospital management. Her special qualifications are in implantology, clear path orthodontics, lingual orthodontics. Along with all this, she has done associate fellowship in World Laser Institute from USA and fellowship in non-surgical facial aesthetics. She has very many awards, publications and other credits to her name. It's a pleasure to host you here, ma'am. And today ma'am is going to cover the topic visual diagnosis in dentistry. I would now like to welcome ma'am on stage to start with the lecture. Welcome, ma'am.
Good evening to all. My topic is about visual diagnosis in dentistry. Now the dentist should be aware of various clinical conditions that can present as a part of a dental disorder or the treatment. The coming cases will know the conditions, what is going on. First case, I tell you about a 26 years old male had an extraction with some other dentist and developed a swelling on a face and itching and eruption of the body few hours after the extractions. This is the case. This case, the oral swelling, is a feature of angioedema. Allergic angioedema can occur secondary to antibiotic therapy, exposed to the latex or injection of certain foods, substance, and they may be life-threatening. Local anesthetics or a common angiotensin converting enzyme inhibitors may cause angioedema. If the angioedema is mild, we can use the injection of pheneramine, maleate or oral histamine, or if it is a moderate without any respiratory difficulty, we can start on antihistamines and steroid. If it is so severe, we can give a adrenaline subcutaneously. Which drugs cause urticaria? Urticaria is nothing but an itching or a rashes in the body. These drugs can cause urticaria. Aspirin, NSAID, codeine, antibiotics, ACE inhibitors, oral contraceptives, methotrexate and antidepressants. The case 2, which I am going to present, is a 40-year-old male patient presented with the burning of a mouth for 3 months. The symptom of more while consuming hot and spicy food. The history was unremarkable except for the change of toothpaste for 4 months. You will be so surprised, I will be showing 2 cases about the toothpaste allergy. This patient is using a natural red toothpaste with a clove allergy. This is the patients which came for my clinic. On examination, the patient had erythema, lymph reactions on the buccal mucosa. The patient was diagnosed with a lymph node eruption due to eugenol. He was advised to stop using the toothpaste. The patient stopped the toothpaste and he was so happy, and we recommend a triclosan oral paste. The lesion subsided within 7 days. And one more case, using a eugenol paste, a 24-year-old patient came for the burning sensation of mouth for the past 6 months. Patient had used the same red color Ayurvedic paste for past 6 months. These are the things, it shows the adverse reactions. On examination, lip were inflamed, had an angular stomatitis, and oral mucosa was diffusely erythematous. The buccal mucosa was inflamed with gingivitis. We actually use eugenol in our dentistry. We never know the eugenol may be so serious for the patients. So better just ask the patient whether they are allergic to any eugenols. Eugenol is a material commonly we use in dentistry. It's not, however, a bio-friendly material when it's contact with oral soft tissues. It can produce both local irritative and cytotoxical effect as well as an hypersensitivity reactions. Then other case is 25-year female presented with the asymptomatic lesions on her tongue. The lesions were recurrent and spontaneously disappeared. We all know the geographic tongue. Basically, it's because of the stress. These patients are advised for the topical anesthetic agents, antihistamines, and anesthetics mouthwash, topical steroids, and topical clonomers. In other case, 20-year-old boy developed an ulcer on an angle of mouth, lip, and genitalia 2 days after the consultation of another dentist. This is the patient. This is because of the fixed drug eruption. This dermatological manifestation of drug reaction that often occurs in the same location upon a re-exposure of the drug. They usually appears as erythematous while it uses circular patches, but several different variants have been described. The most commonly implicated drug including sulfomethazole, naproxen, brufen, tetracycline, and other antibiotics. The other case, a 60-year-old female adaptix presented with the soreness of mouth. He used denture for past 4 years. This is the patient. This is a dental-stomatitis. Denture-induced stomatitis is caused by candidiasis. Confirmation is by KOH mount. This commonly from a mild, chronic, or atopic oral candidiasis occurs beneath the denture, usually complete upper dentures, because they never wanted to get down the dentures because of the aesthetics problem. Denture worn throughout the night or with a dry mouth favor development of this infection, may be a Candida species mainly. This disease is mainly of middle age or elderly or more prevalent in women than men. Patient appears otherwise healthy. Disinfection modalities, anti-fungal medications, antiseptic mouthwashes, natural antimicrobial substance therapy should be advised. Oral fluconazole can be given. The case, 30-year-old female presented with the pain of lips with discoloration of the lips for duration of 4 months. The differential include the lichen planus or discoid lupal erythematous. The oral involvement has been reported is about 90% of the patient with the cutaneous lichen planus. Approximately 15% of oral lichen planus patients develop cutaneous lesions, and up to 20% of oral lichen planus patients shows genital lesions. Several triggers such as traumas, dental procedures, and cigarette smoking can exacerbate the oral lichen planus. These are the patients. These patients can be treated with non-erosive oral lichen planus, can be usually treated with a topical potent corticosteroid. Intralesional lesions, injections like triamcinolone in case of severe erosion. Severe systematic therapies can be proposed as an effective. Thank you. Nandri, Shukriya. I just thank my parents, kids, my husband, and my friends who gave a positive and strength to achieve all my awards. Thank you everyone, and thank you one and all. And one of my friend has came along from Delhi to encourage me, Dr. Shirley. I just thank her and thank one and all. Thank you so much.
Thank you, ma'am. I would like to introduce the next guest lecturer of the day, Dr. Shantala R. Naik, ma'am. Ma'am has already been introduced, so I'll just tell the topic that she's going to cover today, and that is oral cancer. Welcome, ma'am.
Thank you so much. So good evening all of you. I think all of us are getting restless since we are just getting late, running away from time. So I won't be taking much of time. So my topic is very common, like oral cancer आपको लगेगा ये तो क्या है, सब पढ़ा हुआ है, सब actually it's very commonly used, and I think all of us know at least one or other thing about oral cancer. As an undergraduate, I think it is just a brush up since all of you would be passing out and putting up a clinic, and there are certain lesions in the oral cavity which comes up to you, like which could be a potentially malignant disorder, and exact referral and what are the investigations which you need to do to look out for the malignant potential or malignant conversion for that particular lesion would be dealt with. So it's basically keeping you students in mind. I would be reading out my slides. So what is oral cancer? It's basically an ulcer which is very small, unfamiliar, unexplained, and usually associated with one of the oral habits like tobacco use, smokeless or smoked use. Then the certain lesions occur in the oral cavity which are not associated with any kind of habits. They are like de novo. Like those cases, you try to trace out any etiology, you won't be finding any etiology in those cases. But depending on the clinical presentation of the lesion, you would be suspecting an oral cancer or oral potentially malignant disorder in these cases. So oral cancer, it's said to be the 6th most common type of cancer worldwide, and India has got the largest number of global burden. It's like 1/3 of the world burden. And 70% of the cases in India are said to be reported in the last stage, like in stage 4. So that's why the 5-year survival rate also reduces automatically, say only 20% of 5-year survival rate. This happens only in case of like worse prognosis wala cases, like you say the stage 4 cases. Not all the cases, like in stage 1, probably the prognosis would be very good. Like if in case the patient has been well treated with wide surgical margins, I think the patient has got a very good prognosis. But generally, they say the 5-year survival rate for oral cancer is said to be around 20%, like in worst cases. And right now, it has become a community health concern. That's why you see many people conducting many camps, research, like based on early detection of oral cancer. And around 97% of the cases in the oral cavity which occurs as oral cancer is said to be of oral squamous cell carcinoma type. There are other variants of oral cancer also, which includes the salivary gland malignancies. Then you have verrucous carcinomas. And Northeast India is said to be more prevalent with oral cancer for reasons well explained in literature. And oral cancer, they say, usually arises from oral potentially malignant disorders. And what are the oral potentially malignant disorders? These are a few lists, which includes OSMF. All of us know, like patients who eat gutka, tambaku, jarda, they are all prone for oral submucous fibrosis, wherein you can appreciate the marble-like appearance of the buccal mucosa, restricted mouth opening. Then patient will have burning sensation, the entire oral cavity. Basically the marble-like appearance wherein the suppleness of the mucosa is lost, patient can't blow his cheek, he can't open his mouth. Then oral leukoplakia, it's a non-scrapable white patch. And in smokers, it's usually occurring at the retrocommissural area, and with smokeless tobacco use, like people who use khaini and chewable tobacco, it usually occurs in the vestibular mucosa or the gingiva or the buccal mucosa. Then erythroplakia, it's a like red variant of leukoplakia. Then oral lichen planus, I think madam showed a slide regarding oral lichen planus last presentation. Then candidal leukoplakia and disc keratosis conjunctiva. There are also a few other lists of OPMD, that is oral potentially malignant disorders. Then the etiology, it's usually the chemical factors like tobacco, alcohol. Alcohol itself is not a causative agent, but it can be an add-on factor. Like person who has got tobacco chewing habit along with alcohol use, he's got more chances of developing oral cancer, when alcohol alone itself cannot be causing oral cancer. Then biological factors include the viruses, then syphilis, candida, then dental hygiene and related factors. There is an inverse relationship between dental hygiene and oral cancer occurrence. Like if patient has got poor oral hygiene, probably that person might have an increased chance of developing oral cancer, provided he has got all other prevalent habits. And if in case the oral hygiene is comparatively better or good, he has got lesser chances of developing oral cancer. Then nutritional deficiencies also plays a role in developing oral cancer. That's because the local immunity also plays a role. Like if in case tobacco causes what you call a mutated cell, that particular mutated cell can undergo a normal degradation. Like routinely kya hota hai, whenever there is an abnormal cell that has been detected by human body and that undergoes apoptosis. But if in case this apoptosis doesn't happen and that particular mutated cell undergoes replication, that results in like further progression of the mutated cell. That's how usually oral cancer develops. And genetic susceptibility. See, this is just a graphical representation for all the factors which could cause, which is listed as an etiology for oral cancer. And if in case you want to jot down all the factors, tobacco has got the maximum chances which is associated with oral cancer. Like I told you, this has already been discussed, so I won't be discussing it in detail. There's something called a 6S principle for oral cancer. Like S stands for smoking or tobacco chewing, that is smokeless or smoked form of tobacco use. Then S, that is spirit. Then S, sharp tooth or ill-fitting denture. This is, I think, a very common Viva question whenever as an undergraduate we face. 6S of malignancies. Then S for sepsis, that is if in case the oral hygiene is very bad. Then syndrome, that is Plummer-Vinson syndrome, which is again a nutritional deficiency. And syphilitic glossitis. This is the 6S. Then tobacco, it is the main reason, like I told you. The smoking tobacco commonest, it is the commonest form of tobacco use. Like patients use it in the form of cigarette, cigar. I think this is all, I think all of you guys are well aware with all this. Then alcohol, like I told you, it itself cannot be a cause for oral cancer, but along with smokeless or smoked form of tobacco, it does have a major role in causing oral cancer. Then viruses, among the viruses, the human papilloma virus and HSV virus are said to be more commonly associated with oral cancer, and even with human papilloma virus, it is human papilloma virus number 16, which is more commonly associated with occurrence of oral cancer. Then candida, especially the nodular leukoplakia with candida species is more susceptible for oral cancer. They say the candida infection, it causes squamous metaplasia or mutated cells within the normal epithelium. That's how they say candida infested leukoplakia has got more chances of getting converted into oral cancer. I've already discussed with dental hygiene and the occurrence of oral cancer. There is an inverse relationship. Like as and when you go into post-graduation, probably like you would read literature, there is an inverse relationship, increased periodontitis and increased chances of oral mucositis. Oral mucositis comes into picture post-radiotherapy, post-chemotherapy. Like if the patient's oral hygiene is very bad, then bad is the oral mucositis scale also. So there is an inverse, inverse relationship between dental hygiene and oral cancer. Like if the patient's oral hygiene is better, probably he's got lesser chances of malignant potential. So you will have to always promote patients to have a better oral hygiene. Then nutritional factors like Plummer-Vinson syndrome is associated with malignancy. And why is there a wide variation for oral cancer within India is ek to lack of knowledge. Like if you go into the remote places, most of the patients don't even know like they have something called as cancer. It is only those patients who are so bothered about their oral hygiene, they come to us with an early stage even from the remote areas. But even now, most of the patients who come to us from villages, they come to us at a very late stage, like say stage 4. That's why we conduct camps at remote areas saying that you increase the awareness regarding, you put up pictures, banners with, which is showing the oral potentially malignant disorders so that patient gets aware. Again, if in case he has got some white lesion within his oral cavity, he comes to us saying that if you can just diagnose what is it. Then pathogenesis, these are the 6 steps which are involved with oral cancer, that is autonomy in growth signaling, evasion of apoptosis, then unresponsiveness to growth inhibitory signals. I think these are all self-explanatory. Limitless replication. Replication is limitless or infinite. Then angiogenesis, increased blood vasculature. Then invasion and metastasis. These are the 6 major steps in oral carcinogenesis or molecular pathogenesis of oral cancer. Again, a graphical representation of the same 6 steps. In short, like if I want to tell you like what is this pathogenesis chart all about, like a patient who has come to you with like he's been consuming tobacco or any minor trauma, like a chronic trauma, like if in case patient has got sharp tooth in that area which results in a chronic irritation to that area of the oral cavity, or tobacco consumption. Tobacco has got certain, oncogenic factors which might result in carcinogenesis. These carcinogenic factors results in DNA mutation. If in case there is a mutated cell, it is just a consolidation of this chart. If in case there is a mutated cell, it can either undergo apoptosis in a normal pathway, or if in case there is no apoptosis of that particular mutated cell, it can undergo further replication. Like a normal, growth reproduction of that particular cell. If in case it is degraded and eliminated from the system, it is well and good. So there is no malignancy. If in case it is not eliminated and that goes on, replicating, then you will have these unexplained tumors or mass within the oral cavity. That is what this chart is going to explain. And this particular graphical representation shows within the normal mucosa the genetic susceptibility. Initially, normal mucosa doesn't have any deletions or alterations within the chromosomes. Like if in case there is an oral potentially malignant disorders, there might be deletions in the 3p and 9p, that is the arms of the chromosomes. This particular deletions and alterations just increases as in there is dysplasia. With dysplasia, you will have more and more of chromosome arms which are getting deleted or mutated. So with cancer, you will have the tumor suppressor gene, that is P53, which gets mutated, and that is the end note, like short malignancy hone ka hai bolke. So that is what is this is explaining. And the last one, that is tobacco. It induces some mucosal damage, which results in COX-2 activation, that results in epidermal growth factor receptor activation, thereby cyclin D1 activation. I think all of you would have read about this. And leukoplakia, like it appears as a flat white lesion which is non-scrapable, or raised lesions also. Erythroplakia, they are slightly raised or flat, but these are fiery red in color. Erythroleukoplakia, they are both red and white. And especially with leukoplakia, there are 3 variants, like homogeneous hai, speckled hai. So the speckled variant, that is a non-homogeneous leukoplakia, has got major chances of getting malignant conversion. Then oral lichen planus also has got a malignant conversion potential, especially the erosive lichen planus. So if in case any patient comes to you with erosive lichen planus, and like if it is not getting treated over a course of period, like you will have to take certain, big steps saying if you want to detect any malignant conversion in that case. Then OSMF, it is very common nowadays. All of you must be knowing. What are the common signs and symptoms like for oral cancer? There could be ulcers on the lip, within the mouth, like any part of the oral cavity, say it tongue, lateral border of the tongue, usually on the dorsolateral border of the tongue, buccal mucosa, vestibular mucosa, the alveolar mucosa, palatal mucosa, including the junction of the hard and soft palate. Then the oropharyngeal area, that is the retromolar trigone area, retrocommissural area of the mouth, then the labial mucosa, then the vermilion border of the lower lip. There could be ulcers on these areas which could bleed easily, that could be associated with tenderness. and lymphadenopathy would be present, and there would be a major loss of weight history. Patient will have a bad breath like halitosis, a foul smelling oral cavity, and there could be extraoral swelling or sinus or pus discharge. Okay, these are the a few cases. This is a case of papillary projections or the oral cavity. Like initially, if you want to diagnose this case, you would have said it is a verrucous hyperplasia. And obviously you would have you would have done an incisional biopsy and look out for any dysplasia and thereby accordingly grade if it's a verrucous dysplasia or verrucous carcinoma, something like that. So even this case, you will have to look it with a suspicion saying that there could be a malignant potential conversion in this. Then this particular case, if you see there is an ulceroproliferative lesion on the left buccal mucosa. See, it can appear like this as well. This is ulceroproliferative lesion on the alveolar mucosa. Just look into the clinical presentation of this case. That is what is important. Like if you have any case who presents to you with all the symptoms, you can actually refer the patients to higher center rather than treating them with just steroidal topical gels or something like that. So you will have to actually refer them to higher center so that early treatment is possible and better prognosis would be achieved. You can see this extraoral sinus. There is a punctum which is formed and which is about to be like burst, like it will burst within few days. And if you see the oral cavity, there is an ulceroproliferative lesion in the left buccal mucosa again with restricted mouth opening. This is a case of verrucous carcinoma. See, it is little different than those lesions here. If you see the color and see this is actually a verrucous carcinoma which was diagnosed after histopathology, and patient was a smoker in this case. If you see there are tobacco stains on the oral cavity, there is smoker's melanosis everywhere. So verrucous carcinoma is more commonly seen in tobacco smokers. Chewers usually have ulceroproliferative lesions, like I showed you a few other slides. So this is a CA tongue. This female didn't have any habits, but even after that she had this ulceration on the dorsolateral aspect of the tongue. So she was not a tobacco user. Even then she has ulcer on the tongue. And the clinical presentation itself, like if you have any patient who comes to you with an ulcer which is not been healed for the past 15 days or say 1 month, agar ek mahina bolte hai, obviously the patient is having oral cancer. If in case, if it is only 15 days, you can still, it is like 50-50. But along with oral cancer, there could be certain other lesions in the oral cavity like tuberculous ulcer, which could also be non-healing. So in that case, depending on the clinical history, like you take a detailed history about the patient, history of fever, weight loss, cough, sputum, they all go in favor of tuberculous ulcer. Like if the patient doesn't have all these manifestations and if patient is complaining only about oral ulcer, which is not been healing like for the past 15 days, you can always suspect a malignancy in these cases. So like as an undergraduate, you put up a clinic, you please make sure like any patient comes to you or walks into you with an oral ulcer which has not been healing for the past say 15 days or 1 month, try to suspect, like could there be a malignant change in that particular ulcer. Especially when you see an ulcer like this on the dorsolateral aspect of the tongue, look out for sharp tooth in these areas. If in case there is a sharp tooth, go for a coronoplasty or enameloplasty, then apply some topical gels. If in case it heals, you ask the patient, like within the next 7 days, if there are some signs of healings, it is well and good. If there are no signs of healing, the patient has to come to you back immediately without wasting time so that you could refer him or her to the higher centers. See, these are a few other slides. Ulceroproliferative lesion on the right buccal mucosa here. Again, see, this is a ulcer on the tongue. You can see some white patches here. You can see this ulcer here. Again, this was associated with sharp tooth. This is an OSMF, although it can't be like so appreciated on a photograph unless and until you clinically feel the patient, like buccal mucosa, how rigid the buccal mucosa is or how the suppleness of the mucosa has been lost. Or if in case you ask the patient to blow his cheeks, he won't be able to fill in air within his oral cavity. And if in case it is unilateral, most of the cases, like sometimes you get unilateral OSMF also. In that case, you can clearly see, एक side में blowing of cheek होता है, एक side में it is not there. So you can obviously diagnose the case, and there is a marble stone-like appearance on the buccal mucosa. See again a case of oral submucous fibrosis here. All the mouth opening is quite better. It is not that bad. And this is a leukoplakia, case of leukoplakia on the left dorsolateral aspect of the tongue. See, there are not yet malignant changes in this. See, in this case, you can obviously, you can go for some topical antioxidants like topical aquazole, vitamin A therapy, and then you can revert the lesion. Along with topical line of treatment, it is in patient's hand. Patient has to quit the habit. So you will have to educate. Like in the worst words, like you terrorize the patient saying that agar tumne tambaku khana nahi choda, obviously you will develop oral cancer. Again, tobacco pouch keratosis, I think all of you have heard about this lesion, tobacco pouch keratosis, which is further undergoing leukoplakic changes. See a vestibular area, but this is a edentulous patient. So in that case, you will have to look in for, any trauma because of the denture edges, flanges also. Again, a leukoplakic lesion on the ventral surface of the tongue, dorsal ventral surface of the tongue here. See these lesions. So these patients have to be kept under follow-up. Like, आप लोग ने देखा, उसको treat किया, fine. You put him on antioxidants, either topical or systemic, but you have to regularly follow up these patients to look for any malignant conversion. Like if in case patient shows signs of healing within the next 15 days, it is well and good. If in case he is not showing any signs of healing, you will have to carry out an incisional biopsy, look for malignant changes or dysplasia, then refer accordingly to either oral surgery, oral surgeons or any oncosurgeon. See, this is also proliferative lesion on the dorsolateral aspect of the tongue. This is a clear-cut malignant lesion here. Again, a malignant lesion in the anterior alveolus. You can see the extraoral manifestations also. There is also proliferative growth, sinus opening, bleeding. This was a very, this patient was in a bad state. It was a female patient. See the extraoral manifestation of oral cancer which has spread extraorally also. Basically involving the alveolus, thereby coming. See again, there's an intraoral lesion here and there an extraoral sinus here. Again an anterior alveolus malignancy. See how it looks like. Then this is purely an tooth-induced traumatic ulcer. Like you diagnose this case as traumatic ulcer. If in case it heals within a week, like it is good. If it doesn't heal, then you will have to always suspect malignancy in this case. Again a case of malignant lesion here. This is at the right retrocommissural area. You can see it is protruding out also. And if you look into the oral cavity, rest of the places, there is smoker's melanosis. Probably this patient is smoker. Then what are the investigations? There are a hell lot of investigations, like lot of investigations for oral cancer in the present era. What is the first or basic investigation you could do at your clinic setup is a vital staining. Although it could be associated with a lot of false positive, false negative results, but even then you can do a vital staining so that you boost up the patient's motive. Like, induce some positive energy in the patient saying that he has to get it treated. Then histopathology, then cytosmia, brush biopsy, then tissue immunofluorescence, monoclonal antibodies, spectral analysis, then CT scan, MRI, and immunohistochemistry. And of late, it is referred to as salivary liquid biopsy, wherein you collect the oral, you collect the saliva, you collect those cells, malignant cells, you look for those DNA mutations. And there's something called as oral microbiome. आज के डेट में इसके ऊपर बहुत रिसर्च हो रहा है, oral microbiome, wherein they are going to, identify what are the most prevalent type of microbial content within the oral cavity of that particular cancerous patient. And vital staining, it is, I'm not going into the detail of it because we are running short of time. Just to show you some pictures, vital staining. If this is the cancerous lesion here on the palate, it was vital stained with toluidine blue, and you can see it has taken up the stains. So vital staining, basically the toluidine blue stains those areas, like any inflammatory lesions also it stains. But this helps the surgeons to look out for the biopsy site. Like if in case, anyways, this is a clear-cut case of malignancy. Like if in case patient presents with a 50-50 kind of a case, like you're not sure whether it's a malignancy or not. So in those cases you stain the lesion, then the surgeon decides probably which area I could take a biopsy, so that you get a better diagnosis in that case. Vital staining. Then there's something called as brush biopsy, wherein you have a brush which actually removes the superficial cells of the epithelium. This is usually done for oral potentially malignant disorders. Like you remove those superficial cells, you look out for DNA mutations or any metaplastic changes or the DNA changes. See here, this is the kind of brush which is available, which goes deep into the oral cavity. It actually scrapes the superficial cells. That is brush biopsy. Again, this is the brush biopsy, wherein this brush is going into the superficial cells. Even the stratum basale also, it reaches up till that level, so you get those cells. Brush biopsy, you can either make a smear out of it, or else you can also go for a like RNA analysis or a miRNA analysis, microRNA analysis also. So there are certain like things wherein you do a brush biopsy. After that you lavage in that particular area, you collect the saliva. Thereafter, the saliva is sedimented, you collect those cells and further investigate it. Then there are certain light-based investigations which is referred to as VisiLight and well scope. VisiLight and well scope. How VisiLight works, so this is just a representation. So it basically differentiates the normal mucosa from the lesional tissue. So this is about VisiLight. Then you have, see it's written there, normal epithelium, it absorbs the VisiLight or the illumination, whereas the abnormal epithelium, it reflects the light. So it appears as pearly white or, ekdam pearl white kind of a lesion. So normal mucosa, it absorbs the light, whereas the abnormal mucosa or the lesional site, it reflects that particular light and it appears ekdam white. So that's how VisiLight works. And there's something called as well scope. Well scope, when again it is a light-based detection system, again it is used for screening. These results are not like that. It could be false positive and false negative also. When I refer to false positive and false positive in the sense, malignancy nahi rehta hai, even then the report would be suggesting that it is a malignancy. False negative in the sense, like malignancy is actually there, but the report shows there is no malignancy. That is false negative. So vital staining, the VisiLight, well scope, these are the ones which are associated with both false positive and false negative results. But these are like major source for community screening camps. Normally, the tissue produces fluorescence and appears as an apple green glow with well scope, whereas in case of lesional tissue, there is loss of fluorescence which is caused by epithelial tissue and underlying stromal disruption. So normally you can see there is apple green birefringence with normal tissue, but this refringence would be absent in case of lesional tissue. So lesional tissue will appear either black or grey. That's how well scope works. Like I told you, blood and saliva analysis, these are the most recent ones to look for miRNA. Then TNM classification, that is T stands for tumor size, N for nodal metastasis, nodal involvement, lymph node involvement, and M for metastasis. Like I think all of you are familiar, T1, tumor size less than 2 cm, T2 more than 2 cm but less than 4 cm, T3 more than 4 cm, and T4 more than 4 cm with invasion of adjacent structures. Then N, there is N0, no nodal involvement, N1, then single ipsilateral, that same side, less than 3 cm in size, N2A, N2B, N2C. N2 mein there is A, B, and C, and N3 there is NA, N3A and N3B. Not going into again in the details. Then M0 and MX. You always mention it as MX if in case you are not sure about metastasis. M0, no metastasis. If in case you are doing a PET scan and you are looking out for metastasis, you give the report as either there is a distant nodal site involvement. If in case you are not doing any PET scan, Like case history लेते हैं, all the undergraduates when you are doing the case history, you are actually asked to write TNM staging for any oral cancer. So whenever we write TNM staging, we put it as MX because we don't know the metastasis in that patient. Then again the staging. Then histopathology, you all know it, grade 1, 2, 3 and 4. Grade 1 is well differentiated, grade 2 moderately well differentiated, grade 3 is poorly differentiated and grade 4 undifferentiated. Treatment, like agar treatment mein bolna chahe, again it will be like very long. So basically these patients are treated either with chemotherapy, radiotherapy or surgical excision. Like there could be a combination of all the three, like you combine chemo, radio and surgical, all the three, or if it all depends on the TNM staging. How bad is the oral cancer staging? Like if in case it is stage 4, obviously, there are some stages wherein only chemotherapy could be done. Surgical therapy would be like more appropriate if the lesion is very small. If in case patient doesn't want to go for chemotherapy or get rid of the tumorous site at once, obviously you would advise surgical. But basically the oncosurgeon decides or the oral surgeon decides what treatment could be the best suited for that particular lesion. So that's all. Thank you.
Thank you once again, ma'am. Before moving to the last lecture of the day, I would request Dr. Anmol ma'am and Dr. Ashish sir to come on stage for the felicitation of the guest speakers. I would request Dr. Shantala ma'am to please come on stage. I would also request Dr. Pavitra Rastogi sir and Dr. Nandlal sir to please come on stage. Along with Dr. R.K. Patil sir. We would like to felicitate Dr. Shantala ma'am. Thank you, ma'am. Then I would like to call upon Dr. Prashansha Sharma, ma'am. Dr. Prashansha, ma'am, please come on stage. Next, I would like to call Dr. Akhil Manocha, sir. Thank you, sir and ma'am. We'll proceed with the last lecture. That is going to be delivered by Dr. Prashansa Sharma ma'am. She has done her BDS and then MDS in Periodontology and Oral Implantology from Maharishi University, and she is a member of Indian Society of Periodontology. She is currently working as Reader, Associate Professor in ITS Dental College, Ghaziabad. She has done fellowship in facial aesthetics and medical cosmetology from PSKOV University, Russia, and fellowship in laser dentistry from WCLI, USA. Along with all this, there is a list of achievements and credits to her name. But for now, I would like to request ma'am to please come on stage and start with the lecture. The topic that ma'am is going to cover today is ridge augmentation.
Forward, backward. And if you want pointer, then this is the pointer. If you want it. मैम कॉलम आएगी ठीक है आपका? हाँ. एक बार चेक कर लीजिए. I guess.
Okay. Good evening, one and all. Myself, Dr. Prashansa. I'm a reader in ITS Dental College, Department of Periodontology. First of all, I would like to thank you, CynoDent, Dr. Anmol, Dr. Ashish for giving me this opportunity. So today, I will be talking about ridge augmentation. So all the PGs out here, I would like to ask you, if a patient comes to you with a missing tooth, what will be the best treatment modality that you are going to offer the patient? Anyone? Dental implants, I will give you options. Dental implants, bridges, or removable partial denture. Dental implants, right? So, what is the smallest size of implant that is available in the market in terms of width? Do you have any idea? Okay. It is 3.2 or 4 mm. So to place the implant and to have the successful implant therapy, we need 1 mm or 1 to 2 mm of the bone around the implant for the survival of the implant, right? So to place a dental implant in a ridge, we need how much of the width? 3 plus 1 all around. So it becomes 5 mm. Am I clear with you people? Are you people understanding? So to place the implant and have a successful therapy of the implant, we need implant, that is, we have 3.2 mm of the implant available, 1 mm buccal, 1 mm lingual, 1 mm mesial, 1 mm distal. So we need at least buccolingually, we need 5 to 6 mm of the ridge width to place the implant. So what happens if the patient comes to you and patient is not having sufficient ridge width, but the patient is again patient is happy to pay you double the amount? What you are going to do? You can go for ridge augmentation in those cases. You can graft the bone graft there, and then after 6 months we can go for implant therapy. So what is ridge augmentation? It is a technique to reconstruct one wall defect that receives blood supply mainly from the recipient bone or little from the above soft tissue. So there are two terms, ridge preservation and ridge augmentation. Preservation is when you are extracting the tooth, at the same time you are placing the bone graft into the socket defect. So we are preserving the ridge, we are reducing the ridge resorption. Ridge augmentation is we are adding something onto the ridge. It can be particulate graft, it can be block graft. Are you people understanding? Do you understand? Okay. Coming to the classification of ridge defect. See what's class 1, class 2, class 3. So class 1 is when you have only vertical. Class 1 is when you have horizontal ridge defect, but you have sufficient vertical height for the implant. We all know that implant is always talked about in 2 dimensions, implant width and implant length, right? Width 3.2, 4 mm, 5 mm, we have different width of the implant, and then we have length also of the implant, 10 mm, 11 mm, 12 mm of the implant. Are you people understanding? Okay. So see what's class 1 is when you have horizontal defect, but you have sufficient vertical height for the implant placement. And see what's class 2 is when you have vertical defect, but you have sufficient horizontal bone width. And Sievert's class 3 is when you have both vertical and horizontal ridge defect. So what are the concepts of ridge defect? Why there is ridge resorption that is happening? Basal bone is quite stable, we all know that. But there is always resorption in the alveolar bone proper. So according to the classification of atrophic mandible by Corwood and Howell, class 1 is pre-extraction site, as you all can see on the screen. Class 2 is post-extraction site. Class 3 is when you have well-rounded ridge. Class 4 is when you have knife edge ridge. Class 5 is well-rounded ridge, but it is deficient in vertical height. And class 6 is depressed ridge. So why there is resorption of the bone after extraction? Because of the concept known as disuse atrophy. Just like appendix, when we are not using any organ of the body, there is atrophy of that organ, right? So supporting alveolar bone, whenever there is extraction of the tooth socket, there is resorption of the supporting alveolar bone. So how much ridge bone is required, as I have already talked about. If you are placing an implant, suppose you are placing implant of 4 mm diameter. This is when you are looking at it from the occlusal level. So 1 to 2 mm of the buccal bone is required on the buccal side and 1 mm is required on the lingual side for the survival of the dental implant. Why we need this 1 to 2 mm of the bone buccally and 1 mm lingually? Why do we need bone? Why are we doing CBCTs, IOPAs before placing implants and checking the bone? ये तो मैंने बता दिया bone चाहिए, but क्यों चाहिए bone? To maintain the proper blood supply. If you are placing implant too close to the natural tooth, implant भी गया, natural tooth भी गया. So is this point clear to you people? Why we need to augment the bone when we don't have sufficient bone? Is it clear, perio PGs? So this is one of the main indication if you want to go for ridge augmentation. Others are loss of alveolar ridge height, width and decreased vestibular depth and denture bearing areas. When there is some neurosensory disturbance because of the reduced ridge height, increased susceptibility to the fracture of atrophic jaw and replacement of necessary supporting bone and progressive loss of denture stability. So there are nth number of procedures for both maxilla and mandible, but mainly I will be talking about block grafting, ridge augmentation. So according to the structure, the block graft, now we are talking about grafts that we are going to place and augment the jaw with. It can be cortical. Cortical bone is more dense bone. It can be cancellous. It is more porous bone, or it can be cortico-cancellous bone. Okay, one question to perio PGs particularly. Which type of block graft you will prefer, cortical, cancellous or cortico-cancellous? Anybody? Cortico-cancellous. Why? Because there will be more supply in cancellous part of the bone, and if you want to stabilize the block graft onto the jaw of the patient, we need cortical side of the graft. According to the source, it can be autograft. You can take it from symphysis, ramus, mandible, but do you think nowadays patient will go for the autograft, bone block grafting? No. The next option is allograft. From where you can procure the allograft? I am taking lecture on it, but from where you will be able to procure it? What is a allograft? Any UGs, what is a allograft? So autograft is, I am taking block graft from my own body and using it in my own body. Allograft is, I am taking block graft from her body and using it in her body. It is taken from the different individual but same species. So xenograft is other species, and alloplast is, so I will be talking about mostly allograft. Why? Because nowadays patient won't be agreeing for autograft, and there are other disadvantages also. Percentage of bone resorption is also there with grafts. So allograft you can order from Tata Memorial Hospital. You can order from there, allografts are available. They have different sizes of the block graft according to the patient need. You can order it from there. So there are two forms of bone grafts. One is particulate graft, that you must be placing in vertical defects, and another is block graft. Can you appreciate the cortical and cancellous part of this block graft? This is which part? And this is? So coming to the ridge augmentation procedures, ridge preservation, regeneration is fresh extraction socket, horizontal, ridge splitting and vertical ridge augmentation. So augmentation techniques can be of two types, GBR or onlay bone block. These two things I am sure you are clear with it. We have particulate graft and we have block graft. So when I am talking about augmentation, if I will place particulate bone graft on the jaw, will it be stabilized there? Or do I need something else there? So whenever you are placing particulate bone graft in a vertical defect, it is a contained type of defect. It is going to contain the particulate bone graft. But if you are talking about ridge augmentation, for example, you can appreciate in this picture, we have placed the membrane there. If you are using particulate bone graft, you need to stabilize the graft with the help of overlying membrane. So bone regeneration in fresh extraction socket. For UGs, I am going to address this defect as inside defect. If you are going for immediate implant placement and we have placed the implant, can you see this extraction socket? We are going to fill this area with the help of, we can place particulate bone graft there. And this I can refer to as outside defect. It was inside, and this is outside defect. While placing the implant, the buccal bone has been exposed, so we need to cover the buccal bone. So we are placing particulate bone graft and covering it with the help of membrane to contain the defect there. So next is block grafting. Can you appreciate the horizontal defect here? This is a block graft. We have stabilized the block graft with the help of titanium screw. So another method is ridge splitting, where with the help of piezo tips, we can split the ridge and we can pack the bone graft there and we can place the dental implants. So these are some of the cases. This is the block graft from the Tata Memorial Hospital. So this is the IOP of the patient. Incisions are given. Circular incision and 2 vertical incision has to be given to appreciate the defect. We have done the decortication. Why decortication is done during ridge augmentation? To induce the blood supply there. And then secure the block graft there with the help of titanium screw. I have used IPRF over the graft and placed PRF membrane. Suturing and pack is given. So this is the same case in which after 6 months implant was placed. So this is another case in which I have CBCT also of the patient. Can you appreciate here? The length is 11.7 and you can hardly see any width. So this is the post-op CBCT of the same patient. 4.8 mm of the bone is available there. So again, the patient, I have measured the defect, reshaped the block graft according to the defect of the patient, incisions, measured it again, stabilize it with the help of titanium screw and sutures are given. So this is how you can stabilize the block graft in such patients. So coming to the conclusion, internal ridge augmentation procedure has become increasingly predictable. The correct selection and application of the available technique and biomaterial are key determinants of implant survival or success rate. Currently, research in the field of advanced bone grafting is directed at overcoming the technical and biologic limitation that continue to challenge the implant dentistry. Thank you everyone. Any questions? Any questions? Okay. Thank you so much.
Thank you, ma'am.
This one.
So that was the end of the guest lectures. We'll shortly begin with the validatory function. I would request the respected dignitaries and all our dear delegates to please wait for 10 minutes. We'll shortly begin after 10 minutes. Thank you. Hello. Hello.
A very good evening to one and all present here. Warm greetings. I, Dr. Rakshita Gupta, and my co-host, Dr. Misbah Kadri, will be your master of ceremony for today.
We welcome our chief guest of today, Professor Dr. R.K. Patil Sir, Dean Faculty of Dental Sciences KGMC, our dignitaries Dr. Nandlal Sir, Dr. Pavitra Rastogi Sir, Dr. Anmol Bagaria Ma'am, and Dr. Ashish Chandra Sir. We requesting our dignitaries to grace the dais. We welcome our dignitaries, eminent speaker, and our dear offline and online delegates to the valedictory function of the 8th World Dental Sciences and Oral Health Conference and International Dentist Convention.
Theme of the conference is recent advancements and trends in dentistry moving towards a bright future, organized by CynoDent International and Indian Society of Dentistry in collaboration with the Department of Periodontology and Implantology, Faculty of Dental Sciences KGMU, and King George Society of Periodontology in Nawabon ka शहर Lucknow. मुस्कुराइए कि आप लखनऊ में हैं.
I hope you all had a great time and enjoyed various delicacies and historic places of Lucknow. Everyone has dreamed of visiting KGMC at least once in life. So ladies and gentlemen, we are very glad to have opportunity to attend this Asia's biggest dental conference in this biggest platform. From 6 September to 9 September, we had pre-conference courses, keynote lectures along with online and offline scientific presentation, award show and cultural activity. And in the evening today, we all are here for the valedictory function now.
Now we would like to invite Dr. Ashish Chandra Sir, Co-Director CynoDent International and Vice President of Indian Society of Dentistry to address the gathering.
A very good evening, everyone. I, Dr. Ashish Chandra, Organizing Secretary of 8th World Dental Sciences and Oral Health Conference. I want to thank you, everyone. I want to thank the dignitaries on the dais, Principal Dr. R.K. Patil Sir, Head of Department Periodontology, Dr. Nandlal Sir, Dr. Pavitra Rastogi Sir, DCI President, Uttar Pradesh, Dr. Anmol Bagaria, Founder and CEO of CynoDent International. I am extremely thankful to all the national and international speakers, those who have made efforts to come here and make this event a grand successful. I want to thank all the delegates. I would also like to thank the team CynoDent for their constant hard efforts and sleepless nights to make this a grand successful event. I also like to thank the Department of Periodontology, all the faculty members, the JRs and SRs for their constant support. We will be coming up with the upcoming events in the same way and the upgraded version of the CynoDent. I assure you all that this learning process will continue forever. Thank you, everyone. Thanks a lot.
Thank you so much, sir. Now we request our respected Professor and President of the UP State Dental Council, Dr. Pavitra Rastogi sir, to address the gathering.
First of all, a very good evening to everyone present here. Dignitaries on the dais, respected Dean Faculty of Dental Sciences, Professor R.K. Patil, my Head of the Department, Professor Dr. Nandlal Sahab, Founder, CynoDent, Dr. Anmol Bagaria, and Vice President, Indian Society of Dentistry, Dr. Ashish Chandra, dignitaries of the dais, my fellow member of Dental Council of UP State, Dr. Sanjeev Srivastav, Head of the Department, and Odontic Sada Patel Institute of Dental and Medical Sciences. Other faculty members from different dental colleges, Mr. and Mrs. Bagaria, Professor Neeta Mishra, Madam, and very, very dear students. As we all know that this is the valedictory section of this long 4-day conclave. We all know that everything which starts, it's going to be at its end. But this is the time to go with a take-home message. And what is the take-home message of this conclave is always, I think it's a positive knowledge, positive memories with positive attitude. Because yes, it's the end of this particular conclave, But learning never stops, because learning is the process of life. Always, every student, every teacher, and every faculty is always a student. So, with a very positive note that we are going, all of you are going, you should go to the very positive memories and positive attitude. And I'm 100% sure your time was in Lucknow, was in KGMU, was a nice time. So, we will meet again in the next year. Thank you so much. Thanks a lot to everyone. And Jai Hind, Jai KGMU.
Thank you so much, sir, for your kind words. Now I would request Head of the Department Periodontology and President King George Society of Periodontology, Professor Dr. Nandlal, sir, to address the gathering.
Good evening to all dignitaries on the dais, Professor R.K. Patil, our Dynamic Dean of Dental Sciences, KGMU Lucknow, Dr. Pavitra Stogi, President, Dental Council of State UP, Dr. Bagadia, Dr. Ashish, and Dr. Neeta, Mr. and Mrs. Bagadia, Dr. Sanjeev, and all delegates who have come from different parts of the country. I have seen that your enthusiastic approach has made this conference a great success, I think. And you have learned a lot of clinical, biological, theoretical knowledge in this conference. I think Lucknow is has become very good city now, and you might have enjoyed also to the Lucknow very nearby. There is Imambada, Bolbulaiya, etc. You might have enjoyed. So it was a very successful conference only because of your positive approach, and we hope and we think that we will meet next time in forthcoming year in the next annual conference. तो मैंने कल कुछ शायरी नहीं सुनाई थी, मैं आज आपको भी कुछ शायरी सुना के ही जाऊंगा। मौका नहीं मिला था मुझे, लोगों ने कहा, लेकिन मैं सुना के जाऊंगा आज कि आंखों में रहा दिल में उतर कर नहीं देखा, आंखों में रहा दिल में उतर कर नहीं देखा, और कश्ती के मुसाफिर ने समंदर नहीं देखा। तो आंखों में रहा दिल में उतर कर नहीं देखा, और कश्ती के मुसाफिर ने समंदर नहीं देखा। और जब से चला था मेरी तो मंजिल पे नज़र थी। दोस्तों कहते हैं कि जब आप कहीं जाते हैं तो आप जो वहाँ का मीटर लगा होता है, जो किलोमीटर का पत्थर लगा होता है, उसको आप देखते रहते हैं कितने किलोमीटर आप आ गए, कितना बचा हुआ है। इसका मतलब शो करता है कि आप जो है थक गए हैं, जल्दी पहुँचना चाहते हैं, आप थक चुके हैं। तो शायर ने इस पर कहा है, को नहीं थका, शायर नहीं कहा थका, उसने कहा कि जब से चला था मेरी तो मंजिल पे नज़र थी, जब से चला था मेरी तो मंजिल पे नज़र थी, और आँखों ने कभी मील का पत्थर नहीं देखा, और कश्ती के मुसाफिर ने समंदर नहीं देखा। अगला है, शायर ने कहा, कितने खूबसूरत फूल लगे हुए हैं, आप देख रहे हैं, फूलों का समा है, इधर उधर हर जगह खूबसूरती है। तो कहते हैं कि शायर ने कहा कि बहुत मेहनत किया, अगर हम आज यहाँ बैठे हुए हैं, जहाँ आज आप बैठे हैं, कल हम ही वहाँ बैठे हुए थे, आज हम यहाँ बैठेंगे, कल हम चले जाएंगे, आप यहाँ बैठेंगे। तो शायर कहता है कि ये फूल मीन्स अचीवमेंट्स, आपके अचीवमेंट्स, ये फूल मुझे कोई विरासत में मिले हैं, ये फूल मुझे कोई विरासत में मिले हैं, तुमने मेरा कांटों भरा बिस्तर नहीं देखा, और कश्ती के मुसाफिर ने समंदर नहीं देखा। और आखिरी शेर बहुत खूबसूरत है, शायर ने कहा कि पत्थर मुझे कहता है मेरा चाहने वाला, पत्थर मुझे कहता है मेरा चाहने वाला, मैं मोम हूं उसने कभी छूकर नहीं देखा, और कश्ती के मुसाफिर ने समंदर नहीं देखा। थैंक यू।
Thank you so much, sir. Now I would like to invite our honorable chief guest, Dean, Faculty of Dental Sciences, KGMU, Professor Dr. R.K. Patil, sir, to address the gathering.
कश्ती के मुसाफिर ने समुंदर तो नहीं देखा, पर 2 दिन में आपने ज्ञान का समुंदर देख लिया है, ये मैं आशा करता हूँ। ज्ञान के समुंदर को आप पूरी तरह डुबोकर भीग कर यहाँ से जाएंगे और अपना जितना नॉलेज आज लिया है वो आप अपने पेशेंट के जो स्माइल है उसके लिए आप इस्तेमाल करोगे, ऐसे मुझे आशा करता हूँ। हमारे प्रोफेसर नंदलाल सर और डॉक्टर पवित्र रस्तोगी, यूपी स्टेट डेंटल काउंसिल के प्रेसिडेंट, साइनोडेंट इंटरनेशनल से डॉक्टर अनमोल बगारिया, डॉक्टर आशीष चंद्रा, वाइस प्रेसिडेंट, इंडियन सोसाइटी ऑफ डेंटिस्ट्री, एंड डॉक्टर नीता मिश्रा, डॉक्टर संजीव, यूपी स्टेट डेंटल काउंसिल के सेक्रेटरी, मिस्टर एंड मिसेस बगारिया, other faculty members and my dear students, I know you are eagerly waiting for the prize distribution ceremony, who will get the best papers. In advance, I congratulate all of you, all the participants, that participation is important, not the prize. And you have participated, come all the way to this KGMU. Hope you like all this, our campus and Lucknow. I hope you have enjoyed the delicious mouth-watering kebabs and flavors of biryani here. And there was brainstorming sessions continuously of well-known, experienced keynote speakers, and hope that knowledge will be helpful for you for general and overall health of your patient, and that will bring the smiles on the faces of your patients. And I will not take much more time. I hope for your safe journey back to your home, and be safe till we meet again. Thank you very much.
Thank you, sir, for your kind words. Now I would like to invite all our dignitaries to kindly felicitate our eminent chief guest, Dr. R.K. Patil, sir. I would request all the dignitaries to kindly stay back for further felicitation. We would now like to invite our academic partners, Subharti Dental College and Hospital, Meerut, Babu Banarsi Das College of Dental Sciences, Lucknow. I would request the faculty members from Babu Banarsi Das College of Dental Sciences to please join. Next, Bharatiya Vidyapeeth Dental College and Hospital, Navi Mumbai. Students can also join in. Career Postgraduate Institute of Dental Sciences and Hospital, Lucknow. Kotiwal Dental College and Research Center, Moradabad. Next is Maharana Pratap Dental College, Maharana Pratap Group of Institutions, Kanpur. Shri Guru Ram Das Institute of Dental Sciences and Research, Amritsar, Punjab. Chandra Dental College and Hospital, Lucknow.
Now we would like to felicitate Dr. Sanjeev Srivastav sir and his team for conducting pre-conference courses on rotary endodontics. We would like to felicitate Chandra Dental College and Hospital, Lucknow.
Now we would like to felicitate Department of Periodontology, King George Medical University.
We would like to felicitate KGMC.
Next, we would like to felicitate CynoDent International and Indian Society of Dentistry, and I would like to call upon stage Mr. and Mrs. Bagaria to receive the honor.
Next, we would like to felicitate Dr. Pavitra Stogi, sir. Now, I would like to invite members of the organizing committee and volunteers of CynoDent International and Indian Society of Dentistry.
First is Dr. Vinayak AM. Dr. Misbah Kadri. Dr. Norman Sheikh. Dr. Vinayak AM. Dr. Misbah Kadri. Dr. Norman Sheikh. Dr. Anam Siddiqui.
Norman.
Dr. Anam Siddiqui. Dr. Ridhi. Dr. Shubham Bharti. Dr. Khushi. Dr. Ridhi.
Dr. Khushi, Dr. Lakshmi Pandey, Dr. Nitin Garg, Dr. Parthvi Mishra, Dr. Priyanka Khinchi, Dr. Shweta Tiwari, Dr. Akshita Gupta, Dr. Akshita Gupta, Dr. Priyanka Khinchi, Dr. Ritika Singh, Dr. Devansh Bhatnagar, Dr. Shakshi,
Dr. Shivendra Kumar. Samriddhi Singh. Dr. Dhruv Singhal. Dr. Evelyn.
Dr. Shimol Goyal, Dr. Spandan Mukherjee, Dr. Palak, Dr. Shubhangi Garg, Dr. Mihika Todankar, Dr. Janvi, Dr. Dhanshri, Dr. Janvi, Dr. Shirayu, Dr. Rohit Singh, Dr. Vinita Kothari, Dr. Chirayu Shetty, Dr. Madhavi Singh, Dr. Samruddhi Patne, Dr. Gargi, Dr. Ravi, Dr. Harshita Shukla,
Dr. Sanchita, Dr. Rashi Khare, Dr. Rupa Gal, Dr. Ishita Singh, Dr. Aryam,
Dr. Aryan Sekho, Dr. Gaurvika, Dr. Gaurvika, Dr. Jasprit Kaur, Dr. Harmanpreet Kaur, Dr. Harjaslin Kaur, Dr. Sandrit Kaur, Dr. Sukhrinjit Singh, Now we would like to invite all the volunteers of Department of Periodontology for felicitation. Dr. Ahadul, Dr. Sheetal Sharma, Dr. Disha Dikshit ma'am, Dr. Masood Kamal, Dr. Vikas Jayant, Dr. Hirkane Prerna, Dr. Mansi Pal, Dr. Jayant Gupta, Dr. Pratik Yadav, Dr. Akshita Sharma, Dr. Shilpi Mangal, Dr. M. Priyadarshini, Dr. Ashutosh Srivastava, Dr. Nikita Verma, Dr. Nazia Khatun, Dr. Shubhi Khatiyar, Dr. Manisha Verma. Dr. Ahad. So finally the wait is over. Now it's time for the result of scientific presentation. First of all, I congratulate all the participants who really worked hard. All the presentations were amazing. We really appreciate your hard work and dedication. And now we are going to announce the results. The result for the poster presentation slot 1. The first prize goes to Dr. Samruddhi Patne, Dr. Spandan Mukherjee. Dr. Samruddhi Patne and Dr. Spandan Mukherjee. And the second prize for slot 1 goes to Dr. Utkarsh Lamba and Shimol Goyal. Another second prize winner, Dr. Sparsh Bharadwaj and Vanshika Gupta. Also, Dr. Ariba and Ariba Usmani. Also, Dr. Divya Mishra. Dr. Sparsh Bharadwaj and Vanshika Gupta. Dr. Ariba and Ariba Usmani. Dr. Shumaila Zia and Ummehani Bano. And the winner of third prize goes to Shivam and Praneet Kumar. We have another winners, Dr. Nazish Aziz and Priya Gupta. Many congratulations to all the slot 1 winner.
For slot 2 poster presentation, the first prize goes to Dr. Ishita Singh and Dr. Rupal Garg. The second prize goes to Akansha Das and Vaibhav. Devansh Dev and Upasna Patel. Dr. Jyotirmay Datta. Dr. Uzma and Dr. Aksa. The third prize goes to Ritu Saxena and Shreya Nath. Dr. Fatima and Dr. Atika. Dr. Kankana Boro and Sudarshana Chaudhary. Dr. Kankana and Dr. Sudarshana Chaudhary. Dr. Vaishali and Dr. Suryakant Verma. For slot 3, first prize goes to Dr. Shraddha Yadav, Dr. Nidhi Kumari, Dr. Shraddha Yadav. Dr. Nidhi Kumari. Dr. Tanish Mittal and Pratna Krishna. Dr. Mansi Sharma and Dr. Shivam.
Second prize goes to Dr. Sayyid Sahiba and Mariam Jahan. Dr. Khushi Arora and Muskan Arora. Third prize goes to Dr. Ria Rastogi, Dr. Archita Mittal, Dr. Anish, Dr. Riddhi Mittal and Karan Dikshit. The result for the slot 4 poster presentation. First prize goes to Dr. Nandita Verma and Dr. Manas Agarwal. Dr. Ayush Dwivedi and Dr. Akshita Madan. Second prize goes to Dr. M. Vishnuvardhan, Dr. Shubhangi Garg and Palak, Dr. Rishita Puri and Princey Anmol. Third prize goes to Dr. Rupali Pandey and Shivani Shekhar, Dr. Bhavya Agarwal and Ayushi Rawat. Now, the winner for the slot 5. First prize goes to Dr. Navin Mittal and Natasha Singh. Dr. Vartika and Dr. Vidhisha. Dr. Archie and Dr. Ayushi Rai. Second prize goes to Dr. Anjali Tiwari and Yashika Arora, Dr. Khushi and Saili, Dr. Ritika and Shalini Gautam, Dr. Shobha Bhandari and Riya Sharda, third prize goes to
Third prize goes to Rishabh Rana and Dr. Piyush Das, Dr. Vanshika Verma and Dr. Hiba.
the winners of slot 6. First prize goes to Dr. Dhruv Singhal and Yash Bharadwaj, Dr. Sara Mehendi and Dr. Ashina. Second prize goes to Dr. Uruz Atar and Dr. Ankita Sen, Dr. Kritika Dubey and Dr. Sapna. Third prize goes to Dr. Jyoti, Dr. Ananya and Abhishek. Now the results of slot 7. First prize goes to Dr. Muskan Gupta and Dr. Ashi Jha, Dr. Manas and Dr. Ananya, Dr. Pranshu Tyagi and Dr. Nikita, second prize goes to Dr. Soumya Singh and Dr. Nandini Gupta. Dr. Yashika Singh and Dr. Tanya Rastogi, Dr. Harjaslin Kaur and Dr. Harmanpreet Kaur, Dr. Kumari Arya and Dr. Aditya Gupta, Third prize goes to Dr. Ujjwal Verma and Dr. Vani Gupta. Dr. Love Kush Verma and Dr. Muskan Khan. Dr. Shantanu Bansal and Dr. Love Verma. Now the results of Slot Ed. First prize goes to Dr. Hari Priya Sinha, Dr. Abhinav Datta. Second prize goes to Dr. Shubhanjali and Akash Gautam. Dr. Verma Malti Sanjeev and Dr. Saurav Chaudhary. Third prize goes to Dr. Saurav Patla and Alka Sharma. Dr. Soumya Mishra and Saurav Kumar Datta. Dr. Shwetang Dwivedi.
For slot 9, the first prize goes to Dr. Devangi Divedi and Dr. Piyush Chaudhary.
Now from sport registration, first prize goes to Dr. Shraddha Yadav, Dr. Devansh Bhatnagar and Dr. Shakshi Varshne. Second prize goes to Dr. Mihika Todankar, Dr. Marya and Parth, Dr. Shivendra and Dr. Samriddhi. Third prize goes to Dr. Anrit Kaur, Dr. Lipika and Dr. Pakshi, Dr. Himanshi Pal, Dr. Evelyn and Dr. Anushka. Many congratulations to all the winners. Now the result for the paper presentation from slot 1. First prize goes to Dr. Urvi. Second prize goes to Dr. Falak. Third prize goes to Dr. Dipali Upadhyay and Dr. Kavita Nitish Garg. Dr. Farhanaz Jamil and Dr. Anish Kumar Mehti. From slot 2, first prize goes to From slot 2, first prize goes to Dr. Ashi Jha and Muskan Gupta. Second prize goes to Dr. Evelyn Raj and Anushka Tomar. Dr. Rashi Khare. Third prize goes to Dr. Gaurish Batra and Akash Latia. Dr. Shivam Sahane and Dr. Mansi Sharma. And Dr. Nidhi.
Dr. Rashi Khare.
From slot 3, first prize goes to Dr. Palak and Dr. Shubhangi Garg. Dr. Spandan Mukherjee. Dr. Ashmit Singh and Akshit Zohri. Second prize goes to Dr. Tanisha Goyal and Paridhi Varshne. Dr. Sugandhi Goswani and Isha Singh. Dr. Harshita Shukla and Dr. Ravi Ghadge. Dr. Parnavi Sopti and third prize goes to Dr. Gaurav Kumar Verma and Dr. Ritika Srivastav and also Dr. Pakshi. From slot 4, first prize goes to Dr. Sanrit Kaur and Gaurvika, Dr. Muskan Prit Kaur and Dr. Parnita Trikha. Second prize goes to Dr. Ananya Gupta and Dr. Rukaiya Sayyed. Dr. Anjali Tyagi and Kanika Tandon. Dr. Ankita Sen and Juveria Ashraf. Dr. Ankita Sen and Dr. Juveria Ashraf. Dr. Riya Sharda and Dr. Shobha Bhandari. Third prize goes to Dr. Riya Sharma and Disha Taylor. Disha Talyar. Dr. Abhishek and Dr. Ananya. From slot 5, first prize goes to Dr. Anshu and Dr. Anshika. And also Dr. Kansha Jain and Dr. Nidhi. Second prize goes to Dr. Vanshika Gupta and Dr. Sparsh Bharadwaj. कौन सा Dr. Neha and Dr. Sanjeev Kumar Rai. Dr. Rashi and Dr. Abhiti Agarwal. Dr. Bhavya and Dr. Himanshu Chaudhary. Third prize goes to Dr. Shivi Mishra.
For slot 6, the first prize goes to Dr. Amrita and Dr. Kaustiki. The second prize, Dr. Shikha and Dr. Garima Agarwal, ma'am. Dr. Garima.
For sport registration, first prize goes to Dr. Samriddhi and Dr. Shivendra. Dr. Shakshi and Dr. Devansh. Dr. Dr. Sumit Tiwari, Dr. Jasprit Kaur, second prize goes to Dr. Shweta Singh, Dr. Sukhinder Kaur Soni, and Dr. Prashansa. Third prize goes to Dr. Eman and Kanishka, Dr. Zeba and Dr. Neelu.
Able Clinic, the first prize goes to Dr. Devansh Bhatnagar, Dr. Sakshi Vashne, Dr. Sanjeev Kumar Rai, Dr. Neha. We have a second winner also for the first position, Dr. Rupal Garg, Dr. Ishita Singh, Dr. Rashi Khare. For poster presentation, slot 7, first prize, Dr. Manas and Dr. Ananya Gupta.
Now it's time for the winners of cultural activity And for that, I would like to invite Dr. Samriddhi and Dr. Shimol to announce the result for cultural activities.
Good evening, everyone. We are moving towards the Culture Program Awards. We are starting with the off-stage events. The results of Rangoli making is, first prize goes to Dr. Paridhi, Dr. Pratna, Dr. Rupali, Dr. Shivani and Dr. Princey. The second prize goes to Dr. Divya Mishra, Dr. Ankita, Dr. Javairia and Dr. Uruz.
Now we are moving forward with the on-stage events. Solo dance, first prize goes to Dr. Himashwari Raghuvanshi and Dr. Riddhi Mittal. Second prize goes to Dr. Samriddhi Singh and Dr. Palak.
Next is solo singing. First prize goes to Dr. Saud Suban, Dr. Gaurish Batra, Dr. Spandan Mukherjee. For the second prize, Dr. R.N. Sekhon, Dr. Vidushi Mishra, Dr. Evelyn Raj. The second prize goes to R.N. Sekhon, Dr. Vidushi Mishra and Dr. Evelyn Raj. For the third prize, Dr. M. Vishnu Varda, Dr. Upasana Patel, Dr. Kamar Raza.
For duet singing, first prize goes to Rupali and Aditya. For group singing, first prize goes to Dr. Devansh Bhatnagar, Dr. Samriddhi Singh, Dr. Gaurish Batra, Dr. Spandan, Dr. Aditya and Dr. Rupali.
For the fashion show, first prize goes to Team Subharti. Agrima, Gauri, Evelyn, Shubhangi, Palak, Shimol, Spandan, Ayush, Akshita, Paridhi and Tanisha.
The second prize goes to Syed Saiba. The next is Poem and Shairi. First prize goes to Dr. Ankita Sen, Dr. Shimol Goyal. For Poet and Shairi, the first prize goes to Dr. Shimol Goyal and Dr. Ankita Sen. The second prize goes to Dr. Abu Bakar and Dr. Rashi Khare.
Now we would like to invite Dr. Ahad on the stage. Thank you, sir and ma'am. Now I would like to invite my role model and inspiration. She is none other than our organizing chairperson and president of Indian Society of Dentistry and Indian Society of Dentistry and CynoDent International, Dr. Anmol Bagaria ma'am, to deliver the vote of thanks.
I would request all the dignitaries to kindly sit on the dais.
Good evening, everyone. Once again, I would welcome you to the valedictory function. And I would congratulate all the winners for the scientific event and cultural event. I would extend my heartfelt gratitude to all the dignitaries on the dais and off the dais and all our dear delegates. I would extend my sincere thanks to Dean Faculty of Dental Sciences, Dr. R.K. Patil sir, for giving us his valuable time. A special thanks to Head of the Department and also President of King George's Society of Periodontology, Professor Dr. Nandlal sir, for his constant support. I would thank Dr. Pavitra Rastogi sir for his blessings always. I would thank Dr. Ashish for his tremendous support in making this event a grand success. I would like to thank our patrons, advisory board members, head of all the departments of Faculty of Dental Sciences, King George's Medical University, Lucknow, entire organizing committee and all our academic partners. I would also thank the speakers who have taken out time from their busy schedules and made it here. A big thanks to all my dear delegates and students who have trusted us and joined us today. Thanks to all the speakers, clinicians, academicians who have joined us to enhance their knowledge and skills. Sorry if I've missed any name. I'm highly thankful to each one of you. Thank you once again for being with us and giving us your valuable time. Thank you.
Thank you, ma'am, for your kind words. Every ending is the start of a new beginning, and we will meet you very soon in a new conference at a new place. We hope this has been a great learning experience for you all. Thank you. Now I would request everybody to rise at your seat for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I would request one volunteer from all our academic partners to kindly meet at the backstage. Thank you.